still 4 minutes to go. I want to kindly remind you that we have headsets for simultaneous translation right outside that door. It's in French, English, and Spanish in case you want to get one of those. In 4 minutes, we're starting. Thank you. Hello, hola, good morning, and welcome to Barcelona. My name is Luis Quevedo, and I'm honored to be your Master of Ceremony for the world's first Global Forum on Childhood Pneumonia. For the very first time, government ministers, the United Nations, leading international health agencies, and also corporations, civil society leaders, youth activists from more than 40 countries are meeting to discuss how to win the fight against the number one killer of infectious killer of children, pneumonia. Thank you all for traveling to Barcelona. I've been told there's a bus running a few minutes late, but we'll get to that. And thank you to all of you watching through our live stream from all over the world. You are here in Barcelona because of your commitment to the world's most vulnerable children. And thank you as well to Cosmocaixa, to La Caixa Foundation, and to IS Global for hosting us for the next few days. This is an astounding venue. We are really grateful for your hospitality. Let's go to the agenda. The agenda for the next few days is, shall we say, ambitious. But so it must be, because the life of 9 million children are at stake if we don't succeed in the fight against pneumonia over the next decade. Before we begin with the program properly, I'd like to share with you a few remarks. First, we need you. We want you in this conference. We need you to participate, and we have enabled a technological way of doing it. As you can see, in the other side of the stage, using that QR code, you can access a web app specific for this global forum. There, you can register. It is very important because using that app, you'll be able to ask questions to the panelists. Please do it now. If you have any question, you can reach out to our volunteers. They're wearing a badge and smiling all the time. You can find them in both doors. We want you to post on social media, wherever the channel might be. You can Instagram, you can tweet, you can TikTok, if that's your thing. Please go ahead. You can use two hashtags we've prepared for this occasion, the # Stop Pneumonia and the Fighting for Breath. That goes also and specifically for our live stream audience, please. And finally, please remember to wear your name badges at all time and to be timely so that we can start our sessions on time. Let's start with the program. Now, to welcome you to the Global Forum, we have some very special guests from the United Nations, UNICEF, the World Health Organization, Gavi, and Save the Children. Please join me in welcoming to the stage the Under-Secretary General and Special Advisor on Africa to the United Nations Secretary General, the Honorable Jens Gawanas. Welcome. Henrietta Fore, Executive Director of UNICEF. Anshu Banerjee, on behalf of Dr. Tedros, Director General of the World Health Organization. Seth Berkley, CEO of Gavi, the Vaccine Alliance. And Kevin Watkins, CEO of Save the Children UK. We'll start with Ms. Gawanas, please.
Excellencies, colleagues and friends, it's indeed a great pleasure for me to be here at this Global Forum on Childhood Pneumonia. This is a timely gathering of key partners asking a crucial question. What more can be done to reduce the number of childhood pneumonia infections and deaths worldwide? It's a complex challenge, and before going further, it is important that I acknowledge and recognize the fact that great progress has been made in reducing the number of deaths due to increased efforts by many of you in this room. These are the efforts by representatives of governments, civil society, multilateral institutions such as Gavi, individuals, and the United Nations family. But within this context of celebrating success, it is important to reflect on why progress against childhood pneumonia has been uneven. And so we will be talking in the next couple of days, especially on these issues. So we all know that last year we had the SDG summit, where again there was a call made for a decade of action to deliver the SDGs by 2030. Decisive action in reducing the cases of childhood pneumonia and deaths would be an important way to contribute to the decade of action on the SDGs. Similarly, Agenda 2063 of the African Union, which informed, in fact, the 2030 agenda, places emphasis on human lives, and it is my belief that it includes child health. In 2009, the African Union heads of state and government adopted the campaign on accelerated reduction of maternal mortality karma. And in 2010, during their Kampala summit on the theme maternal and child health, they made reducing child mortality part of the karma. But let me address 4 factors very, very briefly. The first is the issue of access to vaccines to reduce the risk of children developing pneumonia. Second, the need for greater access to effective and child-friendly diagnostic tools and antibiotics. Third, the complex issue of health system strengthening and how central this is to even progress on childhood pneumonia. Fourth, and finally, the importance of political will and whole of government response to address some of the drivers of pneumonia, especially air quality and good nutrition. So let me start with the issue of vaccinations as an effective tool to prevent childhood pneumonia. The good news is that we have an effective vaccine which has been successfully deployed in some of the most resource-constrained settings around the world. Thanks mainly to funding from Gavi and national governments, approximately 185 million children have been vaccinated. This is something to celebrate. So as we are preparing for the replenishment of Gavi, it is critical for us to remember that a well-resourced and effective Gavi is absolutely critical. Second factor that I wish to address is that we face in the fight, that it is ensuring access to easy-to-use diagnostics, oxygen treatments, and child-friendly antibiotics. In the case of the latter, it is important for African governments to continue to invest both in research and development and local pharmaceutical production of quality, safe, and effective antibiotics. I was fortunate to be serving as the AU Commissioner for Social Affairs at the African Union when the Pharmaceutical Manufacturing Plan for Africa was endorsed by African heads of state in 2007. Now it's time for African governments to make the necessary investments in support of antibiotics and other essential medicines. The African Continental Free Trade Area, in fact, provides an important opportunity to achieve economies of scale needed to make local pharmaceutical production economically viable. Let me turn to the final factor in my remarks, which is political will and role of government approaches. All the governments represented here committed to delivering the SDGs in the same way as they did with the MDGs. I believe that this time it is possible because of the involvement of multiple actors in delivering the SDGs, and in Africa to complementarity between the 2030 and 2063 agendas. Moreover, in 2016, African governments committed to the revised Africa Health Strategy, which highlights the importance of multi-sectoral responses to health challenges and threats and recognize health as a human right and the centrality of primary health care. As we also know, pneumonia is foiled by inadequate nutrition and poor air quality. AU member states adopted a revised Africa Regional Nutrition Strategy 2015-2025. They also participated in the Climate Action Summit held during the UN General Assembly. It is critically important that we pay attention to the social determinants of health, with ministries of health taking the lead at the national level in connecting the dots with the ministries of environment, agriculture, social development, women and children, water and sanitation, infrastructure, planning and finance. In conclusion, as the UN Special Advisor on Africa, that is home to 8 of the 10 most affected countries, please be assured of my commitment to raising the profile of this important health challenge in the context of Karma, Agenda 2063, and Agenda 2030. We must continue to step up our efforts to reach those left furthest behind and help to shine a light on these neglected diseases that are preventable, yet causing so much deaths amongst our children. Together, ending preventable childhood deaths by 2030 is not only possible, but achievable. I thank you.
Thank you. And now let's hear from Henrietta Fleur from the UNICEF.
So good morning, everyone. 39 seconds. Every 39 seconds, a child dies of pneumonia. Out of every 5 child deaths, pneumonia causes 1. That's more than malaria, it's more than HIV, it's more than measles, it's more than tetanus combined. Last year alone, pneumonia claimed the lives of more than 800,000 children under 5 years old. Of these, an alarming 153,000 were newborns under the age of 28 days, unable to breathe just weeks after taking their first breath. It's a cruel injustice and a tragedy because we know what works. We know how to prevent these deaths. Breastfeeding, good nutrition and vaccines, so children grow up strong and healthy from the start. A healthcare system that provides quality services and health workers trained to spot and to treat pneumonia. Eliminating risk factors like air pollution and unsafe water, antibiotics and oxygen. We know, but still we fail. So why is this? We fail because of poverty, when parents cannot afford to take their children to a clinic. Children from the poorest households are nearly twice as likely to die from a pneumonia than children from wealthy ones. We fail because children showing signs of pneumonia are not accurately diagnosed by parents or medical providers. We fail because children cannot get the basic services that they need from their local clinics, or because treatment is too expensive. But most of all, we fail because we have, so far, lacked the global commitment to address this situation, to find new ways to scale up proven solutions and commodities and services that we all know save lives. This conference is a critical step in building a new global consensus to take action on pneumonia and to prevent nearly 9 million more children from suffering from that same fate in the next decade. To the governments in this room, you have the power to change the course of history. Agencies like UNICEF are standing behind you and are ready to support you, to invest in healthcare workers, making sure that they are well trained and supported and have the vaccines and the antibiotics that they need, that they have clean and safe environments in which to work, and that they have the training to carry out this vital task. To ensure access to life-saving treatments by scaling up critical commodities, for example, low-cost, dispersible amoxicillin DT as a first line of treatment. One full treatment for pneumonia costs less than 50 cents per child. to scale up innovative weapons in our fight against pneumonia, weapons like inexpensive pulse oximeters that can instantly measure blood oxygen levels, and systems that critically ill children can get oxygen that they need to breathe. To help shape the right environment for children, clean water and nutritious foods and clean air to breathe. To heed the call of the Global Vaccine Initiative, Gavi, next month to fund and scale up pneumonia-protecting vaccines, particularly in humanitarian emergencies. And most of all, to build and deliver community-based, accountable primary healthcare services in all contexts, humanitarian and development alike, in which children and family can get all the services that they need in one place. Every 39 seconds, pneumonia shatters a family. We can prevent this. All of us, governments and agencies like UNICEF, businesses and researchers and innovators and communities. This meeting is a start, but the true depth of our commitment will reveal itself in the months and in the years to come. Millions of lives, of young lives, hang in the balance. We know what to do. Let's carry forward the momentum that will be built here in Barcelona to back our workplaces, to our boardrooms, to our communities that depend on us, and to our halls of power. Let's recommit to ending these tragedies for children fighting for breath, for families fighting for their children, and for all of us fighting for a healthier future. Thank you. I'm inviting Anshu Banerjee from WHO to join me, and we have a joint statement. Dr. Peter Salama was a brilliant, accomplished, and inspiring health leader. He focused on the needs of women and children globally, particularly in war-torn contexts and situations where health services have collapsed. He was a role model for many and loved by those who had the chance to work with him. Pete's family background prepared him well for a career in global health and in humanitarian action. His mother was a refugee from Palestine, and his father an accountant from Egypt. They migrated to Australia, where Pete was born in the 1960s. From a young age, he developed a keen sense of social justice and the needs of the most vulnerable. Pete's broad experience in both UNICEF and WHO, from Afghanistan after the Taliban rule to war-torn Syria and the West Africa Ebola epidemic, made him a highly effective scientist, policymaker, leader, and convener. He drove himself relentlessly, advancing issues in a highly principled and persuasive way. And his leadership, he was generous, he was selfless, and he was gentle, and he was caring.
Above all else, Pete was a committed and beloved husband and father. Family life for Pete centered on his powerful partnership with Annelies Borrell, his wife and the mother of their 3 boys, Luca, Kai, and Matisse. The loss we feel in the global health community pales in comparison to theirs. He did his best to minimize travel and would start work early in order to be at home in time for dinner. Pete encouraged his sons to study in ways that ask questions, explore possibilities, and reveal new horizons. With them, he shared a deep love of sports, cricket, rugby, skiing, squash, surfing, and tennis, among others. Not only was he pretty handy with the tennis or squash racket, Pete was an insightful sport analyst and was always ready to share his views on the latest success or failure of Australian sports teams. Pete has left us suddenly and prematurely. His humanity and his extraordinary achievements have brought real benefits to many. There could have been so much more. All of us who knew Pete are profoundly sad. Yet the richness of his life and his unconditional love for humanity gives us all cause to be grateful. Amidst our grief, we celebrate the contribution of a truly remarkable person. The best thing we can do to honor his memory and legacy is to continue his work with the same commitment, humility, and integrity. As Pete would say, there is no choice. I'm pleased to read the following message on behalf of Dr. Tedros Adhanom Ghebreyesus. My sister Henrietta, dear colleagues and friends, I'm sorry I can't be with you today. I had planned to record a video message, but given the urgency of the current coronavirus outbreak, I needed to travel to China to meet senior government leaders to determine how WHO can support China and other countries to contain the outbreak as soon as possible. Coronavirus has put pneumonia in the headlines recently, but all too often, pneumonia doesn't get the attention it deserves. Pneumonia remains the leading cause of mortality in children under 5, accounting for more than 800,000 deaths in 2018. Most pneumonia deaths amongst children occur in low and middle-income countries, particularly in poor and remote areas. In the last 2 decades, pneumonia-related mortality has been reduced by more than half, thanks to improvements in vaccination coverage. We are making progress, but much more has to be done. Over 2,000 children under 5 will lose their lives to pneumonia today. We can end these preventable deaths by reducing household air pollution and ambient particulate matter pollution, by expanding diagnosis and access to antibiotics, and by implementing multi-sectoral interventions to address wasting. We need a concerted effort to ensure every child can survive and thrive, and when needed, can have access to preventive services, health promotion activities, and treatment. So the question is, how do we take forward these effective interventions to move us closer to ending preventable childhood pneumonia deaths by 2030? I believe we need at least 3 key ingredients. First, we need to strengthen health systems so that every child, everywhere, at risk of pneumonia, can access the services they need to prevent, diagnose, and treat pneumonia without suffering financial hardship. That's why universal health coverage based on strong primary health care is so important. This requires renewed political commitment to primary health care from governments and stakeholders, including harnessing the power of communities to improve their health. Second, we need more resources, and we need to use them better. Some of these resources must be mobilized domestically, but as we know, we cannot rely solely on domestic resources, especially for many of the highest burden countries that need support. That's why Gavi and the GFF remain vital for mobilizing external resources for immunization and support of health systems. Third, we need increased investment in research and development to deliver point-of-care diagnostic tests, new vaccines to prevent viral pneumonia, and new affordable antibacterial and antiviral medicines. Finally, we must hold ourselves accountable for results. Together, we must accelerate progress in ending preventable pneumonia deaths, especially in the most affected countries. We must rise to the challenge of strengthening primary health care to achieve universal health coverage. We must rise to the challenge of mobilizing resources, and we must rise to the challenge of investing in research and development. Thank you all for your commitment to preventing the needless suffering and death caused by childhood pneumonia. I wish you a very productive conference. Thank you.
Thank you. And now let's hear from Seth Berkley. He is CEO of Gavi, the Vaccine Alliance.
honorable ministers and friends. First of all, I want to acknowledge also my feelings of grief. I was tearing up as you were talking about Pete Salama, who is not only a friend, but was on the Gavi board, and I was emailing with him the day that he passed. And so I thought the beautiful remarks were appropriate, and of course, given his commitment to this particular topic, it was really special. I also want to say, of course, that this is a historic moment, and you've already heard that from a number of the speakers, because although we talk about the problems behind pneumonia, we don't necessarily discuss the full integrated package of things that are necessary to move forward. So although, of course, I will come back to the vaccine equation here, you've already heard about the importance of treatment for pneumonia, diagnosis for pneumonia, innovation, new tools, trying to get science behind it. All of that is going to be critical to being able to conquer this incredibly important problem. So if I jump to the Gavi side of things, our goal has been to try to bring new vaccines to the places that need them. And we usually focus, when we think about pneumonia, about the pneumococcal vaccine, and I'll come back to that because that obviously is a very important vaccine. But we started well before that with other vaccines that are important. The fact that we have vaccines against Haemophilus influenza type B and that they're universally available in low-income countries. The fact that we have vaccines against pertussis and diphtheria are obviously also important. Measles, a very important cause for pneumonia. Those vaccines universally available, although we see a backsliding in measles across the world that we also have to deal with. And there are new vaccines coming. We were disappointed in this last year with RSV vaccine, which would have been a new vaccine that we could have used in pregnant women or maybe in infants. The trial of that vaccine did not show the efficacy we had hoped, but there are other vaccines coming that can make a difference. And we now have TB vaccine, a new vaccine for TB that is also showing promise. And it was just announced this week that the Gates Foundation will be driving that vaccine forward. So I think, in a sense, we're in a nice place in terms of the prevention side of things. And that is really critical because at the end of the day, we have to have treatment, we have to have diagnosis, but of course, where we can prevent, that is always better than going ahead and dealing with treatment-related issues. If I move to the pneumococcal vaccine, that vaccine has now moved to a coverage rate of 48%. It's been rolled out in 60 of the Gavi 68 countries, covering 80% of the countries. Of course, there's a lag as coverage rates go up. The good news on that front is there is a new manufacturer that has just entered the space, the Serum Institute of India. We should see some adjustment in prices because of that. And I think we need to make sure that that vaccine gets out to everybody who needs it because it can make a dramatic difference. One other point that's important on the prevention side is the antimicrobial resistant component of this. Because one of the challenges, of course, is if you can't diagnose, if you don't prevent, you have to treat, and we don't necessarily treat with the right agents, and of course we also treat viral infections with antibiotics when we don't have good diagnosis. And so the fact of having people vaccinated, of staying healthy, reduces dramatically the numbers of use of antibiotics. We think that in the years 2000 to 2030, more than 20 million cases of AMR-related disease were reduced, and that's about 500 million or half a billion cases of antibiotic use averted, which is really important. So I think there is a whole agenda around the vaccine space. As you've heard from a number of my colleagues, this is an important year for Gavi. We had a 20th anniversary celebration at the World Economic Forum last week, where we looked at what has been accomplished in the past, but most importantly, what we need to do in the future. And our focus is going to to move towards zero-dose children and making sure that those zero-dose children are included in the routine system. There's 10.4 million children that receive no vaccines. If we can extend the system to them, then we can get them the vaccines and the other parts of the health system that are going to be critical. So I thank you all for your attention and for the important work that we will do here together to move the whole pneumonia agenda forward. Thank you.
Thank you. And now I invite to the podium Kevin Watkins. He is CEO of Save the Children UK.
Thank you. Good morning, everybody. I'm hugely thrilled to be here in this beautiful building, so a big thank you to Lakasha for hosting us and to all of you for being here. We're meeting against the backdrop of a pneumonia-related emergency that is making a lot of headlines globally. And it's quite right that it should be making headlines and that governments are responding with great urgency. And I'm talking, of course, about the response to coronavirus. There is another emergency that is being played out every single day, well away from the headlines. And there's the picture on the screen here is of a picture of a little boy whose name is Nio. And his mother, whose name is Joy. And I met them about 2 months ago in Jigawa in northwest Nigeria at a small health center. And Nio had severe pneumonia. And his story, as his mother explained it to me, was a story that I think could be told many thousands of times around the world today. So he had been misdiagnosed 3 times. His mother had delayed taking him to a health center because the health center was a long way from her home, and she was worried about being unable to afford the fees. And at the health center that we met her, there was no amoxicillin. Nio was really struggling to breathe, and there was no medical oxygen. And again, actually, he'd been inaccurately diagnosed. Now, this is a story with a happy ending because we were able to get him referred to a center where he was properly treated. But 800,000 times every year, as Henrietta said, once every 39 seconds, there's a story that doesn't have a happy ending. And these are the children who lose their lives as a result of pneumonia. Now, I think all of us, we're going to hear a lot over the next few days about statistics and some of the very complex health challenges that have to be addressed. But I think anyone who is a parent will understand the anguish of that mother who has a child who is struggling to breathe, who is struggling for oxygen, the most basic of all commodities that sustain life. And we made a commitment as an international community 5 years ago that there would be no preventable child deaths by 2030. That is a promise to the world's children. We have a decade to act on that promise and to deliver on that pledge. And if we carry on as we are, it'll be a broken promise. We know that these lives can be saved, but we're heading for a broken promise. And this conference is actually about holding to the promise that we made to children. And as all of the speakers have said, we know what the interventions are. We know that if we provide a full replenishment, an ambitious replenishment of Gavi, we can prevent so many of these cases, children like Nio, ending up in the condition that they were in on the day that I met them. We know that if we have the health workers and the facilities in place that can do the accurate diagnosis, that just 50 cents worth of antibiotics will save a life. And we know that with basic referral systems, getting children access to pulse oximeters and to oxygen, we can dramatically reduce the death rate, even in the most severe cases of pneumonia. These are things that we can achieve. And as I think about this conference, I think about this conference not as the end line, not as a great event in a beautiful city, in a great building where lots of interesting people will come together, but as the start of a partnership that can really make a difference for these children. in this city, there is a great football team. Some of you may know that, Barcelona. What makes it a great football team is that when you put all the parts together, all the players together, they're bigger than they are as individual players. They are bigger than the sum of their parts. Now, on this platform, we have great organizations who are delivering fantastic things. My own organization, Save the Children, the UN agencies, UNICEF, the World Health Organization, and Gavi. All of us separately are doing great things. If we can be like Barcelona Football Club, come together. I mean, we'd all have to play for Barcelona Football Club, but I think that may not happen for many of us. But if we can all come together and make this conference the start of a partnership that will save these lives and hold to the promise that we made to the world's children 5 years ago, that would be a great accomplishment and something that we could be proud of. Thank you very much.
Thank you all. And before our speakers leave the stage, I'd like you all and ask you to watch the screens, because I'd like you to learn the story of a young protagonist who, much like Naya's, survived pneumonia. Her name is Niruta. She's from Nepal, and she, Naya, and children like them are the reason we are here. Let's hear from her.
अनि ज्वरो आएको मम्मी मलाई त ज्वरो आयो भने पढेर स्कुल गएर आएपछि
फोन गरेपछि अनि के हो भनेर चाहिँ अब उदिनैखेरि म आउनु चाहिँ
ल्याएपछि झन् छैन अनि छोरी निरुता त बिहोसमै लगेको हो मैले त
झाँक्री लगाए नदेखेपछि अनि हाम्रो जबरजस्तीले नै अनि यहाँ झाँक्रीको मात्रै भर नगर्ने अब हस्पिटल लाने भनेर एम्बुलेन्स बोलाएँ
म चाहिँ अब रुने अब मेरो छोरी के पो हुने हो
अनि त्यहाँको चाहिँ मेन डाक्टरलाई बोलाएर गर्दा कुन चाहिँ डाक्टरले यसो गरेर आज रात पनि काट्नलाई गाह्रो पर्छ यहाँ हुँदैन उपचार अनि सबै त्यो पाटन हस्पिटलमा पैसा भन्ने कुरो चाहिँ मसँग त्यतिखेर जम्मा 6000 रुपियाँ पैसा बाँकी रहेछ खल्तीमा धेरै मान्छेहरू चाहिँ भने कि अब भेन्टिलेसनमा हाले मान्छे 1000 मा 100 मात्रै हुन्छ अनि त्यही माथि चाहिँ 4 जना त्यही रुमबाट 4 जना चाहिँ निकाले बेच्नु भन्नाले चाहिँ यहाँ बेचबिखन गरे भने चाहिँ खाटहरू चाहिँ खाट पलङहरू थियो कुर्सी टेबलहरू त्योहरू चाहिँ सब हल बेचे
त्यही मात्र हो बेचेको चाहिँ गोरु मात्रै अर्थको चाहिँ अब छैन पनि
लाख भन्दाखेरि माथि खर्च गर्छ सबैभन्दा डर लाग्ने भन्ने विषय नै अब डर सबै चिजमा डरै डर के छ कस्तो छ यो भन्दा नि ठिकै भयो हुन्छ कि हुँदैन कि तँलाई कस्तो के भइरहेछ तेरो लागि चाहिँ म जे गर्न पनि म जति जे गर्न पनि म तयार छु तँलाई सुधार भयो कि भएन हुन्छ कि हुँदैन त्यस्तै भनेर चाहिँ सोधबुझहरू गरिन्थ्यो बोल्न पायो कहाँ कस्तो भइरहेछ सोध्न पाइन्थ्यो
नमस्ते मेरो नाम निरुता बिका हो म अहिले 13 वर्षको भएँ मेरो घर नेपालको मकवानपुर जिल्लामा पर्छ मलाई 11 वर्षको हुँदा न्युमोनिया भएको थियो हस्पिटलमा भर्ना गरेर राख्नु परेको थियो र मलाई अहिले राम्रो निको भइसकेको छ म अहिले स्कुल पनि जाँदैछु मलाई निको पार्ने क्रममा मेरो आमा बुवाले धेरै मेहनतका साथै धेरै खर्च पनि गर्नुभयो त्यो समय हाम्रो परिवारको लागि धेरै कठिनको समय थियो किनकि हाम्रो परिवार धेरै गरिब छ म अबदेखि न्युमोनियाबाट अरूलाई बचाउने अभियानको अभियन्ता बन्न चाहन्छु र न्युमोनिया सम्बन्धी जनचेतना जगाउन निरन्तर लाग्नेछु यदि मैले राम्रो शिक्षा हासिल गर्न पाएँ भने म एक सफल नर्स बन्न चाहन्छु र म जस्ता समस्यामा परेकाहरूलाई बचाउन र उपचार गर्न सधैँ लाग्नेछु धन्यवाद
Thank you, and thank you all. And we now begin the first session of this global forum. This is the path to 2030, which is, of course, the deadline for the Sustainable Development Goals. How's the world gonna end preventable child deaths from pneumonia in just 10 years? Well, let's find out. It is my pleasure to introduce Stefan Peterson. He's Chief of Health at UNICEF.
Thank you very much. I was remarking with friends that I waited 20 years for this conference because that's how long I've been at it, beating pneumonia. Can you hear me? Good. Can I have my first slide, please? This is Niruta. We just heard her story. She's a pneumonia survivor. In fact, when I was a kid, I also had a pneumonia, and I'm a pneumonia survivor. Unlike Niruta's family, my parents in Sweden, they had a car. They could drive me to the nurse who could take me to the doctor. And I got the antibiotics, and we had health insurance, and they came back with the car, and we were okay, and no one was impoverished. So I'm a pneumonia survivor. How many pneumonia survivors here? There's many of us here, if you look around. It can be cured. Pneumonia can be made history. And that's what we're here to commit to. Let's get that nerve going. Let's commit to making pneumonia history. Now, I wanted to, with the help of Tyler up here and some Gapminder moving graphs, show us the world's progress actually in 30 high-burden countries in controlling pneumonia since the year 2000 up to where we are now. And you see we have pneumonia, diarrhea, malaria, measles, meningitis, HIV, and measles down there. And which one is on top always? It's big and it's green and it's scary. It's pneumonia. It is reducing, but it's reducing slower than the other ones, where we're actually investing a lot more money. It is still the biggest killer of children. 20% of under 5 deaths still due to pneumonia, and we're not on track to meet the targets as we heard in the last session. And you see the size here. Now, let's then look at 30 high-burden countries that we've singled out. Let's look at the history of 30 high-burden countries over the same period. And we can see it's a crowded field here. Generally, the trend is going down, but not sufficiently fast, and it's actually highly variable. Some countries are doing better, and others have some obstacles on their path, don't they? Now, we wanted to single out in this crowded field here 2 countries, neighboring countries, that started out next to each other, and then we'll see how it plays out for them over these 2 decades. Let's roll the time. And what we can see here is that there is difference in context. There is difference in policies. There is differences in many ways that actually makes history play out differently, in this case for pneumonia. So that means that we can actually affect the course of things. There's a reason for us being here. And there's a reason for us not just waiting for time or economic progress to fix things, but actually to engage ourselves in improving context and policies and delivery. And that's the hopeful message around here. And that's why it's great to be in this business. So if we now switch back to PowerPoint, I wanted to show you a few more slides here, going beyond Niruta. So I wanted to ask and actually illustrate a little bit, as we've already discussed. Who dies from pneumonia? Is it anyone? Well, as you heard, Niruta came very close to dying, and I didn't. And chances are there is inequity. Poverty is at play here. If you have poor parents, if you live in a rural, remote place, if you happen to be displaced, if you're living in a humanitarian setting, or, God forbid, if you're an urban poor, you're almost twice as likely to die from a childhood disease, including pneumonia, before the age of 5. That's the same story as usual, and it plays out for pneumonia, and pneumonia is a disease of the poor in addition to being a neglected disease. Isn't it ironical that the biggest killer of children in the world is a neglected disease, effectively? Now, why do children get pneumonia? Well, poverty is of course at one level, but what's at the next level? Let's look at some risk factors. The nutrition and the malnutrition are the biggest contributors to the multiple deprivations and the problems that will end up giving you pneumonia. 55% of pneumonia can be linked to wasting, 15% to stunting, and wait for it, prematurity, low birth weight, 16%, and here we go, pollution. It used to be indoor air pollution. You cook with dirty cook stoves and you get pneumonia inside the house. Increasingly, it's outdoor air pollution, as we know, in more and more cities, in more and more places around the world. So you may say that this adds to more than 100%. It's true. You can have more than one risk factor. It's multiple deprivations, and that's what makes kids in these countries, high-burden countries, 3 times more likely to get pneumonia than I was as a well-nourished kid in Sweden at the time. So there's a difference in the risk of getting pneumonia. There's also a risk in actually in the kind of healthcare that you have as well. We already heard about the preventive care from Seth here. Do you have access to immunization? Is it close enough? Is it user-friendly? Are the vaccines okay? We hear a lot about vaccine hesitancy these days, but actually when we look at it as UNICEF, we discover a lot of that hesitancy is actually a failure on our part as a health system to be user-friendly, to be close to people, to be open when people have a time to go, and to provide good and courteous services. So it falls back on ourselves. And the same applies when your kid is sick. How far away is that closest health worker? Is there a community health worker in their village? Is the private drug shop there knowing what it's doing? Is the health center nurse there? Is she able to diagnose? Does she have the diagnostic equipment? And then, as we heard from Kevin's example, is the amoxicillin out of stock or is it there? Disappointingly often the amoxicillin is out of stock. And I spent a lot of energy digging into this. And unfortunately, I must say, between national governments and donors and how all this circus is set up, it is designed to be out of stock. And that's one of the things we must overcome in this meeting. We must close that commodity gap, and we'll return to how in a minute. It's also about the quality of referral care, as we heard, because once you reach that hospital, having sold your oxen and whatever you've done, borrowed everything, is there oxygen there? Disappointingly often, there is no oxygen. And I have, in my previous life, seen so many examples of kids and families who, just like Niruta's families, mortgage everything, made it to the hospital, only for the child to die there for lack of quality services, for lack of commodities, for lack of things like oxygen. So healthcare, it's access, but it's also quality of the care. But then there's something else, empowered people and communities. My advice to an unborn child is always, pick your parents well. Make sure they are educated, make sure they live in an empowered community that can demand services, right? Many children don't heed my advice. They don't get it. They are born in impoverished communities with unempowered parents, and they don't have a way to exact accountability and demand their rights. So, putting this together, the world committed to something called primary health care, 1978. We recommitted in Astana the other year again to primary health care. And primary health care has 3 legs. It has the integrated health services that we talked about and we will talk about. It has the multi-sectoral policy and action, and it has the empowered people and communities. And Anshu and I had a bit of a brainstorm and thought, but what would this mean in the case of pneumonia? Well, obviously we heard that services, you need to immunize kids, then you need to have access to IMCI, ICCM, being able to diagnose and treat your child, and you need to have good quality referral care. In this case, have access to oxygen. We discussed and said that out of many multi-sectoral risk factors, nutrition and air quality are 2 ones that are really very important to control pneumonia. And then we said, what does empowered communities mean? Well, it means an accountability mechanism, right? Saying, am I getting the services I need or not? Are we getting our services? It means having engaged people, engaged communities in producing health. It means having educated parents. I used to quote my mentor, Professor Francis Omaswa in Uganda. He always said, health is made at home and hospitals are for repairs. And that's where I think this green sliver comes in here. Health is made at home. The health service is only there to repair when the home fails. Now, let's look again at the 30 high-burden countries in what we call the pneumonia wheel. What's the status here? Well, Seth and his colleagues have done remarkable work on the immunizations. Haemophilus influenza is out there with a high coverage. Pneumococcal vaccine is at 50%. We need to fill it up to 100%. Care seeking is doing a bit better, as you can see. But then there's a huge drop. As you can see, there's no data there in the gray for the amoxicillin or for the oxygen. Two life-saving commodities and things for which we actually don't know the status. We hear a lot of reports like Kevin's saying the amoxicillin is out, or I reach the hospital and the oxygen is not there, but we actually don't know. We're not following up this systematically in this age 2020. How serious is that? Now, there's also making sure that there's the absence of stunting and absence of malnutrition out there that we really need to take care of. We need to take care of the indoor air quality and the outdoor air quality and make sure that those reach 100% of clean air and well-nourished kids. And then, again, the accountability measure is gray. In the aspect of social accountability, saying, am I getting health services? Can I affect this? Again, we don't have a good measure. There's a need for innovation here. We're not measuring this. Then we put in two proxies here, women's engagement in decision-making and female completion of secondary school. We need that. This is a gender issue as well. We need to reach 100%. Because when this pneumonia wheel is full across all these domains and sectors, that's when we will have beaten pneumonia. And until we've done so, a child living in one of these countries actually has 60 times higher risk of getting and dying pneumonia than I had in Sweden. There's a differential of 60 times in mortality risk to pneumonia across the world because of failures across multiple sectors. So, money obviously comes into play. We've already heard this, and I wanted to bring home that this is not unaffordable. Pneumococcal vaccine costs $12 now. It's going to come down in price, we had Sir Berkeley say, thanks to innovation from India. Amoxicillin DT is less than 50 cents. Dispersible tablets, that's the mystical DT, it's actually 40 cents per dose, my friends. And that's what little guy what's his name again? Nyai was not getting. Caring for a child in the community with a community health worker is $6. And if we put this together for the 30 high-burden countries, we're looking at $10 million to buy that missing amoxicillin. We're looking at $130 million to set up care at community level. I mean, this is pocket change in this type of world here. This is where I want commitments out of this meeting, where I want us to work together, national governments, donors, international organizations, to fix this. Obviously, the domestic resources are key. We couldn't trace them down to pneumonia, so we looked at official development assistance. And where are we? Well, let's look at the last 10 years. The blue here in malaria, that's the resources. The pink in HIV, that's the contribution you see. We have a global fund for HIV, TB, malaria. We don't have a fund for pneumonia. You see the sliver that is in green for pneumonia. It's small. Let's examine that green sliver. It's mostly vaccines. Again, thanks to Gavi and the last 20 years. In blue here, in light blue, Haemophilus influenza, and in dark blue, pneumococcal vaccine are up, and the expenditure up, and the coverage is up. But for everything else, the curative care, the community health worker, that's again that little green sliver at the top. That's everything else that ODA spends on pneumonia. Again, insignificant. And let's look at that insignificant sliver. Yes, there's a bit of research and development, but 30% of something very small is very small. There is the treatment-based inventions, and there's the community-based management. This is where we need to fix things. We need much bigger investment here from domestic and global resources. So, looking ahead, what is it we need? We have tools, they need to be improved. We need better vaccines, we need better diagnostics, we'll discuss that. We need better care systems, we need social innovation as well as product innovation. We projected, though, if we take the tools we have today, and we scale them up to 100% coverage around the 30 countries, what will we get? Well, we will save this many lives from pneumonia, 3 million, 20% of which in the first month of life. But by scaling these interventions up, we get secondary effects from other causes, which is another 5 million. That's why we're getting to 9 million saved lives over the next decade, and we'll be fulfilling that promise that we referred to, the promise made 5 years ago to end preventable death. So returning to Niruta's happy family here. This is a family whose happiness was saved. Every 39 seconds, one family is broken. We are many constituents here. We are ministers, we are policymakers, we are donors, we are researchers, but I think most of us and many are parents as well, and even the occasional young person. In this beautiful museum here, let's make primary health care deliver for children with pneumonia. Fittingly in a museum, let's commit to make pneumonia history. Thank you.
Thank you. Thank you, Dr. Peterson. And now for the next panel, I'd like to invite on stage Sarah Bosley. She's health editor at the Guardian newspaper. Sarah, thank you.
Thank you very much. So, this is the first session, and I'm Sarah Bosley, health editor of The Guardian. I'm delighted to moderate this. We have an excellent panel for you, and hopefully we can frame some of the issues here that will be discussed in much greater detail at this conference, and I'm sure it'll be very interesting. So, first of all, we have the Minister of Health for Uganda, Jane Acheng. We have Leith Greenslade, who's coordinator of Every Breath Counts Coalition. And we have Irene Cook, Acting Assistant Administrator for Global Health at USAID. And Matti Dia at the end, who is the Partnership Manager of the Global Financing Facility. So perhaps we could start with you, Minister, and maybe you would like to talk to us a little bit about the situation in Uganda and what you're managing to achieve at the moment. Could you talk to us about what you have been doing to bring down child pneumonia deaths in Uganda, what further actions you plan, and also a bit about the challenges ahead?
Oh, thank you very much. It is a pleasure for me to be here to discuss pneumonia, even as our countries are battling with what to do regarding the coronavirus. Now, the current situation regarding pneumonia in Uganda is not too good. If you looked through Stefan's presentation, Uganda was among the 30 high-burden countries. Pneumonia accounts for 10% of under 5 deaths in Uganda, and 25 children die every day. But we have not been seated. We have been scaling up approaches to protect, prevent, and treat pneumonia among the under 5. And some of the interventions in that area included ensuring that we continue to scale up breastfeeding that now stands at 66%, complementary feeding at 32%, vitamin A supplementation still low at 30%, the measles vaccine coverage at 88%, the pneumococcal vaccine coverage at 96%, hand washing is poor at 34%, and safe drinking water at 78%. DPT coverage 93%. However, we started the integrated management of neonatal and childhood diseases in the early 90s, and over 3,000 facilities in the country are enrolling it, and both public and private health workers have been trained in this area. We have also been scaling up the integrated case management since 2010, and now we have covered 67 out of the 134 districts and treating almost 800,000 pneumonia cases annually, but leaving a treatment gap of about 150,000 cases of pneumonia among the under 5. The pneumococcal vaccine was introduced in 2013, and the current coverage is 96. Many of you have also heard about the measles rubella vaccine that we introduced only last year. We had the biggest campaign south of the sub-Saharan, and we vaccinated over 19.4 million children under 15 years, achieving a 99.5% coverage. We are institutionalizing what we call the community health extension workers. These are workers who will be paid and move door to door to deliver a package of preventive, promotive, and curative services. We have also launched up a campaign to scale up oxygen to the entire country so that we are able to treat hypoxemia. And we are doing this in collaboration with a number of partners, CHAI, PATH, and UNICEF. We have also intensified social behavioral change communication, educating people, especially those that use firewood, not to cook inside the homes. But we are also happy that the government introduced very heavy taxes for second-hand and used cars. And we are working with partners to improve availability of real data from the communities to guide planning and implementation. Pneumonia treatment has improved over the last 3 years from 800 cases to 1.4 million cases per year.
So what are the challenges, do you think, in the way that you're addressing this? You're obviously doing a great deal, but it's hard, isn't it?
Yes.
And you're, as you said yourself, you're not quite getting the success that you would like.
Well, one of the major challenges is underfunding. There is no specific budget allocation for pneumonia. We have been advocating for this, whereas government has been increasing domestic funding for vaccines. We still need funding to ensure that we have amoxicillin for treatment of pneumonia, adequate quantities so that we don't have the stockouts that Stefan was talking about. We need funding to support social behavioral change communication, expand the cold chain up to the lowest level, but also support the community health extension workers. Social behavioral change communication is not cheap. We also need to demystify the myths and misconceptions around vaccines. This is a global problem. People need to know that vaccines work and that vaccines are quite useful, and that when we vaccinate, then we prevent. And so there is a lot of work that needs to be developed in that area so that the coverages go up. We also need to get the health workers trained to be able to diagnose on time. We heard about misdiagnosis, diagnose on time, and treat the children appropriately so that we don't have complications resulting from poor treatment as well as drug resistance and antibiotic resistance.
What about, how important is your commitment to primary health care as part of universal health coverage in addressing pneumonia? Because we increasingly talk about trying to go for universal health care rather than vertical, actually, approaches to diseases. So,
universal health coverage is a priority for the Ugandan government. And to that effect, we have developed a roadmap to universal health coverage. And one of the roadmaps is ensuring that we invest in communities by enhancing community health, but also ensuring that the communities participate in their own health. Universal health coverage is enshrined in our national development plan that
will be approved shortly, that is National Development Plan 3, as well as in our health sector development plan. We are working with partners to ensure that we have a community health strategy and a community health policy, but also be able to collect information from the communities in real time, because whatever we do is around the communities. And it is only important that we have information from the communities in real time, but also work in a multi-sectoral collaborative manner with all our partners so that we avoid duplications and account for every dollar. So yes, primary health care is extremely important for us.
I'm sure we'll come back to a lot of the issues you've been raising, but maybe I can move on to Irena Cook. I'm sorry, I keep mispronouncing your name. Could you perhaps talk to us about what USAID is doing? The US government has been a long-term, a strong supporter of child survival programming. How is USAID going to continue to support countries in their goal to end pneumonia deaths within the next decade?
Well, thanks very much, Sarah, for the introduction and the question, and I really want to thank the organizers for inviting me to be part of this very distinguished panel. This, Stefan's presentation really outlined a lot of the issues and the things we needed to do, and it really brings home that what really are the actions that we needed to support. I really do love the wheel, the pneumonia wheel, and I think it's something to think about and adapt is sort of how do you measure what the integrated approach that we really need to take. So, as you mentioned, Sarah, USAID has long been a supporter of maternal and child survival programs. For 50 years, it's an issue. We've been partnering with countries, with the NGO community, with civil society, with faith-based community, with our UN colleagues, with country governments, and the private sector to really try to take action and make progress against these issues that do needlessly kill so many children every year. And our commitment to continue to do that is very strong, and it remains one of our priority goals as we talk about what we do in the health sector, that reducing those preventable deaths for children and for mothers in the developing world is a core priority for USAID. Kevin and Stefan made reference to the meeting, the event in 2012, which was a call to action, a child survival call to action. It really did came together with Ethiopia, with India, with the US, and with UNICEF to really bring action to end these preventable deaths. And at the time, by 2035, while we made a fair bit of progress, obviously, given the work that we've been talking about here today, that job is by no means done, and there's a lot more to be done. So, but building on that approach and that call to action, USAID is focusing most of our resources in about 25 high-burden countries that really collectively account for about 70% of global child mortality. And then preventing, protecting against, and treating pneumonia is a central tenet of these efforts. And as we heard from the previous speaker, pneumonia is very much a disease of inequity. It's a disease of poverty, and it really does affect those children who are living in the underserved communities. This is not unique at all to pneumonia. I mean, as we think about every issue in child health or in maternal mortality or tuberculosis or any of these issues, it really is the inequities and the poverty is such a factor that we need to keep in mind. The speakers in the first panel and earlier all talked about the many interventions we need to do around pneumonia, and pneumonia is part of a comprehensive approach to child health. And that's certainly how USAID, that forms the basis for how USAID approaches this, and that's very much our priorities around it. And as we look to 2030, we really need to ensure that our programs and our efforts understand subnational inequities and access to high-quality prevention and treatment measures for pneumonia, and really strategically respond to those inequities. This includes supporting efforts to strengthen the quality of care. I mean, the story that Kevin shared of what really happened in that village in northwest Nigeria is really, as you noted, is something we see over and over and over again, and it's a real function of poor quality of care in so many health facilities around the world. And that is something we really need to address and get on top of. We work very much with governments to strengthen their community health programs, which really are essential to achieving equitable coverage of primary health care for children and for holding health systems accountable for making sure those services are delivered to the kids that need to access them. And it also means working with civil society and faith-based community to reach those communities and those children that are most marginalized and don't always have access to their public sector or private sector facilities very easily. We know that the community health platforms currently have gaps in critical commodities, as we've heard already this morning. But moving forward, we want to really collectively address these shortfalls and ensure that commodities such as amoxicillin are available across the board. That was a core principle to some of the progress we've seen in things like malaria and in HIV/AIDS, of making sure those commodities are available when they need to be available and that they're affordable. And that's got to be core of how we approach things like pneumonia as well. We need to encourage greater care seeking at the community level, as well as better armed caregivers and frontline health workers with the knowledge and skills to identify those early warning signs of pneumonia. But we also know, and has been talked about and is nicely portrayed in that wheel, that health system alone is not going to end preventable pneumonia deaths. And for USAID, looking at this from a multi-sectoral approach is extraordinarily important. We want to really address some of those underlying determinants of pneumonia, looking at high-quality water and sanitation and hygiene services, routine immunization, as well as addressing those issues of air quality. I think this is very much, again, part of how we're trying to approach pneumonia. The couple of examples I want to share, at least one example I want to share, and we have seen working across sectors really can drive results. A program that USAID has supported, an integrated health program that USAID has supported in Nepal called Suahara 2, has increased the percentages of households that have soap and water at hand washing stations from 48% to 61% in just 2 years. And since 2012, has increased the rate of exclusive breastfeeding in supported communities in Nepal from 46% to 69%. Those kinds of interventions and those results really do prevent the sort of the foundation for progress against, as we've been talking about. And with 75% of the world's unvaccinated children residing in these 25 high priority countries that USAID supports, strengthening routine immunization is a really central pillar to what we talk as we talk about our maternal and child health strategy. Immunization is core. We've been very proud to be a part of the Gavi partnership from the very beginning, and will continue to do so. This is, in Gavi, as we've talked about, has made a tremendous progress on this, but there are still there's still work to be done, as the Honorable Minister talked about. Lots of progress in immunization coverage, but lots more needs to be done. In the next decade, we also need to see a lot of collaboration with the private sector. You know, the private sector is there, and the private sector has many different forms. There's certainly private providers, there's the corporate private sector, and everything in between. But engaging the private sector in our work is extraordinarily important and very much a high priority for USAID. And we really can see the private sector as a powerful partner in driving some of the change that we need to see at country level. And for example, in South Africa, USAID piloted programming that provides small pharmacies with working capital to access medicines and offers business logistics training to improve their services and sustainability. And very often it is these small pharmacies that are the ones that families first access to get drugs. And while we've made progress on child survival in the last decade, we really do have a long way to go. And going forward, catalyzing progress will require overcoming some of these new as well as ongoing challenges and new challenges, such as the growing population, urbanization, increasing migration, both to cities and across borders, and political and social instability. These are things that are affecting so many countries so often. To accelerate progress, USAID is prioritizing our strategies and partnership models and program practices to maximize country ownership and work across a time when foreign assistance is no longer necessary. For another example I want to share from our team, our USAID's team in India has long been looking for ways to pilot models that are then taken to scale by state governments as well as national governments and also private sector. These are, for example, the USAID demonstrated a model for the use of a technology. This was bimodal pulse oximeter in the hands of frontline health workers. that was to improve the diagnosis and management of pneumonia. Many states in India have already taken this forward as in their program implementation and their plans for scaling up. So finally, we really look forward to working in partnership with all of you. This is where we hope to identify some new opportunities for collaboration in the next decade and further strengthen our collective action and to end preventable child deaths and particularly to end pneumonia. So thanks.
That's terrific. I'm sure you're going to have some interesting conversations.
Yes,
in this
absolutely.
Yeah. I'll move to you, Leith, if I may. And could you talk to me about how a coalition such as Every Breath Counts can bring together all the various players? There are so many different players in this whole thing. And Irene just talked about public and private partnerships, civil society, so many different players. How can you bring them together to act effectively at global and country level when there are a lot of divided opinions about the best way forward?
So the first point I want to make is that the world has never mobilised a serious effort against the leading killer of children, pneumonia. No single nation, no international agency has ever done what's needed to end preventable pneumonia deaths. And child pneumonia is the leading infectious killer of children for many decades. It was the leading killer. So that's a quite extraordinary statement when you think of all the activity and focus on global health now, that we've never been able to come together to do a comprehensive pneumonia strategy. The vaccine piece is strong, for sure. Gabby has done extraordinary work. We're not there yet, though. We're only halfway with that PCV coverage. We have much, much further to go to fully protect children with the pneumonia vaccines. But the rest of it, it's just not there. Diagnosis and treatment are the missing pieces in the pneumonia strategy. We don't even know what we don't know, as Stefan said. We don't know antibiotic coverage for pneumonia. We don't know systematically what the diagnosis is. We get little snippets from different studies. So some of the data coming through is suggesting that less than 5% of children with severe pneumonia are getting correctly diagnosed. In other countries, it's a little bit higher. So all these children falling out of the system. This is why we have a child pneumonia problem. So out of sheer frustration, the Every Breath Counts coalition came together because there was no agency focusing on pneumonia control. The countries were on their own, as the Minister has said. If a country said we need to talk about vaccines, nutrition, diagnosis and treatment to get a handle on our number one killer, there was nowhere for them to go. So the coalition is almost, it's not an ideal, and we would love to have a very powerful and well-funded institution like the Global Fund, or another fund to work in a more integrated way, but in the absence of that, we've had to cobble together our coalition. So we have 40 members, public and private, very, very strong groups, and we're trying to build momentum to fill those critical gaps. But there are many, many of them. And I think it's because at the end of the day, in health, dollars don't follow disease burden. In an ideal world, countries would have their priorities. The diseases that are killing their children, let's just talk about child health, and everything else would fall in after that. So if in Uganda, pneumonia, newborns, which is a very big issue, pneumonia, diarrhea, malaria, it's usually the same 4 or 5 causes in most countries, they just differ in their order. And the entire system should be built around those national priorities and to support targeting the leading killers of children. If we don't do it that way, we just won't achieve the SDGs. This is the way we have to work to achieve that very ambitious goal. We have to have all of our resources working in an integrated way around the leading killers of children. At the moment, we have some very strong efforts in a few areas and we see great progress. But imagine if we could just take a more integrated approach, the results we would get. I'm so impressed by the analysis that UNICEF did, which showed that by investing in pneumonia control, you can save all these other deaths from other causes. So the 9 million figure you're going to hear a lot at this forum, 9 million children's lives that can be saved over the next decade with pneumonia control. Only 3 of those are from pneumonia, 3 million. The other 6 are from those other causes. I think it's diarrhea, meningitis, measles and sepsis. So if there's one message I had for country government leaders as well as international agencies, investing in pneumonia control is a very smart SDG strategy. Please take a serious look at it over the next few days. The Every Breath Counts Coalition is here to support you. We're very excited the Nigerians are on stage later. Nigeria has partnered with Every Breath Counts to show how this could be done, how a pneumonia control strategy should be done, and you'll be hearing more about that later.
And yet, you're talking about emphasis on one disease, which was highly criticised when it came to HIV, of course, in the past. We now go for universal health care with the idea is integrated systems. How can you justify focusing on one disease when actually the move forward is for universal health care?
So this debate about a single disease versus integrated, this is the false choice. Countries need both. Countries need to focus at the strategy level, the policy level, on the leading causes of children, women, etc. When it comes to delivering, that's where the integration comes in. So services must be integrated. Families must have one place to go, not 5 when they have a sick child. So the integration piece is in the primary healthcare delivery. At the strategy level, countries must have strategies that focus on the leading killers. Otherwise, the fact that we don't have pneumonia as a line item in country budgets, for example, that's why it's slipping through the cracks. So you have to have at that policy and legislative level really your eyes on the leading causes of children and women and other populations. But delivery always must be integrated, otherwise people won't come.
Right, Matty, you have got quite a job, haven't you? What is the role of civil society in trying to ensure accountability for child survival at global, national, as well, and subnational level as well? I mean, that's a massive thing to try to hold everybody to account for the deaths of these children.
Absolutely, and thanks for inviting me. It's an honor to be here. I think I would not say the role of civil society. There are several roles that we have, and I'm glad that everyone here has been talking about integration. And this integration needs to go all the way down to the community level. Because we talk about it at the global level, and we have now the Global Action Plan for Healthy Lives. We have different global action plans, but what does it really mean at country level? Do we...
Matty, I think we're having difficulty hearing you properly. If you could actually direct yourself to the audience.
Is that better now?
I think that's better, yes.
Okay, sorry, I was moving. No, I was saying that the integration that we're talking about at global level needs to trickle down to countries and to communities because we're seeing it in paper, and civil society have a role of making sure that this translates at the community level. Like Leith was saying, when you go to the health facility, you might have pneumonia, you might have malaria, you might have other diseases, but the child is usually taken for one disease. So this integration is key, and as CSOs, we are pushing for this to happen at the community level, we're pushing for this to happen at national level, but also at global level. The other thing that I wanted to add is the multisectoral aspect of pneumonia, because we are often looking at taking care of the child in health, but we're forgetting about the mother's education. And this is where I want to put a focus. Women who are not educated often have children who are sick and have higher causes of death, whether it's pneumonia or other diseases. And women who are not educated cannot feed their children right. So we have the malnutrition effect, and this is where we come in at the community level and educate these children. Educate the mothers, but also educate the fathers, because often you have the women who want to treat their children but do not have the right, or they do not have the agency of going and seeking health care because of power structures, and because the husband has to provide he needs to give permission for the woman to go and seek help. So this is where we talk to communities, we talk to mothers, but we don't only work with mothers, we work with their husbands, we work with community leaders, and we do behavior change communication, which to us is very important because we have talked about prevention, and vaccine, of course, is key in preventing pneumonia. But when you, change behaviors, we need to shift cultural norms. You're talking about indoor air pollution. We've been cooking indoors forever. I mean, I grew up, my grandma was cooking using coal and wood. And a lot of women who cook like this do not know the bad risk and consequences. So CSOs are close to the communities. We have an added value of knowing the communities, knowing their needs, knowing how they work and how they live. So by going to these communities, talking to them, and having this cultural shift, not only with mothers, and I keep insisting that it goes beyond, because in a lot of communities where we are, women do not have that power. Even if they want to, sometimes it's cultural traditions. Going on nutrition, women do not exclusively breastfeed their children, because grandmothers or mother-in-laws always have something to provide to the child. So there's a lot of cultural norm and shift to be done, and this is not coming from immunization. This is coming from CSOs talking and being close to communities and talking to communities, changing the way people think, changing the way people live, and the way people behave, and only then we can see sustainable change. To me, immunization is not the only solution, although it's, I would say, 50% of what is required, but there's so many other things, and it all comes down to mothers' education to me, because there's a big gap happening in all those countries where you have high death of pneumonia of children under 5. You have also very high illiteracy rates of women. You have high rates of child marriage. You have low level of education. So it's really one big piece. And I like the pneumonia wheel that Stefan was showing, because it all requires several stakeholders, and civil society have to be at the center, because we are working for communities, and if we only work at the top level, and you forget about the communities and the CSOs who are at the center of the communities, then you're missing the point, yeah.
You can see why pneumonia is such a challenge, can't you? When it actually you have to involve not just the Minister of Health, but the Minister of Education and various other government departments and all the civil society people as well, and so on. I was wondering whether you think, and this is now, I think we could have a general discussion, I'm happy for everybody to join in, whether vaccines have been overemphasized, or perhaps not by you, but they have been assumed to be the answer by a lot of people. And so perhaps people have gone down that road thinking it's all right, tick the box, vaccines are going to solve this. Does anybody want to reflect on that at all? Perhaps the Minister?
Well, I wouldn't say vaccines have been overemphasized. Actually, they've been underemphasized. We need to talk about vaccines, as I mentioned before, and demystify the myths surrounding it. But we need a lot more than vaccines to control pneumonia. We need a lot of social behavioral change. We need people to understand the burden behind pneumonia and the deaths that it causes. And we need multi-sectoral action, as we have been indicating. Pneumonia kills, and Stefan brought this out very clearly, that many of our African countries, it is still the #1 cause of death. People need to know that it is still a leading cause of death, because many times people assume that other diseases like HIV, a lot has been done, people are no longer dying of HIV. A lot has been done in the area of malaria, but like Liz said, people are quiet about pneumonia. Nobody talks about it. It is only the pediatricians who meet it on the wards, or the physicians who come across it and they get to treat pneumonia. But it's killing. The statistics is showing that. So we need vaccines, and we need cheaper vaccines to be available so that we can prevent. Most of our countries cannot treat. If you look at the case of Narita, she was unconscious for over 1 week. She needed life support. How many African countries would have that readily available up to the grassroots? It wouldn't be there. But if it is prevented, then people like Narita wouldn't need to go to hospital to get treated for severe pneumonia. If we have amoxicillin available and it is being given freely to the households, that would go a long way in preventing severe pneumonia. So we need to talk about prevention, prevention, and prevention. And we still need to talk about vaccines, because vaccines is prevention.
I'm quite perplexed, just as, on the side, you know, amoxicillin, why is it in such short supply in your country? Why do you have stockouts? Do you know?
Because there is inadequate funding for amoxicillin. Nobody is focusing on ensuring that amoxicillin is widely available to everyone who needs it. There are so many priorities for our countries, so many priorities, and new priorities keep on coming up. Look, now we have coronavirus. The minds are shifting in that direction. We need money for everything. But there is not enough money for everything. So what do we do? Where do we get the money? How do we ensure that the commodities don't run out of stock? The best answer is prevention. So we need the amoxicillin much cheaper, and we need funding for that.
Leith, did you have thoughts on this?
I do have thoughts on the vaccine issue, because the vaccines are critical and essential. But countries need to know that even with full vaccine coverage of, say, the PCV, the Hib, you will still have 50% of your child pneumonia burden. The vaccines will not take care of all of the child pneumonia deaths, because the vaccines only protect against certain strains of causing pneumonia, bacterial and viral. So you will still have a lot of children dying from pneumonia, even if you do everything with the vaccine that you're supposed to do. And that's where diagnosis and treatment comes in, but also where those other prevention, nutrition and air pollution, you can really reduce the risk for children by keeping wasting at very, very low levels and making sure the air is clean at home and outside. I do think, though, another point to make is I very much agree with the Minister. When we ask and talk with countries, pneumonia is often not on the table, and there's often a lack of awareness that pneumonia is the #1 killer in that country. A lot of talk about malaria and HIV, and I think this is some of the responsibility for this is on the global agencies. And we know there's studies showing that a focus on some of these issues can distort national health systems, and there's good data on that. If you put yourself in the position of the country, it's very difficult when you have very large organisations coming with very large amounts of money for one or two things, but there are actually other things killing your children. What do? You obviously accept that and work on that, but what happens to the other issues? So it's really a partnership approach that we need, with national governments sitting with the international agencies to fill these gaps. And that's what the agencies promised to do last year with that new SDG action plan. They promised, Global Fund, UNITAID, and UNICEF, WHO, there's 12 of them, promised to come together to make it easier for countries to come to them and fill these gaps. And I would argue that pneumonia should be first on the list of issues to resolve, how to fill the gaps.
Anybody else? Matthew or Irene? Do you want to go first?
Yeah, just very briefly, I think the Minister put it very beautifully, and I agree with Leith. I don't think immunization has been overemphasized at all, and I think as we talk about these larger programs, there's obviously still a lot more work to be done on immunization, and it's an extraordinarily powerful intervention, and we can't stop until every child has easy access to all vaccines, right? That said, I also think when, certainly within Gavi and more broadly, when we've talked about immunization, we see it as a way to really bring kids into the primary healthcare system. So it can be an instigator to get that comprehensive set of services. And that's really how we have to look at it in program and look at the connection between things like immunization and pneumonia, and get attention to issues like pneumonia without turning it into a pneumonia-specific initiative, as we've been talking about all along. It has to be a comprehensive approach, and something where that comprehensive set of services are available when families need them.
Matty?
Yes, I just wanted to raise the fact that with the different civil society constituencies of the global health initiatives, we have the opportunity at country level to influence the GFF investment case. And these investment cases are prioritizing the priorities within countries. And that's where CSOs can say, this is the #1 killer of children. If you want to decrease lower mortality of children here, this is where we need to put the money. And there's one piece that I forgot to mention, which to me is very, very important, is the social accountability at community level. Stefan mentioned it. There's not enough that's being done at the community level. And I think we need to empower communities to demand for good quality integrated healthcare at the primary level. We need to make sure that amoxicillin is available where even the community health workers are the only persons that can take care of the treatment of pneumonia. We need to make sure that the funds that are supposed to be there are arriving where they're supposed to arrive. And not only, we keep pushing for increased funding, but sometimes we do have funding in some places, but it's not well spent. So this is where, as CSOs, we need to look at making sure that the priorities are set for pneumonia, but also the funding is there and is well spent. Thank you.
Yes, so on funding, we have just got a couple of minutes, and this is probably a very long issue, but let's just try to address that very quickly. How much more funding is needed for pneumonia, and how should it be orientated? Because, are we doing it from the perspective of the minister, putting funds into healthcare, or should we be looking also at education and environmental pollution and so on? How do you do this? How much more money is needed, and where should it go, I suppose, is the question. Well, maybe, Minister, how much more do you need, and where would you like the funds to go? Write the bill.
Well, good question. How much more money do I need? I need a lot of money. I can't tell you the figures because health is very dynamic. It keeps on changing. So you can never say exactly the amount of money that you need. While we need to invest more in pneumonia, we need to work towards strengthening the systems and integrating management of many diseases. We cannot continue to have vertical or verticalized management of illnesses. It doesn't work. And it creates, disharmony in management of systems, in our health systems down there. So we need money to strengthen the systems right from the grassroots up to the highest level, where we have communities aware and involved. We have good referral systems and ambulance systems. We have information being sent out to the public on a daily basis, and we have strong health facilities where when patients come, they can be well treated and treated on time, and they receive quality treatment without stockouts of commodities. So we need funding for all that. So how much? Well, the rest of the people here can tell us how much.
Yes. What about funding? Elaine, perhaps I should ask you about this.
No, actually, I don't know how much either. I very much agree with the minister. But I assume people around the room have been looking at this question, but, and again, going back to that lovely wheel that Stefan showed, it did tell us where some of those investments need to be, and it really does need to look at some of where do we see the gaps in those areas that can make a difference, and whether it be the commodities like amoxicillin, or really looking at the sort of the comprehensive referral centers, or those multi-sectoral approaches. Those are all areas where we do need to make some investments. So, yeah.
The fact that this question can't be answered is the problem. Because you would not have this in some of the other areas. Mm-hmm. They know exactly what they need and for what. So this is the problem. So what the Every Breath Counts Coalition is trying to do about this is work with countries to develop what we're calling pneumonia control strategies. And that pneumonia control strategy is a strategy document. It is not a new vertical program. It's a document that looks at the 5 vulnerabilities. So we look at air quality, nutrition, vaccination, where the vaccine gaps are, diagnosis and treatment, and the critical 5th, female literacy and empowerment. Mm-hmm. They're the 5 areas where we think if we could close gaps in most countries, that would put pneumonia on the trajectory it needs to be for SDGs. So because countries have gaps in all different areas, it's a different strategy for every country, so you can't just have one big approach. And that's what Nigeria's done. I'm going to mention it again because I really want you to watch this afternoon to have a look at it and see what you think. And once you come out with a costed strategy, the country understands where its vulnerabilities are. And then you can look at domestic resources first and put some domestic money on the table, and then bring the international agencies in to see where the gaps are. Not the other way around, which is the way too much health is still done. It's a global agenda, and the country is in the second seat. The country must have its own national strategy, and then the external agencies come in to support where needed. And that's, I think, the only way we'll do it in this new era, this new SDG era, when it's really, it's national leadership, and international health supports national leadership.
Okay, I'd love to get you in there, Matty, but I've been told we have to stop. So thank you all very much. It's been a really interesting session, and I hope you enjoyed the conference.
Thank you all. That was our first panel. By the way, all-female panel first, but won't be the last. So keep tuned. Now, let's go to Indonesia, a country that has one of the largest children populations of the world. That's, would you care to guess the name? The number is 25 million under 5. The health of these children is of interest, is of relevance not only to the Asia-Pacific region, but to the world as a whole. Today, we are honored to welcome on the stage the Indonesian Minister for National Development Planning, Suharto Monoarfa. Please an applause.
A very good morning, ladies and gentlemen. It is a great pleasure for me able to attend this very important occasion, the Global Forum on Childhood Pneumonia. On behalf of Government of Indonesia, I would like to thank you for the opportunity to speak in this event. I would also like to express a warm greetings to all speakers, international partners, representatives from member states, civil society partners, academia, and private sector. It is timely that we today are gathered in this global event to discuss pneumonia. As we all know, China is facing an extremely serious coronavirus outbreak. All countries in this region, including Indonesia, are on high alert. A global public health response is essential. Let us start conference by offering both our condolences and our support. We must work together to end this outbreak and commit to controlling all forms of pneumonia everywhere. I understand that pneumonia is a cause of a virus. Ladies and gentlemen, Indonesia is a vast country. We are an archipelago of more than 17,000 islands, of which over 5,000 are inhabited. As the Minister of National Development Planning, my role is to ensure that resource and skills, thank you. As the Minister of National Development Planning, my role is to ensure that the resource and skills reach where they are needed most. Together, we must ensure all of Indonesia of 270 million people benefit from the rapid pace of development that is taking place in my country. This is our common commitment. Indonesia is proud of its recent achievement. As our economy has grown, so have we achieved major progress in reducing child mortality, surpassing our Millennium Development Goals target 2015. Indonesia is also committed to achieve the Sustainable Development Goals. The SDGs inform every aspect of our development policy. This includes our recent medium-term development plan for the period 2020 to 2024. Both the SDGs and our national plan call for major reduction in preventable child death. Indonesia is firmly committed to cutting our infant mortality rate by nearly 2/3 in the next decade, from 32 deaths per 1,000 to 12 per thousand live births by 2030. We know we cannot achieve these targets without addressing pneumonia. Pneumonia remains the leading killer of children after the newborn period. We need to seriously take various measures to reduce pneumonia, primarily by increasing the coverage of immunization, addressing malnutrition, and access to health care. To tackle the ambitious agenda, I would like to take this opportunity to share a number of commitments. First is addressing the challenge of undernutrition. Children with undernutrition get sick and die from pneumonia more often. For the past 3 years, Indonesia has made childhood stunting a top priority. We have established a task force representative by 18 ministries to work together to address stunting across 260 districts, as half of the number of districts in Indonesia. This convergence of intervention for poverty reduction, health, nutrition, and water sanitation creates an opportunity to more holistically address both stunting and its root causes. By 2024, this program will be extended to all 514 districts in Indonesia. Second is ensuring access to health care. Over the past 5 years, Indonesia has brought 220 of its 270 million people under one government-administered health insurance program. This is the largest single-payer health program in the world. It guarantees all citizens access to a basic package of care and support services, free from financial hardship, no matter where you live in Indonesia. Currently, we provide full subsidy for the premium of 97 million of the 40% lowest income population. We are committed to extending coverage to all Indonesian citizens by 2024. Third is improving the quality of care. While access to care is important, this is just a first step. For pneumonia, it means having health providers with the skills and supplies required to correctly identify and manage sick children. This quality improvement requires investment in human capital. Human capital is the center of the medium-term development plan and is essential for improving the quality and reach of essential services. But money on its own, it's not enough. I agree with you, Minister of Health. Money is not enough. Resources must be matched with improved financial management, effective community engagement, and shared accountability for achieved results. Finally, we are focusing on pneumonia prevention. A major driver of pneumonia is Pneumococcus bacteria, which cause half of pneumonia cases. In Indonesia, there are close to 500 cases. 6% is a hospitalization, and close to 10,000 child deaths from this infection each year. While a safe and effective vaccine exists to prevent infection, the PVC vaccine, Indonesia has only introduced it on a small scale in demonstration sites. This is partly due to the high cost of the vaccine. It gives me great pleasure today to announce that the government of Indonesia is committed in proceeding with the special mechanism for PCV procurement through the Gavi Advanced Market Commitment. We appreciate the effort of Ministry of Health and Ministry of Finance and the support of Gavi, the Bill and Melinda Gates Foundation, and UNICEF is helping to make this happen. This will allow to purchase PCV at lower price and opening the path to reach all of 5 million babies born each year by 2024. Securing this agreement has not been easy. It has required major ministerial engagement outside the health sector, and with higher levels of government. This has been an important opportunity to work across ministries and draw attention to the critical issue of pneumonia in child death. Ladies and gentlemen, on behalf of the Indonesian delegation in Barcelona, we look forward to sharing our experience and learning lessons from other countries. As a large country, we realize that achieving our commitments can make important contribution to global health. However, it is only through working together, through our collective commitments across countries, that deep and sustainable progress will be possible. Our children's future depends on it. Thank you very much.
Thank you, Minister. And now, let's take a break, shall we? Right outside, there are refreshments. This is a half-an-hour break, so please be back at 11:05. But please, before you leave the room, two quick things. First, while you're out, please take the time to read through the declaration, the Forum Declaration. You can find it on the app as well. This is a declaration that describes 6 action items that we are inviting you to support to end preventable child pneumonia deaths by 2030. Also, those of you who are going to take official pictures, photographs, please, stage left, they're waiting for you there. And by the way, the next session, it will be in Spanish, a few minutes at least, so if you need a translation, a headset can be found there through that door. Enjoy the coffee. your seats. Pleasure now to introduce special remarks from each of the hosts of the Global Forum. We'll start with Mr. Antoni Vila, Director General of La Caixa Foundation. In a minute, please. The picture always takes a minute. We'll get there. How many of you have already signed? Oh, come on. How many of you have already signed on the declaration outside? Because you did take coffee. I saw that. Well, I really encourage you to read the declaration and support it. We are ready now, I believe. Just a sec. All the cameras, okay. Okay, I think we're ready now. Beautiful. So now I introduce Mr. Antoni Vila from La Caixa Foundation, which will give special remarks. Please come to the podium. An applause, please.
Buenos días a todos. Es para mí un honor dar la bienvenida en nombre de la Fundación Bancaria La Caixa a este Global Forum Neumonía Infantil, al excelentísimo señor Ministro de Sanidad del Gobierno de España, señor Salvador Illa, a los ministros de Sanidad de las distintas delegaciones que hoy nos acompañáis, al director general de Investigación e Innovación a Salud de la Generalitat de Cataluña, el señor Robert Fabregat, y al señor David Malmusi, así como a todas las autoridades, altos directivos, científicos de las más prestigiosas entidades y fundaciones del mundo, comprometidas con la lucha con la mortalidad infantil. Señoras y señores, sean bienvenidos a Barcelona. Más de 110 años después de su fundación y con una inversión anual de 545 millones de euros, nuestra organización continúa preservando la misión de construir una sociedad mejor, más justa, que brinda oportunidades a los más vulnerables de esta sociedad. Este foro global se enmarca dentro de los campos de la cooperación internacional, la investigación y la innovación, Como muestra de esta misión, solo indicarles que en el año 1931, en relación al ámbito de la salud, la Caixa ya estableció en Barcelona un hospital de referencia nacional en el tratamiento y la investigación de la tuberculosis. La participación de la Caixa en la lucha contra la neumonía comenzó hace más de 10 años y fue el momento cuando iniciamos nuestra colaboración con Gavi, de Vaccine Alliance, focalizando nuestra colaboración con la vacuna contra la neumonía. En 2008, nuestra organización lanzó un programa innovador, la Alianza para la Vacunación Infantil, para ofrecer a las empresas, clientes, stakeholders que trabajaban con nosotros, la oportunidad de colaborar contra la lucha de la mortalidad infantil mediante la vacunación. Dentro de un esquema de fondos de contrapartida, todas estas donaciones que recibimos de todos estos stakeholders y compañeros y empleados y empresas de España, todas estas donaciones con esta alianza fueron igualadas por la Fundación La Caixa y a posteriori la Fundación Bill y Melinda Gates vuelve a igualar esta cifra, con lo cual eso significa que por cada nuevo euro donado llegamos a la conclusión de que llegan a Gavi 4 euros, cuadriplicando así las ayudas recibidas. Gracias a esta alianza y a la Fundación Bill Melinda Gates hemos recaudado más de 33 millones de euros que han contribuido a vacunar a más de 6 millones de chicos. Además de invertir en la prevención de la neumonía, comenzamos la gran alianza con UNICEF mediante un programa llamado ARIDA, que seguramente ustedes conocen. ARIDA ha sido una de las mayores inversiones de la Fundación La Caixa en un único proyecto. Nuestra contribución a este programa fue de 5 millones de euros. Y a través de este programa, aproximadamente 1,3 millones de niños han accedido al tratamiento con antibióticos para la neumonía. Más de 300.000 niños se han beneficiado de mejor atención y, lo que es más importante, 6.000 trabajadores de la salud han sido capacitados en diagnóstico de neumonía y equipados con dispositivos automáticos de innovadores. Este programa se ha implementado en Bolivia, Etiopía, Mozambique, Nepal, Sierra Leona y Zimbabue. Y es precisamente en el marco del pilar estratégico ARIDA, de trabajar en la sensibilización y promoción de la neumonía, que surge la idea de organizar el evento que hoy aquí nos reúne. Hoy es una necesidad para mí expresar nuestra gratitud a todos los socios que trabajan para mejorar la salud a nivel mundial y en especial la neumonía, y que han hecho posible este foro global. UNICEF, la Fundación Bill Melinda Gates, Instituto de Barcelona para la Salud Global, Easy Global, Save the Children, Every Breath Counts, USAID, UNITAID y Gavi Vaccine Alliance. También nos gustaría agradecer a todos los participantes, desde el primero al último, que han hecho posible este foro, y especialmente a los expertos y las autoridades de tantos países que se han esforzado hoy por estar aquí. Esperamos que este foro global no se trate solo de buenos deseos, que todos somos capaces de expresar. Esperamos encontrar caminos reales y prácticos para que los gobiernos y sus socios puedan tomar y cumplir el Objetivo de Desarrollo Sostenible sobre supervivencia infantil. El progreso en la reducción de muertes por neumonía en niños menores de 5 años ha sido significativamente más lento que para otras enfermedades infecciosas y demasiado lento para lograr terminar con las muertes infantiles prevenibles en el 2030. Necesitamos con urgencia enfrentarnos a la insoportable realidad de la muerte de tantos niños, millones de vidas de niños que pueden salvarse para el año 2030, si todos nos priorizamos esta lucha contra la neumonía. Estar aquí hoy me llena de optimismo. Saber que todos ustedes están comprometidos en esta lucha me hace pensar que el fin de la enfermedad de la neumonía es posible. Muchas gracias por su atención y que tengan ustedes un Global Forum espectacularmente eficaz y bueno. Muchas gracias.
And now we'll hear from Antoni Plasencia. He's Director General of IS Global.
Good morning, everyone. Sorry. It's my pleasure to welcome you, Excelentísimo Señor Ministro, Your Excellencies, different ministries from the more than 11 countries here represented, authorities, officials, Director General de la Fundació La Caixa. It's my pleasure to welcome you to this event and to introduce you very briefly to IS Global. IS Global is a research institution that was born to respond to the challenges of global health, to the challenges of health without borders, and to the challenges of equity. And to do so, we are the result of the involvement of key institutions in our board that were at the core of the creation of IS Global, such as the philanthropy of Fundació La Caixa, such as the support of the governments of Spain, of Catalonia, and of Barcelona, and also with the involvement of two key universities, like the Universitat Pompeu Fabra and Universitat de Barcelona, and two teaching hospitals. Our role is to generate the best research that is helpful to provide new knowledge and innovations for some of the challenges of global health, thus trying to break the vicious circle of poverty and disease. And that's what we do on an everyday basis, working closely about a group of a little bit more than 400 people, working closely in partnerships in more than 36 countries in different projects. Pneumonia is high in our agenda, in our research agenda, and both from a perspective of epidemiology and surveillance, trying also to develop new tools to improve surveillance. For example, the development of what is called the minimally invasive tissue sampling under the sponsorship of the Gates Foundation and in support of, I should say, the largest current project dealing with surveillance of child mortality in many countries. But other areas of research have to do with biomarkers and diagnostic tools to be able to diagnose a disease as early as possible and to be able to support effective clinical decisions. But also we are involved in the evaluation of the deployment of vaccinations, and also I have to say, because we not only deal with infectious diseases, but also with the role of environmental exposures, with the role of indoor and outdoor air pollution, and the impact on respiratory health. So this is at the core of our mission and our work, but at the same time, IS Global was designed to be able to bring evidence, scientific evidence, closer to the policy decisions. So therefore, trying to bring the knowledge in support of the policy decisions, and as part of this process to bring together actors and key stakeholders who, at the end of the day, are at the core of the global decisions with global impact. So this is an event that clearly illustrates this vocation of us to try not only to generate knowledge of excellence, but also to bring this knowledge close to the decisions at the highest level and involving the many stakeholders, public and private, national, international, regional, local, around the challenges of global health, and in this case pneumonia. So it's a real privilege to be able to co-host this meeting. Let me just end by acknowledging the tremendous work of all the people, and among them the IS Global people, and I will just mention two names. One is the chair of the steering committee, Dr. Quique Bassat, our ICREA professor, and one of the leaders, research leaders in our scientific leaders in our institution, and also Professor Dr. Nuria Casamijana, our Director of Training and Education. Both of them on behalf of the many people, not only at IS Global, but at the many organizations that have been fiercely, I should say, preparing to ensure that this meeting will be a productive meeting, that it will be a meeting to enhance the networks and connections, and even more to support the key decisions that we have on our plate, each from our different responsibilities. So thank you very much. Thank you very much for your commitment to be here, and thank you very much for your fight for breath. Muchas gracias. Buen día.
Thank you. And now we'll hear from Julie Bernstein. She's Deputy Director for Global Policy and Advocacy at the Bill and Melinda Gates Foundation.
Thank you. I'm very pleased to be here. On behalf of the Bill and Melinda Gates Foundation and all of the host organizations, I too would like to welcome all of the ministers and their delegations, many of whom have traveled very far to be here today. We're honored to have representatives from the Catalonian and Spanish governments as well, and leaders from critically important partner organizations working together to improve child health. Thank you all for taking the time to be here in Barcelona. It's very special for me. I was a student studying in Sevilla in 1991, and I had the opportunity to visit Barcelona for about 4 days. And I was young and curious and had no money and just walked the city. So I'm here now, and I cannot wait to explore this beautiful town. But first, we're at a very important conference. So my colleagues and I are delighted to be here participating in this forum because fighting pneumonia is so critical to improving child health. And it's integral to achieving health equality, which we heard earlier this morning by this wonderful all-woman panel. As you know, pneumonia remains the leading killer of young children, despite being preventable and treatable. On a recent visit to a Delhi hospital a few weeks ago, my colleague and I saw one of the smallest premature babies we had ever seen. He couldn't have weighed more than 1 kilo, and he had pneumonia. Fortunately for him, he was in the care of top doctors and nurses. He was in a state-of-the-art incubator. He was hooked up to oxygen. He was receiving the life-saving medication he needed. His doctors gave him a very good prognosis. But this isn't the case for 800,000 kids every year who lose their lives to pneumonia. While we're all aware of those staggering statistics, I would like to tell some numbers, and there's an important number story with pneumonia that I think is interesting. Let's start with the number 5. So 5 years old is the metric we use to gauge how many children die from pneumonia. We've heard those numbers today. They're startling. They must be decreased. We must make sure that all children make it to their 5th birthday so they can do what 5-year-olds do, learn to read, play with their friends. The number 4, now for some good news. You heard from Seth Berkley from Gavi. Gavi, the Vaccine Alliance, has committed $4 billion to support the cost of pneumococcal vaccines by the end of 2021. Most Gavi-supported countries have introduced these life-saving vaccines, and thank you to the government of Indonesia for making your commitment to introduce pneumococcal vaccine. And many of you in this room make that possible, so we thank you for your support. 3, there's 300 of us here today, and we have 3 days together. So I'd like to challenge us to use this time for deciding practical next steps to really decrease pneumonia deaths. Even so, we know that more than 2,000 children still die from pneumonia every day, or 1 every 39 seconds, as others have said from this stage. We can and we must do better. We're here to protect all children from life-threatening pneumonia, every last one of them. But to do so will demand that we work together across many sectors, including immunization, diagnostics and treatment, nutrition, primary health care, to name a few. To that end, here's our call to action. It's time for each of us to deliver on our continued promise to save millions of children's lives. For starters, we can all support Gavi replenishment this June in London. Let's tackle this challenge together with renewed energy and commitment. Thank you very much.
And now it's turn for Davide Malmusi. He's Director of Health Services at Barcelona City Council.
Good morning, everyone, ministers, authorities, and colleagues. Thanks for this initiative. It is an honor that researchers and stakeholders from all over the world venue today in Barcelona. So thanks to the Barcelona Institute for Global Health and the foundation that are making possible this event and make today Barcelona capital of the pursuit of the right to health for all and of the 2030 Sustainable Development Goals. The unacceptable toll of deaths caused by childhood pneumonia is the unacceptable toll of death caused by social injustice. As the WHO Commission for Social Determinants of Health state concluded in 2008, social injustice is killing people at a large scale, and social injustice is responsible for the lack of universal health coverage in many countries, exploited of their own resources, with underdeveloped fiscal systems, and the same social injustice is generating strong income inequalities and leaves billions of people in poverty. As the same Commission stated, health is the result of social and economic circumstances in which people are born, grow, live, and work, and childhood pneumonia is a clear example of that. In Barcelona, during the last year, we have renamed the cooperation area as Global Justice Area. We have advanced towards destinating the 0.7% of municipal budget to cooperation projects and institutions, but we are also working for the global human rights responsibility of the remaining 99.3%, and also outside the municipal budget. For example, next week we will meet with 10 of the biggest public health care providers in the metropolitan area to discuss how to make public procurement more respectful of human rights through all the supply chain and waste management, to avoid, for instance, that medical gloves are manufactured under slavery conditions. We also still have a lot to do in our own house for the right to health for all. Spain is one of the European countries with largest figures of child poverty. The pollution of our cities is affecting children's respiratory system. And we have, in Barcelona, we have put the fight against inequality, pollution, and climate emergency at the center of the government action. Universal healthcare coverage in Spain still excludes large sector of treatments such as dental care or the free access to prescribed drugs, at least for lower incomes. And we know that the new health minister has a clear agenda on that, and we will be watching closely and eager to collaborate for its quick completion. So I hope you have a very fruitful exchange during this event that helps us to advance in the fight against childhood pneumonia. So let's stand up together against global injustice and let's fight for the right to health for all. Thank you and have a nice meeting.
And now it's time to hear from Robert Fabregat. He's General Director of Health Research and Innovation at Catalonia's government.
Hola, bon dia a tothom. Good morning, ministers, authorities, organizers. It's a pleasure for us to host this forum in Barcelona, so welcome to Barcelona, welcome to Catalonia. First of all, I would like to thank all organizers for having joined forces and efforts in this global forum on childhood pneumonia. We know this is one of the greatest health threats that children face around the world, claiming almost 800,000 lives per year, which means 2 deaths every minute of every day. For these reasons, it's really urgent to put pneumonia on the global health agenda and to set up forums like this, not focus on the analysis or reflection, or at least not only focus on this, but mainly on delivering concrete measures to act against this infection. The government of Catalonia, and in particular the Ministry of Health in Catalonia, is absolutely committed in facing the main challenge in global health, not as a passive actor, but with a proactive determination, more especially with regards to those diseases that affect the most vulnerable population, such in this case, in which poorest children are the most at risk. Our health systems, as you know, prevents infection with an early age vaccination coverage, but unfortunately, this is not, or not yet at least, a common pattern throughout the world. You have our total compromise in continuous supporting research and innovation, like the example of the institution is global, for reaching new treatments with real social impact, and moreover, developing new strategies and tools to face global challenges that go beyond our borders. I am totally sure this forum will provide answers and solutions to many of the current open questions. So thank you so much in advance for the good work you will do these days. Muchas gracias and enjoy this meeting. Thank you so much.
And now it gives me great pleasure to introduce the Minister of Health in the Government of Spain, the Honorable Salvador Illa, to officially open the Global Forum on Childhood Pneumonia. Ministro.
Ministros de, creo que de 11 países, directora ejecutiva de la UNICEF, director general de la Fundación La Caixa, director general del Barcelona Institute for Global Health, director de Servicios de Salud del Ayuntamiento de Barcelona, director general de la Generalitat. Senyores i senyors, bon dia i benvinguts a Barcelona i a Espanya. I know we are in front of an international audience. I have prepared my speech in Spanish, but just a few words to welcome you to Barcelona, to welcome you to Spain. I hope you enjoy your stay here and you have a good discussions here in Barcelona. Quería darles la bienvenida a Barcelona y a España y mostrar mi satisfacción por poder inaugurar este foro internacional de alto nivel. Me gustaría agradecer en primer lugar a las entidades organizadoras, especialmente a IS Global, esta iniciativa para la reducción de la mortalidad infantil por neumonía, que ha permitido reunir hoy aquí a importantes agentes internacionales comprometidos con el desarrollo, con la salud y con la infancia, así como a representantes de gobiernos con los que comparto el honor y la responsabilidad de trabajar para la salud infantil, tanto dentro de nuestras fronteras como fuera de ellas. La salud de los niños y las niñas es nuestro gran capital de futuro. Por ello estoy encantado de que sea la salud global infantil el foco de mi primera intervención internacional como ministro de Sanidad. El Gobierno de España está firmemente comprometido con la Agenda 2030 y los Objetivos de Desarrollo Sostenible, como hoja de ruta ética y operativa para la construcción de un futuro social responsable y sostenible, tanto para los que estamos ahora aquí como para las próximas generaciones, que serán quienes heredarán las consecuencias tanto positivas como negativas de nuestras decisiones y actuaciones presentes. Los objetivos de desarrollo sostenible se pueden y se deben concebir como un gran marco de determinantes sociales de la salud. El conocimiento científico y la salud pública nos muestran que en la salud de las personas influyen múltiples factores sociales y medioambientales más allá de los sistemas sanitarios, por lo que para abordar la salud debemos ampliar el horizonte y apuntar hacia la salud en todas las políticas. La neumonía infantil es un buen ejemplo de ello. La neumonía infantil es una enfermedad prevenible y tratable, cuya gravedad está muy condicionada por distintos factores asociados al desarrollo social. Voy a mencionar 4. En primer lugar, la lactancia materna exclusiva durante los primeros 6 meses y una nutrición adecuada son protectoras tanto para evitar enfermar como para evitar complicaciones graves o incluso morir por neumonía. En segundo lugar, la calidad del aire es un factor esencial para el desarrollo de enfermedades e infecciones respiratorias, máxime en la infancia. Respirar aire contaminado en el interior de los hogares debido al uso de combustibles sucios para cocinar o para calentarse, es un riesgo importante que aumenta la mortalidad de la neumonía infantil, como también lo hace la contaminación exterior. Por ello, la contaminación ambiental y el cambio climático es uno de los factores esenciales para la acción global en salud infantil, y en especial para las enfermedades respiratorias como la neumonía. La evidencia científica ya ha demostrado que la contaminación del aire es responsable de una carga significativa de muertes, hospitalizaciones y numerosas enfermedades a las que los niños son especialmente vulnerables. En tercer lugar, otro de los factores esenciales asociado al desarrollo para la aparición de la neumonía y otras infecciones infantiles es el acceso a agua potable, a sistemas de saneamiento y a un adecuado entorno higiénico-sanitario. Y, por supuesto, y en último lugar, el acceso a sistemas sanitarios universales, que permitan llevar la atención sanitaria a todas las comunidades, especialmente la atención primaria. Es fundamental tanto para prevenir la neumonía mediante programas de vacunación como para diagnosticarla y tratarla rápidamente. Anualmente, más de 800.000 niños y niñas menores de 5 años fallecen por neumonía en el mundo. De hecho, es la enfermedad infecciosa que más niños mata, casi 3 veces más que otras infecciones como por ejemplo la malaria. Aunque su mortalidad se va reduciendo, no lo hace a un ritmo suficiente o equivalente a otras infecciones que han tenido un apoyo internacional específico. Desde el punto de vista médico, en la actualidad es sencillo vacunar, diagnosticar y tratar la neumonía infantil. Lo que está resultando verdaderamente complejo es conseguir llevar el diagnóstico y el tratamiento a todas las zonas del planeta, y en particular a las zonas más desfavorecidas y en particular a las poblaciones y colectivos más vulnerables. Además, la neumonía infantil tiene una distribución desigual y dependiendo de dónde nazcan, los niños y las niñas tienen mayor o menor probabilidad de enfermar e incluso de morir. Los países con menos ingresos y dentro de ellos los niños de familias con menos recursos son mucho más vulnerables. En España tenemos una tasa de mortalidad por neumonía en menores de 5 años de 0,3 por 100.000 niños. Sin embargo, en algunos países del mundo las cifras son mucho más elevadas, llegando incluso a 27 niños de cada 1.000, según las cifras del informe de IS Global. España cuenta con un Sistema Nacional de Salud universal basado en la atención primaria, cuyo modelo es referente internacional y es considerado como uno de los mejores y más eficientes a nivel europeo y a nivel mundial. La organización de nuestro sistema es clave para la prevención y el control de las enfermedades e incluye programas de vacunación universales y toda una cadena de cuidados que permite el diagnóstico y el tratamiento precoz de las enfermedades y de sus complicaciones. Nuestro Sistema Nacional de Salud es una de las grandes fortalezas de España. Nuestro compromiso a nivel internacional consiste en seguir apoyando los esfuerzos de los países socios para que desarrollen sus sistemas sanitarios, extendiendo la cobertura universal a toda su población. Este es sin duda uno de los cambios estructurales más importantes para conseguir reducir la neumonía infantil a nivel global. Como miembro comprometido de la comunidad de donantes, España ha venido realizando importantes aportaciones de ayuda oficial al desarrollo para mejorar la salud global. Me complace recordarles que España ha vuelto a la comunidad de donantes del Fondo Mundial de Lucha contra el SIDA, la tuberculosis y la malaria, con una financiación de 100 millones de euros en 3 años. Confiamos que nuestra aportación pueda seguir incrementándose en próximos años. Ya he mencionado antes la preocupación del Gobierno de España por las desigualdades. Dentro de este compromiso amplio, España está empeñada en luchar contra los determinantes sociales de la salud, especialmente en los niños. Como muestra de ello, se creó en España el Alto Comisionado para la Lucha contra la Pobreza Infantil. A pesar de su corta andadura, ya ha sido reconocido por su actividad en la promoción de medidas eficaces para eliminar la exclusión social de los niños. Nuestro compromiso con la salud global, con el desarrollo y con la infancia debe estar perfectamente alineado con los objetivos que nos marca la Agenda 2030, y para ello hemos comenzado los trabajos para la elaboración de la Estrategia de Salud Global de la Cooperación Española. Adicionalmente, el Gobierno de España ofrece hoy un apoyo firme a la ciencia y a la investigación biomédica como herramientas fundamentales para avanzar en esta batalla. Algunas de las instituciones españolas que están hoy aquí presentes son la muestra de lo lejos que podemos llegar cuando el sector público y el privado trabajan juntos para promover la innovación y el conocimiento en enfermedades que determinan todavía la vida de cientos de millones de personas en las regiones más pobres del mundo, o que plantean desafíos comunes como el de las resistencias antimicrobianas o el de la búsqueda de tecnologías y servicios más asequibles y eficientes para todos. Luchar para respirar, fighting for breath, es el lema, is the motto of this event, es el lema de esta jornada. Luchar para que los niños y niñas respiren es una necesidad que requiere una acción internacional urgente. Solo colocando la salud en el centro de todas las políticas y acciones lograremos alcanzar los compromisos eficaces que nos permitan salvar vidas infantiles y promover, en definitiva, un desarrollo justo y sostenible. Con mi presencia hoy aquí quiero expresar este compromiso de España y también explicitar mi propósito de que el Ministerio de Sanidad siga dando pasos al frente en la esfera internacional para promover el cumplimiento de los objetivos de desarrollo sostenible relacionados con la salud en todos los países. Confío en que lo haremos en estrecha colaboración con el Ministerio de Asuntos Exteriores, Unión Europea y Cooperación. Mi enhorabuena a IS Global y al resto de entidades organizadoras por esta iniciativa y mi deseo a todas y a todos de los participantes de este foro de que el trabajo sea provechoso y disfruten de su estancia en Barcelona. Muchísimas gracias y bienvenidos una vez más a Barcelona y a España.
And now the forum is officially open, and we head towards our second session. Two things before we start. On the next session, we will have a French speaker, so should you need a translation, there are headsets right out that door. If you need one, please go and get one. Why? Because I still have to get 1 more minute of your time. We're going to use technology to enable you to participate in this town hall, this kind of town hall that we are making. So shortly you'll see on the screen how to use the web app that you can access through that QR code. This is the web app. I'd like you to go to the session, the current session, and then down below, top bottom, you see you can ask your questions. If you do that while the panel is ongoing, then we'll get those questions and ask them at around, let me say, in half an hour, 12:14. 12:40, sorry. At 12:40, we'll start the town hall proper. So, you have your translation for French speakers, and you have your web app to ask questions. Now, let's get to the chase. I'm delighted to welcome on the stage Dr. Margaret Agama. She's the head of health and nutrition at the African Union. She will be moderating this session. Oh, sorry. From here, if you want. Welcome.
Distinguished guests, participants, good afternoon. I bring you greetings of the African Union Commission and from every African child, indeed every child, anywhere they are in the world, who is at the risk of being infected by pneumonia. This decade, this new decade, is extremely important for all of us, given that we have 5 years left to implement the Global Action Plan for Pneumonia, which was launched in 2013 and is expected to be delivered upon in 2025. 2025 will be halfway into the delivery of the SDG targets, in particular SDG 3.2. So join me in welcoming a very diverse but illustrious panel to assist me in figuring out how we are going to meet these targets and achieve these goals. Our first guest is Dr. Mohamed Shamsul. He is the line director of maternal and neonatal child and adolescent health directorate, general services of the Ministry of Health and Family Welfare of Bangladesh. Following him is Professor Mamadou Samba, who is an associate lecturer in public health and economics and a researcher at the Houphouët-Boigny University in Abidjan, Côte d'Ivoire. Following him, I have Dr. Sylvain Yuma Kamazani, Director of Medicine of the University of Kinshasa, Democratic Republic of Congo. I have our First Lady, Meseret Zalem, Director of Newborn and Child Health of the Federal Ministry of Ethiopia, who is followed by the Commissioner for Maternal and Child Health, Ajay Kera, of the Ministry of Federal Health and Family Welfare, India. Last but not the least is Felix Vandala, Head of Newborn and Child Health Unit, of Ministry of Health of Tanzania. Good morning again, and thank you for being here.
Good morning.
If I may start with the first question.
Yes, sir.
And would you be kind enough to tell me, in Bangladesh, what successes your country has accomplished in child health, in universal health coverage, and primary health care that might be translated into pneumonia control?
Excellencies, colleagues, and my dear friends, Assalamu alaikum. Bangladesh has made significant progress in reducing child mortality from 133 in 1993, now it is 45 in 2019. There is a strong political commitment towards reaching the targets for pneumonia by 2025. Given a sustained high immunization coverage in Bangladesh, over 95% among 1-year-old children. We have DTP cover 3 coverage is 98%, HIP 3 98%, and PCV 3 it is 97%. We are grateful to WHO, UNICEF, Gavi, Bill Melinda Gates Foundation, and Save the Children, also the ICDDRD, for continuous support of our immunization program. To improve access to basic primary health care for all, Government of Bangladesh has functionalized 13,000 community clinics, which was established by our Honorable Prime Minister, Sheikh Hasina. It is the brainchild of our Prime Minister. Across all 64 districts, and equipped the community clinics for treatment and management of pneumonia at the community level. Additionally, the country has made commendable improvements in exclusive breastfeeding. Now it is more than 62%, and reductions in malnutrition, which overall contributes not only in pneumonia reductions but also towards achieving universal health coverage. We have established 46 SCANU, special care newborn unit, in district levels, and more than 200 kangaroo mother care unit in sub-district levels, also in the district levels. So this is the course. So
Thank you
success.
very much. Interesting. I took note you mentioned breastfeeding. May I ask the same question to our colleague from Côte d'Ivoire?
Merci. En Côte d'Ivoire, les succès au niveau de la pneumonie, nous avons eu une baisse de l'incidence entre 2015 et 2018. Même avec cette baisse d'incidence, le problème reste préoccupant. C'est aussi les résultats des politiques qui ont été menées en Côte d'Ivoire. Nous avons eu à travailler sur essentiellement 2 grandes barrières. La barrière de type géographique pour avoir accès aux soins et la barrière financière. Concernant la barrière financière, l'État de Côte d'Ivoire a, depuis 2012, décrété la gratuité des soins pour les enfants et les femmes, et surtout pour les enfants dans ce cadre-là, avec les médicaments qui sont également gratuits. En termes géographiques, nous avons développé une politique de santé communautaire pour rapprocher les populations des soins. Nous avons un réseau d'agents de santé communautaire, d'environ 15 000 agents de santé communautaire qui ont été formés à la prise en charge globale à la fois des pathologies de l'enfant, mais également de tout ce qu'on peut avoir comme problème de santé au niveau de la communauté. Et ils sont formés, ils sont supervisés par les agents des centres de santé auxquels ils sont rattachés et ils sont motivés. Et tout ceci grâce à nos différents partenaires. Mais également, nous avons eu, au niveau de la lutte contre la pneumonie, un approvisionnement en médicaments relativement important qui permet à la prise en charge à la fois des essais dans les centres de santé. Cette prise en charge est essentiellement basée sur la prise en charge intégrée des maladies de l'enfant et du nouveau-né, avec bien sûr un volet clinique qui concerne un meilleur diagnostic et un meilleur traitement avec les médicaments dont je viens de parler. Mais cela a été fait à travers des formations des agents de santé, de sorte qu'ils puissent reconnaître et faire les bons traitements. Nous avons également, depuis 2014, la vaccination de routine pour la pneumonie, ce qui a permis d'avoir ce type de résultat, car on a une couverture administrative d'environ de plus de 90%. Mais aussi, si nous avons pu avoir ces succès, c'est grâce aussi à l'engagement de nos différents partenaires qui nous accompagnent durant tout ce processus. Donc, même si on a une tendance à la baisse, mais cela reste préoccupant car la pneumonie reste une des premières causes de mortalité des enfants de 0 à 5 ans chez nous. Donc pour nous, certes, on a des succès sur lesquels on va travailler pour avancer, mais cela reste préoccupant. Merci.
Merci beaucoup. Note is also taken on the strengths on access to services, in particular free services for children. I ask the same question to my colleague from DRC.
Oui, merci beaucoup madame. Je crois que pour la RDC, du point de vue stratégique, qu'il faut souligner ici comme succès, c'est essentiellement la volonté politique. La volonté politique avec l'engagement du chef de l'État. Un chef d'État aussitôt investi a pu déclarer pour la première fois officiellement la couverture sanitaire universelle comme priorité de son gouvernement. Ce n'est pas limité là-bas, il a nommé tout un conseiller spécial chargé de la question de la couverture maladie universelle, qui lui a mis en place un mécanisme d'élaboration d'un plan stratégique multisectoriel de la couverture sanitaire universelle en impliquant les différents secteurs du ministère, des autres secteurs au niveau du gouvernement. En plus de ça, le président lui-même préside le forum sur la vaccination pour booster la vaccination de routine. Et il donne les instructions, et ça c'est très important, pour que le budget de l'État puisse doubler pratiquement. Donc on est parti de 4% en 2017 pour qu'en 2020 nous soyons autour de 10%. On est à 9,8 par là. Donc c'est un engagement très fort. Au-delà de ça, au niveau opérationnel, il faut noter aussi que le ministère de la Santé a développé un plan national de développement sanitaire dans la perspective de la couverture sanitaire universelle et qui met l'accent comme priorité la santé de la mère et de l'enfant ainsi que de la nutrition. Et là, on développe même aussi un dossier d'investissement dans le cadre des GFF où on priorise en fait les interventions à haut impact, tenant compte aussi des provinces qui sont prioritaires en termes d'indicateurs qui sont critiques. Alors, il faut souligner aussi qu'on a ajouté certains vaccins, comme par exemple le vaccin contre la pneumonie, le vaccin contre le rotavirus, et ainsi le vaccin contre l'hémophilus influenzae, qui sont en fait des vaccins qui contribuent à la réduction de la mortalité maternelle. Donc, ici, il faut avouer que la RDC a fait de gros efforts ces dernières années, parce que si on regarde les résultats des mix qui sont sortis, mais qui ne sont pas encore publiés officiellement, mais on montre qu'il y a une réduction de autour de 30% de mortalité des enfants de moins de 5 ans. Parce qu'on est parti à peu près autour de 104 en 2013, pour qu'en 2018, on est autour de 70 pour 1000 naissances vivantes. Voilà.
Merci beaucoup. You also placed strong accents on political will, the nomination of an advisor, and the focus on women and child's health. Before I move on to my sister and the next speaker, may I remind the audience that there's an app you can access on the forum platform, and this allows you to ask questions which can be put to the panel in due course. So my sister from DRC, may I ask you the same question? What are your successes?
Ethiopia.
Ethiopia, sorry.
Yeah. Thank you, Chair. Excellencies, ladies and gentlemen, all protocol is observed. It's my honor being here this morning, representing my country, and on behalf of the Federal Minister of Health. And I will just give you a highlight on the success stories of my country, Ethiopia, in particular in health and specifically in child health. So Ethiopia, in terms of the child mortality rates, we have declined. We significantly decreased the child mortality, in particular for under 5, since 2005 to the year 2019. It has been 123. Okay, good. Thank you. The mortality rate in 2005 was. Is there any problem? Okay. Sorry for the inconvenience. The mortality rate in 2005 was 123 per 1,000 live births for under 5, but now very recently we have done the survey and it shows us 55 per 1,000 live births in under 5 since 2019. So this really shows us a significant effort toward this reduction of the child mortality in my country. So we have also a success story. Why we reached to this number is due to the commencement of the primary health care using the health extension program, which is commenced since 2003. So we have so far to date close to 40,000 health extension workers who are really basing in 17,000 health posts, and among them 98% of them are women. So this is also a success story that we have. We have also integrated the child case management at the community level, and we have also we strategize the ICCM and the CBNC. So that's also contextualized for the pastoralist region, because Ethiopia has 3 divisions. When you see based on the geography and the living context, we have the agrarian, pastoralist, and urban. So we try to contextualize the findings so far we have in agrarian to the well contextualized for the pastoralist region. And the other thing is, when we see the coverage of ICCM, it's close to 99%, and since 2013 we have also integrated into ICCM, including this community management, which is being managed by the health extension workers, and since 2013. And we see the coverage in 90% because they use the integrated one, not only for pneumonia, but also for sepsis. And the other success story that we have is the data matters. So we have been rolling out the DHIS2 since 2018. So with this success story, we also included the 8 indicators, 8 instruments in DHIS2. One of the basic elements that we have is those under 5 children treated for pneumonia is being captured every month. So this is also the success story so far that we have. In addition, the commodities are being forecasted in a yearly basis, and the maternal and child health service is free of charge because the government is taking care of it. Because in my country, maternal health and child health is a top agenda, number one agenda, because we are really following the SDG elements as well. And the other thing is, we are also working very well on the One Wash national program, and we reached to 70% reduction of the ODF, because this is a huge contributor for child mortality and morbidity, in particular for pneumonia prevention. And the other thing is the immunization, because immunization really matters. So we follow reaching every district with the aim of reaching every child. So we commence immunization since the last four decades. Now it is a 40-year journey. So it has been started with 6 antigen, now we reach to 12 antigen. So we have a very good coverage of PCV since the last 3 years. So we are really working very hard on the immunization expansion and working on a quality immunization, because immunization and One Wash program and nutrition really matters. And concerning the nutrition, the other element of the success story in my country is we really reduce stunting and wasting from 51% to 37%, which is in particular for stunting, and we reduced the wasting percentage of 12 to 7. So working very hard on multi-sectoral fashion on nutrition, and working very hard on immunization, One Wash national program and the health extension program, and strengthening of the health system. This all contributes for the reduction of preventable child mortality, particularly the childhood pneumonia. Thank you.
Thank you very much. The audience clearly appreciated your focus on how strong integrated community systems are driving your primary health care program for pneumonia, and you also raised the issue of mobile populations, which is important, and data. So on that note, may I go to our commissioner from India, another big country like the DRC, to hear what your successes are.
Yeah, greetings to all of you on behalf of Government of India, and thank you for the opportunity. And I will certainly like to share the excellent story of India, because the good news is that for the first time, the under 5 mortality rate in India is below the global average. As on today, the under 5 mortality in India is around 37 per 1,000 live births, and against the under 5 mortality at the global level is 39. And the good news is that for the last 10 years, the under 5 mortality is consistently showing a significant decline. Another important point which I would like to mention here is, because India is a big country with 1.3 billion population, where 25 million births are happening every year, and the under 5 mortality across the country also varies. You know, there are number of parts of the country where we find under 5 mortality rate to the tune of maybe single digit. There are areas where we find between 10 to 20. So there is a lot of geographical variation across the country. So that's one good news. Now all this good news has been possible by adopting a basic strategy of a primary health care. Strengthening universal primary health care is one of the strategy which is being adopted, which is also one of the strategy which is being talked about if we really want to achieve our sustainable development goals. Looking at the SDG commitments which the Government of India has, Government of India has also come up with the National Health Policy, which was recently released in 2017, and where the kind of the goals which have been set, they are even more ambitious than the Sustainable Development Goals. For example, the SDG says we have to reach 25 under 5 mortality by 2030. Within the India's policy, the ambition is that we want to achieve 23 under 5 mortality by 25. That means in the next 5 years' time, we want to reach to those, committed SDG goals. So that means if we have to reach to those kind of a ambitious goal, something out of box needs to be done. So one of the important approach which is being followed, which I said, is the universal health coverage. There is a lot of investment happening in terms of strengthening the primary healthcare system across the country. We have recently, converted all those, the sub-centers, which are available at a population of around 5,000, they are being converted into the health and wellness centers. I think there's going to be a sea change in terms of the availability of the primary healthcare services near to the homes of the people. Now, not only in terms of, reaching each and every child, there is a concept which we have adopted, that we have been able to identify, we call them the high priority districts. And the Prime Minister has called them as the aspiration district. Those are the districts which are lacking in terms of the indicators. So there is a kind of a targeted attention being paid to those 118 high priority districts. That means in order to reach to each and every child, each and every population in terms of the primary healthcare services. Now the second, the important pillar, which is a success story, that the whole approach of improving the health of children, survival and development rests on the concept of health system improvement. Because beside health system improvement, you can't make a change. Now in terms of health system improvement, we have infusion of manpower. There is a special kind of address being addressed in terms of improving supply chain, a special effort in terms of program monitoring, program reporting. We have a dedicated kind of a RCH portal where every child is tracked in terms of services being provided. So all those the important elements of the health systems are given due attention. And then the third important success story, because we do understand that the 50% of the health outcomes, they are related to the non-health sector, and particularly nutrition. And again, I think in the context of pneumonia, the other sectors are as important, whether in terms of improving the nutrition level of the children, whether through exclusive breastfeeding or right complementary feeding. And then we also have the other sectors, beside this is the kind of indoor pollution. That means the clean air provision is also one of the, and recently the
the government of India has provided to around 80 million the poor families have been provided the clean fuel kind of a system. So I think there are efforts in that direction. And last but not the least, because to my mind, immunization is supposed to be the most cost-effective intervention, or public health intervention, which can be brought to the remotest part of the country. And the government of India has done excellent work in terms of improving the immunization coverage. Because I remember maybe few years back, we were improving by only 1% per year. Now for the last 5 years of intensified mission in the Dhanush program, we have been able to jump our full immunization coverage from 60% to 80%. I think this is excellent, and we have been able to introduce new vaccines, particularly addressing pneumonia. We have been able to, introduce pentavalent vaccine across the country, and the coverages are reaching to the tune of 85%. And we have recently concluded the big measles rubella campaign across the country, reaching to more than 320 million children. I think these are the things which have been introduced. And thirdly, in terms of the pneumococcal vaccine, we have also been able to introduce in the 6 states in some geographical pockets. And now we are very hopeful that we would like to expand pneumococcal vaccine across the country, so as to show a real dramatic change in the overall child survival as well as the development. Thank you very much.
Thank you so much, Commissioner. You've clearly made the case for strong policy and very strong health systems, which are underpinned by investment, prioritization, and a multi-sectorial approach. Thank you very much, and may I hear from our brother from Tanzania?
Thank you very much, Madam Chair. Greetings to all of you. I feel honored to represent my country, talking on behalf of our minister who is not able to make it. Tanzania is an East African country with square kilometers of almost above 0.9 square kilometers, and the population estimate of around 60 million. And it is among the countries reported to have achieved MDG 4 before the time, according to the UN report of the September 2013. And basically, this came due to the good coverage of immunizations, malaria control, IMCI, and the other related interventions. Okay, pertaining the pneumonia, Tanzania, we don't have a vertical program dealing with pneumonia alone, but rather we have this the integrated kind of interventions. And here I just highlight on the component of IMCI, but coming from the integrated packages. One, on the issue of prevention, yes, we do have the very good immunization coverage, around 90%, due to the different strategies like routine immunizations, campaigns, outreach program, and so forth. But also, we have the different packages addressing newborn and child, like essential newborn care, growth monitoring, which address nutrition part of it, including complementary feeding and exclusive breastfeeding. But also we have different programs like WASH programs. We do have this one. But again, on the part of the diagnosis and treatment, what we did, we have the updated packages for the training, the capacity building. We have the IMCI, Integrated Management of Childhood Illnesses, through the distance learning approach. Here we do have the pediatric standard treatment guidelines, which is this one, which also includes the essential newborn care, essential medicine list for children and adolescents. But again, when we completed these packages, we made the capacity building to the safety providers using the IMCI, as I mentioned, IMCI distance learning, so far covering almost 110 counseling out of 183. But again, this we made the availability of the first line, the medicine for treating the pneumonia, of which for Tanzania it is amoxicillin DT, is for the pneumonia non-severe, but for the severe pneumonia, we basically use ampicillin and gentamicin. We first introduced amoxicillin DT, it was 2014, and in 2013, 2016, UNICEF supported the ministry to procure these commodities, and when we had these commodities at the time, we realized that these commodities was lying in medical store department, and this was the time we went through the whole country to advocate about these commodities, meeting with different service providers and other key people that they should start ordering. But within 1 month or 2 months after this advocacy, now we saw this, our stock, that the stock, we had again started experiencing the stock out because now there was a very high created awareness on using these commodities. That's about amoxicillin. But later on, we had the result for development, which at first started procuring, supporting the government, but so currently now it is co-financing between RFOD and the government to make sure that these commodities is available to the health facilities. And again, about the community awareness, yes, we do on every 12th November, which is Pneumonia Day. We have structured simple and clear messages, which usually is being distributed all over the country, at least for the people to know what is pneumonia, how can be prevented, and the importance of the promptly on the early care seeking. Thank you very much.
Thank you very much. And thank you for sharing your experience with training and training guidelines on commodities and procurement, and of course, giving special attention to pneumonia by having a national day. But you already began to allude to the next question, the challenges, because wherever we have successes, we definitely have challenges. So again, I turn to the panel to ask, what are the key bottlenecks that prevent your country to advance in an equitable and a comprehensive manner, a comprehensive approach to pneumonia control and improved child survival? And perhaps I'll start with DRC.
Oui. Ah, ok. Ok, merci beaucoup, madame. Alors, pour la RDC, je crois que les défis ici, il faut le voir en termes de l'offre, de la demande et même de l'environnement global du pays. On signale par exemple qu'au niveau de la couverture des services, cette couverture reste très faible. Il se pose un sérieux problème d'accessibilité géographique. Dans ces pays vastes, il y a des coins où il est difficile d'atteindre. Il faut signaler aussi, par exemple, vous imaginez un enfant qui est en détresse respiratoire et qu'il faut référer à 40 km sans réseau routier, et tout ça, ça pose problème. Aujourd'hui, par exemple, s'il faut parler de la couverture en termes d'oxygène médical, elle n'est qu'à 5% pour le pays. Alors, l'autre défi, c'est aussi tout ce qui est lié aux ruptures de stock de médicaments. Ici, entre autres, c'est aussi lié non seulement aux ressources, mais aussi à un problème de quantification. Et là, on est en train de travailler là-dessus. Je parle par exemple en ce qui concerne l'amoxicilline comprimée dispersible. Alors, il y a un défi important, c'est par rapport au paiement direct, parce que tout ce qui est accessibilité financière, en fait, le paiement direct, avec le poids que supporte le ménage, qui paye en fait les lourds fardeaux, jusqu'au risque de le basculer vers la pauvreté. Et là, c'est aussi un problème réel par rapport à l'accessibilité aux services. Parce que nous sommes dans un pays où il n'y a presque pas de mécanisme de partage des risques qui fassent en sorte que la population puisse payer, pas quand elle est malade, mais payer de façon anticipative à travers des initiatives comme les mutuelles de santé et autres. Et donc, chez nous, les mutuelles, par exemple, la pénétration reste très faible. Il y a le problème général, c'est aussi l'environnement, toute cette situation des épidémies et autres crises que les pays connaissent. C'est un pays où il y a toute une partie avec des conflits armés et il y a cette survenue récurrente des épidémies, tout ça qui font qu'à un moment, l'attention du système de santé est focalisée vers ces crises et fait en sorte que tout ce qui est soins de santé de base, tout ce qui est activité de santé publique de base ne continue pas normalement. L'autre défi, c'est l'insuffisance, parce qu'on parle de la multisectorialité. La multisectorialité ici, on le dit de façon verbale, mais il n'y a pas cette redevabilité de d'autres secteurs en termes de contribution de ces secteurs-là vers la santé. Ça, c'est un problème aussi en termes de redevabilité de la multisectorialité dans le cadre de la collaboration intersectorielle. Alors, il faut signaler aussi l'autre défi, c'est que nous sommes dans un contexte de ressources limitées. Il y a un sérieux problème d'alignement des partenaires, et donc il se pose non seulement de partenaires, mais aussi l'efficience par rapport à l'utilisation des ressources, y compris les ressources gouvernementales. Donc, le peu de ressources financières qu'il y a dans les pays, il y a des gros défis par rapport à l'efficience allocative et l'alignement, bien sûr, des partenaires derrière les vraies priorités du pays, éviter qu'il y ait des doublons par-ci, par-là. Donc ça, c'est encore un défi important. Voilà, madame, ce que je peux relever comme les grands défis par rapport à l'offre, par rapport à la demande et même l'environnement global du pays. Voilà, merci beaucoup.
Merci à vous aussi. We heard from you about difficulty with referral systems, stock out-of-pocket expenditure, limited and effective use of resources, instability and conflict, and lack of multi-sectorial engagement from other sectors. So thank you very much, and perhaps Bangladesh, you share the same challenges as DRC.
Thank you again. In Bangladesh, care seeking for pneumonia from the appropriate skilled and trained service providers is less than 50%, which is the key bottleneck in advancing towards national pneumonia control. Treatment of pneumonia cases in many instances are still occurring through unskilled and informal service providers. And another challenge for Bangladesh is accessing immunization in the fragile context of forcefully displaced Myanmar nationals in Bangladesh. More than 1 million Myanmar nationals are now residing in Bangladesh, where more than 50% of the population are children under the age of 18 and 19% of children under the age of 5 years. Their immunization coverage was too much low. Bangladesh government has, at first they have started the immunization, and we have already started the routine immunization, also the campaign for cholera vaccine, measles, 3 times MR campaign done there, but still the coverage is low. So it's a great challenge for us. And another challenge for Bangladesh is rapid urbanization now. More than 40% people are now residing in the urban areas, and rapid progress of our garments industry or like this. So immunization and access to quality healthcare is a question for urban areas, because the urban area is now the health system of urban area is now covering by our local government. These are the bottlenecks now in Bangladesh.
Thank you for sharing the challenges a host country faces when it has displaced persons within its territory, and also the challenges linked with ensuring that you have enough trained, specialized service providers for pneumonia care. Are there any other countries that would like to share their challenges? Tanzania?
Yeah, thank you very much. I also summarize and highlight the challenges based on 2 areas. One, on preventive measures, and the second, on diagnosis and treatment. Okay, maybe it's easy giving information to the clients coming during antenatal care visit and the other caretaking visit about the nutrition and so forth. But Okay, for example, Tanzania, where almost 70% of the population lives in the rural areas, and now you are addressing about the prevention, like air pollution, that it should go away about air pollution and not use, using the charcoal, wood, and so forth to prevent smoke. And this is kind of the families where the house is not only the place to sleep, but also is used for cooking, is also used for each and everything, and there's also overcrowding or part of it. So addressing that one does not just go as a single message, but it also needs improved economic status to build the other structures to say for that. Otherwise, they have no place to cook, especially when it is raining. They have to do each and everything in a single house. About the diagnosis, unfortunately, yes, we do capacitate our providers that they should, for example, count the respiratory rate before they decide whether this is just a cough or cold, that there's no pneumonia or it is pneumonia, or to look for other signs that is the severe pneumonia. However, we do not have the specific tool, for example, to detect this is pneumonia. That although we are talking about a pulse oximetry, but yet this one is not specific to the pneumonia. This can pick any severe condition apart from pneumonia. That's why even if a study is coming in Tanzania, for example, we insist that we would love to have a gadget which can be not only picking the pulse oximeter, but also counting the respiratory rate to know that which is a cut-off point. Because as someone who is, the child is coming with cough or difficulty breathing, I really need to know whether this is just cough or difficulty breathing, so that I just give a safe limit, or I know this is pneumonia, and then severe I give amoxicillin DT, or to severe pneumonia I put on severe management. So that specific tool we really need, and we think that one will be helpful. Second, on the issue of the treatment, yes, I've mentioned about the support from UNICEF, support from WFOD and the government, but unfortunately, so far we have not reached the maximum stock of amoxicillin DT, which is 9 months, the national stock, and the minimum of 6 months. Always we do oscillation about 1 month to 3 months. So we also suffer from that stock of amoxicillin DT, which is not reaching the maximum we would love. And this community, the sensitization in the community outreach, that including the private pharmacies, the ADO, accredited drug outlets, that's when the advocacy or the awareness of the availability of these commodities is still low. Thank you.
Thank you very much. Before I move to our commissioner from India, you did raise a number of important issues in terms of challenges, and these include managing pneumonia within a traditional and cultural context, because those ways of cooking, etc., are not going to change overnight. So how do we manage pneumonia in that text? The need for innovative diagnostic tools that can reach these communities wherever they are. The sustainability of commodities and other supplies. I'm sure we'll keep hearing about this. And you did mention the private sector and their role in managing pneumonia. So our commissioner from India, can we hear
I'd like to share just 2 or 3 important challenges, because in India we have around 130 million under 5 children, and as per our estimate around 30 million episodes are happening every year. So we need to reach to each and every child in terms of protection, in terms of prevention, in terms of vaccination, or in terms of better nutrition. So that's one big challenge of reaching to 130 million children in the remotest part of the country. That means we need to have primary health care near to the homes of the people. That's a big challenge. And second important challenge is, while providing these primary health care services, particularly in the context of pneumonia, maintaining the skills. Number one is training a large number of workers, primary health care workers, and also maintaining the skills of these workers is also one of the important challenge. And then we will also like to use the maximum use of the available technology, like counting respiratory rate, or trying to understand the oxygen level. There are equipments are available. Bimodal equipment is available, which can help in the counting respiratory rate, which can help in understanding the oxygen level, so that we have a right kind of a diagnosis and right kind of a referral, and a right kind of a antibiotic is provided to the children who are really cases of pneumonia. So that's big challenge which we have in front of us. And the second important challenge is in terms of private sector, particularly in the context of pneumonia. I think private sector is one of the major player. More than 60% of the children with pneumonia, they attend private sector, and unless we improve the capacity, knowledge and skills of those private sector, we won't be able to make a major difference. So I think engaging private sector is another important challenge. And third is, out-of-pocket expenditure. Now, in order to, because out-of-pocket expenditure, and we also find neglect of a girl child because of this out-of-pocket expenditure in some, societies in the country. So that's why the government of India has also come up with that concept of a universal health coverage, which not only, make sure that the delivery is done free, and even the management of a sick child is also provided free care in terms of free transportation, in terms of free diagnostic, in terms of free antibiotics. So those kind of mechanisms are being put in place, and we are quite hopeful with this kind of approach. We should be able to make a major difference. And another last point which I want to mention here is that considering the importance of the pneumonia, the government of India recently launched a big program which is called as the SANS program, that is social awareness and action to successfully neutralize pneumonia. It's a big kind of in a campaign form, where we are doing the capacity building of the healthcare providers, we are creating a demand generation, we are making people to understand the early signs of pneumonia so that they report to the health system at a right point of time. So I think and then continuous monitoring and reporting. I think pneumonia is one kind of a neglected disease where we do not have good systems of managing and monitoring. I was looking at the data sets of India. Out of 30 million episodes, we are just recording 1.4 million episodes. Less than 5% of the pneumonias are being tracked. We don't know in which direction we are going. I think this is another important challenge which we need to keep in mind. Thank you very much.
Thank you very much, dear Commissioner, and for really highlighting the challenge of servicing huge populations. In many parts of the continent of Africa, our populations are rising, so I'm sure there are lessons we can learn from you. But what was particularly interesting was the nexus that you made between tradition, out-of-pocket expenditure, and targeting the girl child who could be at risk of pneumonia. And you also raised the important issue of monitoring and evaluation and follow-up. And I was trying to get from my notes, because I know we have somebody on this panel who has a strong background in monitoring and evaluation. But before we go there, let me hear from our sister.
Okay. Thank you very much once again. It's not a simple business to reduce child mortality with several challenges that we come across. For example, the number one challenge is the disparities. So there are disparities among geographical disparities, and the other is like in urban slum, and there are also social determinant factors which directly affect the child life, like the economy and education. These are the major disparities which still keep going as a challenge in my country. The second challenge is the recurrent drought and disease outbreak, despite the good coverage of the immunization due to different conditions. And the third is multi-sectorial coordination and collaboration is still the challenge. We are just exercising this multi-sectorial nutrition, for example, but still it is very challenging to coordinate. And the other thing is, there are also like the huge problems that we really face is the oxygen limitation. So we are working very hard on the community-based like childhood illness management, but still the problem is at the tertiary level, even at the secondary level, down at the primary, there is still shortage of oxygen. So my country is really demanding support from the global community because we are exercising on oxygen roadmap, but we would like to have an implementation. This is really like finance intense, so we demand, I call for action for anyone who is really interested to support my country in this regard, because every breeze counts, every breeze really matters, it really demands oxygen. And the other challenge that we have is the human resource, because we have 3.1 million surviving infants every year with a growth rate of 2.6%, because Ethiopia is a huge country with population of 100 million. It's not a very simple business to taking care of 3.1 million live births every year. So this really demands a human resource, it demands finance, it demands governance, it demands everything, I could say. So the human resource shortage is another challenge that we really face despite the infrastructure that we are working on it. And the other thing is the weak referral linkage that I do share with my colleague. My brother was raising this issue at the very beginning. So still this is also the challenge that we have. The other thing is the quality service delivery is still the challenge. The other point which we would like to extend this one for the Gavi colleagues is the last mile delivery of immunization is under-financed. So unless we reach to the last mile delivery with a visibility even at the facility level, it's very hard to reach to close to 1.2 million children in Ethiopia is really unvaccinated due to the last mile vaccine delivery is unfinanced. So this is also another call to action to demanding support from the Gavi colleagues. And the other thing is hygiene and sanitation and behavioral change is still the challenge. So I did really mention a few of the challenges that we have despite a good progress that we have. Thank you.
Thank you very much for reminding us that we should not forget that oxygen is an important element of treated cases of pneumonia. And I very quickly turn to our brother from Côte d'Ivoire. We have very little time left, but if you could highlight a challenge or two.
Merci. Rapidement. Le premier défi, c'est la demande et l'utilisation des services. Elle reste faible. Malgré toutes les politiques volontaristes du pays, la demande reste faible. Et également, l'autre problème que nous avons, ou l'autre défi, c'est la disponibilité du médicament au dernier kilomètre. Comment faire pour que le médicament puisse arriver aux bénéficiaires? Nous avons des centrales d'achat qui fonctionnent de plus en plus mieux, nous avons des districts qui ont les médicaments, nous avons même des centres de santé qui ont les médicaments, mais les médicaments n'arrivent pas quelquefois au dernier kilomètre, c'est-à-dire chez le bénéficiaire qui aura besoin de ces amoxicillines-là. Nous avons aussi comme autre défi, c'est l'engagement des partenaires à nos côtés en termes d'alignement ou d'harmonisation sur nos politiques nationales, surtout en matière de santé communautaire, de sorte que les populations puissent avoir accès à certains soins. Mais le grand défi qui pour nous est essentiel, c'est le renforcement du système de santé. Car si le système de santé n'est pas renforcé, toutes les actions de type individuel ou de type vertical ne pourront pas aboutir. Il faut un système de santé qui soit développé, robuste et qui permette que la pneumonie ou toute pathologie puisse être prise en compte. Mais si on a un système de santé qui n'est pas robuste, j'ai bien peur que malgré tous nos efforts, toutes les ressources que nous mettrons dans nos différents programmes verticaux, nous n'arrivons pas à avoir les résultats immédiats. Voici vraiment très rapidement, comme Madame l'a conseillé, les défis que nous pouvons dire au niveau de la Côte d'Ivoire.
Merci beaucoup. Thank you for re-stressing the need for strong health systems and touching on partnerships, the need for strong partnerships. So now I will turn to questions which have come from the audience. We have two questions and perhaps one is a bit of a scolding. So I will read the questions and then we can come to the scolding. Okay. I apologize, my order is wrong. We have a respondent to the panel in the name of Dr. Lindsay. Forgive me, the last name is a bit difficult. But she's a senior consultant pediatrician from Rwanda with more than 10 years experience and shall respond to the issues raised by the panel.
will talk about the quality of care.
Sorry, you have your own question. She will respond, she will tell us what approaches you are taking in Rwanda to improve quality of care in child health services at the community and primary and secondary levels.
Thank you so much. Thank you for inviting Rwanda to be represented in this forum. I can say the quality of care and its success in Rwanda can be summarized in three major determinants, but it's shaped by many things. So the three major determinants are, first of all, the prevention. Secondly, the best clinical practice. And the third is commitment and accountability. So the first, as prevention, the country puts an effort to maintain a high level of coverage of immunization, above 93 for all antigens, including PCV, the pneumonia vaccine at all levels and all children. So another strategy is the community-based health insurance. This is something very, very important in our country because the population can access to care and can have insurance without paying out of their pockets. This is a good experience in Rwanda. So a second determinant is about best clinical practice. So this is really a big achievement for the country, and it's succeeding because it's based on trainings at all levels, from the community, training of community health workers, to the health centers near the population, training of nurses, and to the hospitals. We are training doctors, especially some important courses like ETAT courses, like EMCI, and other very, very strong courses based on evidence-based. So another strategy to improve the quality of care in our hospitals is based on mentorship program. This is a big program for the country, which is supported by UNICEF and the USAID, and is involving all pediatricians in the country through their association in collaboration with the Ministry of Health. Another big program to improve the quality of care in Rwanda is accreditation program. This is a good program to improve the quality of care through the implementation of standard of care in all hospitals. And in some teaching hospitals, we are implementing the international standard of care. Another strategy is accountability. And this accountability is really a big challenge for some countries. And what we are doing in Rwanda is based on two things to increase the accountability of healthcare providers. The first is performance contract. This is the first strategy. The performance contract, which is signed between the government and the hospitals, healthcare providers. Another is community-based financing, which is motivating our staff in hospitals to treat correctly patients, to document all things they are doing. So those are just a summary of what we are doing to improve the quality of care. And I can say we cannot achieve without challenges because we continue to have challenges. We continue to register delays for seeking of care in our country for children. And also, we have a big challenge of insufficiency of oxygen, as my colleagues said. So this is not enough for the whole country. So we would like to expand or to increase the oxygen plant in our hospitals. But also we are lacking we lack really, there is a big challenge of high level intensive care unit for very sick children with specific equipment, CPAP machines, and ventilator machines for very small babies and even children, but also few ambulances to move patients from lower level to higher level where they can be well treated. So this is some challenges we continue to face, and hopefully we can have some support for that, and we continue to sustain our effort, what we achieved already, and hopefully we will have some support. Thank you so much, and enjoy the day.
Thank you very much, Doctor, for providing a response that builds on a lot of the successes and challenges that we heard from the panel. So now I'll turn to you, the audience, and read out the first question. It's a good one because it brings in civil society. And the questionnaire asks, we spoke this morning about the 3 pillars of primary health care. How do you partner with civil society to engage and empower communities? Do we have any member of the panel who would like to answer this question? Commissioner.
Yeah, in the context of civil society, to my mind, wherever the health system doesn't go, civil society really helps. So I think in order to achieve our universal goal of reaching each and every child, I think civil society can play a major role in terms of reaching, particularly the remotest part of the country, the marginalized population, and kind of unreached population because of a variety of reasons. That's number one. And then the second important thing, from my perspective, in the context of pneumonia is, in terms of, community mobilization, demand generation, because to be very frank, large number of the parents or the mothers, they are not aware when to, suspect pneumonia, when to take the child to the doctor. So I think, making people aware, that could be second investment where the community, civil societies could be very well engaged. And third, last but not the least, I again repeat, that is in the context of a private sector. I think private sector is a major player in terms of overall pneumonia, ending deaths due to pneumonia. And if we can engage private sector through the window of civil society, that can also really make a change. So these are the 3, I think, priorities which can be put on place. Thank you.
Do we have another respondent to this question?
Thank you so much. In Ethiopia, we are also realizing the effort of civil society, but even very recently, we would like to expand this civil society collaboration with the government, because we have lots of success story, in particular in the immunization program, particularly in the demand generation, advocacy, and the like. It really helped us a lot. So we want to scale up this issue to the specific program, specifically in pneumonia. So now we realize not only the civil society, but also the private partnership is very important, and the engagement and involvement of the academia and the research institutes are also very important, because it's not only the government who will definitely bringing a result, but the coordination effort and the collaboration between the government partners, academia, civil society, and the other institutes, and including the empowerment and engagement of the community. Thank you.
Do we have another take?
Oui, peut-être pour ajouter aussi, c'est que, comme on l'a dit, la société civile reste une partie prenante importante, parce qu'on parle de la prévention, il s'agit par exemple de tout ce qui est bonne pratique familiale essentielle en matière de la santé. C'est la société civile qui peut favoriser, par exemple ici nous parlons de la pneumonie, faire en sorte qu'au niveau de la communauté, qu'on identifie des enfants qui ont des problèmes et qu'on peut les référer au niveau de l'hôpital. Voilà. Et donc ça, je pense que ça reste une composante importante avec laquelle il faut travailler pour pouvoir améliorer la référence à temps et même la prise en charge éventuellement. Aussi, il y a le problème de la redevabilité des prestataires de soins vis-à-vis de la communauté. C'est la société civile qui peut favoriser cette redevabilité de sorte que les prestataires sachent qu'ils sont en train de travailler pour la communauté et non pour eux-mêmes en termes d'amélioration de la qualité des soins et même la prise en charge de façon globale des enfants. Voilà. Merci.
I'll take one more and then we move to the next question.
Merci. Je pense également que pour la société civile, elle est importante. En Côte d'Ivoire, nous travaillons avec la société civile car où nous sommes, quand nous travaillons, il y a des endroits où nous ne pouvons pas avoir accès pour des raisons multiples. Et la société civile est notre relais dans ces zones-là. C'est pour cela qu'essentiellement nous travaillons avec eux pour résoudre plusieurs problèmes, notamment dans le cas de la pneumonie ou de la prise en charge des enfants, mais également de manière plus globale. La société civile en Côte d'Ivoire est un acteur essentiel pour faire en sorte que les soins arrivent aux personnes les plus démunies et les personnes qui en ont le plus besoin. C'est le point que je voulais ajouter.
Okay, merci. The next question from the audience is, what approaches is your government using to address subnational inequities in prevention and treatment? And there's an example here, particularly for the urban poor and gender-based care seeking. Please,
Yeah. Because in the context of India, one of the strategy which I made a reference to was something called as the aspiration district approach. That out of 700 odd districts in the country, we have been able to identify 100 odd districts which needs priority attention. So that's one approach in order to address the equity. And in terms of gender kind of inequities which are observed, that's why the government of India came up with a clear approach in terms of providing free care to the sick child up to 5 years of age, whether in terms of transporting them to the hospital or providing them free dose of antibiotics or providing maybe free food and everything in the hospital. So these are the two things which are being addressed optimally and adequately, and we are hopeful that if we continue to invest in this way, we should be able to reach our goal of ending preventable deaths due to pneumonia.
Do we have any other takeout for this question? Yes?
Yes, thank you very much. In Tanzania, one is that free policy to under fives seeking care to the health facility. That is the free to all under fives. And the second is this make sure that the guideline is available in all health facilities for the differences. But again, the commodities through the medical service department, they are being distributed in all public health facilities. But for private sector, we have to advocate for them to procure from the wholesalers.
Okay. Perhaps I can move to the third question, which is a bit of a telling off. You all rightly talked about comprehensive integrated services, yet we are here talking about one disease. What do you want the global community to do to promote primary health care? What is your number one ask to the global community? So this is your moment in time. Yeah. Ethiopia took the lead in asking for oxygen. Any other requests? Anyone? Commissioner?
To my mind, I think if the ask to the global community will be, because somehow for pneumonia, we are talking about only mortality. I think it's high time that we must continue our advocacy, not only that pneumonia management and control is going to help the child survival, it is also going to help in improving the so-called the Thrive agenda of the SDG. We are now in the midst of the SDG and we have not spoken about Thrive. We are just talking about survive and survive. And pneumonia management, pneumonia control not only addresses the survive component, it will also address the overall child development. It will also address undernutrition, because both are quite interlinked. So my ask is that we must continue to do this advocacy around pneumonia, keeping morbidity also as one of the important parameters.
Thank you very much.
Merci. Ce que nous demandons, c'est vraiment, je l'ai dit, c'est le renforcement des systèmes de santé. C'est vrai qu'aujourd'hui, on parle de la pneumonie. Mais si nous ne renforçons pas nos systèmes de santé, nous allons avoir plusieurs réunions de ce type, à la fois sur la pneumonie, après sur une autre pathologie, après sur une troisième pathologie. Il faut qu'on renforce les systèmes de santé pour qu'ils soient plus robustes. Et si nos systèmes de santé sont robustes, les problèmes, j'ose dire, d'oxygène, de médicaments, tout cela seront réglés dans un système de santé robuste. Il faut que tous nos partenaires nous appuient dans le sens de nos différentes politiques nationales, qui nous appuient dans le sens de renforcer notre système pour le rendre robuste et résilient, être capable de répondre à nos épidémies, mais également être capable de répondre à des besoins comme la pneumonie ou comme d'autres pathologies. L'essentiel, c'est que si on veut atteindre la politique sanitaire universelle, c'est l'élément clé sur le renforcement des systèmes de santé, avec bien sûr la prise en compte du paiement à l'acte ou faire en sorte que le patient qui arrive à l'hôpital ne sont pas dans la pauvreté, faire en sorte que la prévention soit développée, mais faire en sorte aussi qu'on ait les établissements de santé sanitaire de qualité à tous les niveaux de la pyramide. C'est tous ces éléments-là ensemble qui vont nous permettre à la fois de réduire tous nos problèmes de pathologie, mais également de faire en sorte que le système soit plus robuste pour éviter que les ressources mises à disposition pour le ministère de la Santé partent dans des épidémies et que des problèmes de santé puissent persister. Donc mon point essentiel, c'est qu'on puisse renforcer vraiment les systèmes de santé de manière plus durable. Merci.
Merci beaucoup. RDC.
Voilà. Merci beaucoup. Pour la RDC, je vais dire deux choses. La première des choses, c'est que nous sommes en train de travailler parce que notre pays bénéficie beaucoup de financements dans le cadre des humanitaires, dans le cadre des épidémies. C'est de faire en sorte comment tous ces appuis et tous ces financements énormes puissent bénéficier au pays en termes de renforcement des systèmes. Parce que c'est parce qu'il y a des systèmes qui sont faibles qu'il y a cette résurgence des épidémies et autres. Donc, on est en train de travailler là-dessus pour voir chaque fois qu'il y a une épidémie comme celle qu'on est en train de connaître maintenant, épidémie d'Ebola, il y a la rougeole ou autre, tous ces appuis qui viennent, comment profiter de ces investissements pour renforcer les systèmes. Ça, c'est une chose. Deuxième chose, c'est tous ces financements verticaux. Ça, j'en appelle à tous les partenaires au niveau mondial parce qu'on a des gros financements verticaux pour certaines maladies. C'est de solliciter la flexibilité de ces financements pour les shifter vers des interventions comme la pneumonie. Parce que par moment, on a des investissements qu'on est obligé de les reprogrammer pour les mêmes maladies, alors qu'il y a des gaps. Par exemple, on manque de l'oxygène, mais ils vous disent que non, nous avons apporté des financements. Pour le VIH, on ne peut pas shifter ces financements vers une autre pathologie. Et ça, quand vous parlez avec les gens qui mettent en œuvre au niveau local, ils disent nos managements ne nous les permettent pas. Alors, c'est l'occasion, parce que tous les managements sont ici, c'est solliciter cette flexibilité, de sorte que ce financement puisse profiter là où il y a des vrais gaps exprimés par les pays. Voilà.
Merci beaucoup.
Yes, please. Thank you. Though we are thinking about the pneumonia or global pneumonia forum, in this forum we are talking about pneumonia, but we have to think about all the immunization probabilities. And I want to say that Bangladesh is now in a transitional phase, going to the middle income countries. And they will have to think about it. The government has successfully developed a national Gavi transition strategy, which is costed and integrated in the operational plans of the Bangladesh Health Sector Development Program. So we are also thinking about this. Thank you.
Well, distinguished guests, participants, the case has been made. Pneumonia is the entry point for an integrated, multi-sectorial primary health care system, which is community-focused. You've heard from the experts. They have advocated with you. I hope we would all go out there and sign the declaration that is upcoming. Please join me in giving them a warm round of applause.
Okay. Thank you very much. That was a great first town hall. Thank you all for contributing. By the way, Even though you listened to 3 questions, those were distilled from 11. So that's our mark. For the next town hall, which is right after lunch, please let's go above 11 questions. If you haven't, install now the web app. Now, lunchtime. You will find it right outside the auditorium, courtesy of Cosmocasha. Thank you, Cosmocasha. Should you need one, there are halal, kosher, veggie, and vegan options. Please take a minute of your time, if you haven't done so already, to take a look at the Forum Declaration and perhaps sign it physically. Let's convene back here at 13:55. That's 1:55 p.m. Shall we? Enjoy your meal. Buen provecho, bon profit. as a data point, Nigerian youth will number about 140 million. That's only India and China will have more young people, and we all share a stake in the future of these youth. We begin the afternoon with a keynote address by the Nigerian Minister of State for Health. But first, let's wait a couple more minutes. Let's let a very special guest introduce him. Shall we? Look at the video.
Fighting in the northeast of Nigeria has forced families to flee for their lives and left children like Usman battling to survive.
Banya harbe shi mun tashi mun daga wannan din mun tashi da shi mun tafi da shi can ruwan gaba mun ba shi jarka shiga ruwa to muna jiran ya tsallaka ne ashe shi Allah masa cikawa cikin ruwa.
Many of the families I'm about to meet have had to make journeys like this. Dr. Noor runs the medical center and he knows the problems they are facing today.
Malnutrition, diseases, poverty, illiteracy. All these problems, you can relate them with this conflict. Our work is between life and death.
It's amazing to see firsthand the difference Dr. Noor's team are making. Centers like this across Nigeria are vital to make sure every child gets the right nutrition they need to recover and grow. But the scars of conflict run deep. Children need more than medicine to help rebuild their lives.
Heart program means healing and learning through art. This program is a form of psychosocial sport which we are doing in child-friendly space.
It's so important that children have a space where they can finally be themselves and are able to dream of their future. When you ask them what they want, they all say the same thing, an education, so they can be somebody and look after their family when they grow up. And that's the same answer you'll get from children all across Nigeria. It breaks my heart to know that today, 13 million children are missing out on school completely in our country. I want every child to have the best chance in life and to become who they want to be. Please join me in supporting the work Save the Children is doing across Nigeria today. Good afternoon, ladies and gentlemen. My name is Florence Otedola, also known as Cuppy. Despite being an international DJ, a different cause brings me to this stage. At 26, I am proud to be speaking today as an African, a Nigerian, and an ambassador for Save the Children. Also, a member of the African Advisory Board and founder of the Cuppy Foundation. The video you just saw captures my recent visit to Maiduguri, known as one of the most dangerous cities in Nigeria, where I had the chance to witness the courageous work that Save the Children does as they fight to keep children healthy and thriving. This trip truly changed my life. For several years, I have committed my passion, time, and resources to supporting the most vulnerable children in my country. Education has been my priority until I met some of those children who could barely breathe, talk less of read a book. Let's just say I have not been the same since that visit. Upon my arrival to the Save the Children Stabilization Center in Maiduguri, the first child I met was 2 years old, but she was the size of a 6-month-old baby. The child was so ill that a blood transfusion was urgently needed. And I tell you, bed after bed, I met more and more sick children gasping for breath because of pneumonia. In the corner, I encountered a 16-year-old mother who was malnourished, and her baby was acutely malnourished as well. This was so heartbreaking because I was seeing the lucky ones who had made it to the stabilization center. The doctors told me that their chances of survival had increased. But what about those that were dying? What about those that couldn't make it to the center? Most of you sitting here already know that a malnourished child is 9 times more likely to suffer from pneumonia. There are thousands more that cannot make it to health centers and die. You already know that pneumonia is the single biggest infectious killer of children in the world. It claims over 800,000 lives annually. And yet this disease, for whatever reason, is neglected nationally and globally. In my country, Nigeria, pneumonia kills more children than any other cause. That is 160,000 precious souls each year. These children have young, ambitious dreams. They are girls such as myself who could be the next international DJ. We all know that these deaths are preventable, so please tell me why the world is not doing more to address this disease. By 2023, pneumonia will kill 1 million more children unless we act now. I really hope through this forum we can come up with concrete steps to do more and to do better. I am proud that the Copy Foundation is collaborating with Save the Children to raise funds to provide solutions that will ensure that no child in my country, Nigeria, dies from pneumonia moving forward. My plea to every single person sitting here today is that we all come together to play our part in ensuring that the numbers of children suffering from this disease goes down. In the next 3 days, I am open to having conversations with every single one of you present to see what we can do. Together, we are stronger. And now it is my pleasure to introduce to you Senator Dr. Adeleke Olorunigbe Mamora, my country, Nigeria's Minister of State for Health, to give today's keynote address. As a proud Nigerian, I'm particularly pleased to see our government is showing leadership against this fight for pneumonia. Honorable Minister, I thank you, and we welcome you, and we all look forward to your remarks. Gracias.
Thank you very much, Kupi. I'm happy to be here, and good afternoon to you all. I am Dr. Adeleke Olorunigbe Mamora, Minister of State for Health of the Federal Republic of Nigeria. My colleague, the Minister of Health, Dr. Osage Ehanire, regrettably had to cancel attendance of this meeting at the last instance due to highly pressing needs that demanded his presence back home, and I am to apologize for his absence. Our country, Nigeria, is the 7th most populous country in the world, with about 200 million people and a corresponding burden of public health challenges. I wish to thank the Every Breath Counts Coalition and all the co-organizers of this global forum on childhood pneumonia for setting up this very important event, and also for the opportunity I have to give this keynote address. Pneumonia is notoriously the world's leading infectious disease, a killer of children in low and middle-income countries. And this is despite being quite preventable and treatable. It claims the lives of over 800,000 children under the age of 5 annually, a staggering figure to contemplate given available proven intervention options, a figure translating to 2,000 lives daily accruing to a single disease entity, and a testimony to how far we still have to go to build delivery systems that make universal health care available, accessible, and affordable to vulnerable groups, especially children. The target of reducing pneumonia-related under 5 deaths to less than 3 per 1,000 live births by 2025, set by WHO and UNICEF in the Integrated Global Action Plan for Pneumonia and Diarrhea, will be an illusion if concerted and proactive steps are not taken to reverse current trends. We are moving closer to the end of the SDG era, and yet far from meeting the SDG 3 child mortality target of less than 25 deaths per 1,000 live births. Failure of our collective effort will represent violation of children's right to survival and development as enshrined in the United Nations Convention on the Rights of the Child. Relative to other infectious diseases, progress in reducing pneumonia-related deaths lags significantly behind. Available evidence shows that the 54% reduction achieved in pneumonia-related mortality among under 5 children in the period from 2000 to 2018 compared poorly with 67% and 81% obtained for HIV and measles, respectively, indicating that pneumonia control may in fact have fallen between the cracks in global and national health agendas. Unfortunately, and not surprisingly, the main burden of pneumonia is concentrated in the world's poorest countries, with children in the most deprived and marginalized settings suffering the most. A child in a poor family living in a low or middle income country is therefore twice as likely to die before his 5th birthday compared to a child from a wealthy family, because the socioeconomic and environmental determinants of health weigh heavily against him, particularly in the areas of poor access to clean air and water, poor hygiene, sanitation, and health services, poor nutritional status, and co-infection with other disease entities. It is such a scenario that Nigeria is working to get out of. Out of our nearly 200 million population, under 5 children are about 35 million. The background to this high value being an estimated 40 million women in the reproductive age group, a low contraceptive prevalence rate, and attendant high total fertility rate of 5.5 children per woman. With 2.4% of global population, Nigeria contributes 10% to under 5 mortality, the vast majority being caused by malaria, pneumonia, and diarrhea. These common diseases are of great concern to the government, and bold steps are being taken to address them. Regarding the pneumonia component of the burden, the government of Nigeria has taken innovative initiatives in line with the protect, prevent, diagnose, and treat strategies of pneumonia control. Only recently, the President of the Republic issued an executive order to prohibit open defecation in support of environmental sanitation of communities and ultimately children's health. Other preventive measures are the scale-up of nationwide vaccination coverage in the National Immunization Schedule, in particular pentavalent vaccine, the campaign for exclusive breastfeeding practice in the first 6 months of a child's life, which is yielding desired result with a compliance increase from 18% to 25%. In order to ensure proper diagnosis and prompt treatment of children, Nigeria is scaling up its integrated management of childhood illnesses and integrated community case management of childhood illness, which contribute to significantly reduce child mortality. Amoxicillin dispersible tablet has been included in the essential medicines list for use at all levels of care to strengthen the healthcare delivery system as a side benefit of domestic demand for healthcare products such as amoxicillin dispersible tablet, low osmolar oral rehydration salt, and zinc discernible tablets. The enabling environment for domestic manufacturing is created too. At least 4 pharmaceutical companies are benefiting from producing locally. In addition, government partners with relevant agents to facilitate easy access to medical oxygen in health facilities. Moving towards 2030, the need to achieve Sustainable Development Goal 3, targets of reducing under 5 mortality to less than 25 per 1,000 live births by 2030, stares us in the face. Pneumonia control needs to be given requisite attention as a major contributor to under 5 deaths. Against this backdrop, the Federal Ministry of Health, in collaboration with Every Breath Counts Coalition, faith-based and civil society organizations, private sector partners, health regulatory bodies, and community leaders had interministerial cross-sectoral consultative meetings where barriers to pneumonia control in Nigeria were examined, and such efforts as needed to meet pneumonia-related childhood mortality reduction targets were articulated to develop the first edition of our National Pneumonia Control Strategy and Implementation Plan. The strategy was launched on 23rd January 2020 in Abuja, Nigeria. And of course, I have the pleasure and the honor to present that strategy to this audience. Thank you very much. And to the best of my knowledge, This is the first of its type in the entire world history. We intend to work with the EBC coalition, that is Every Breath Counts coalition, state governments, and all stakeholders to disseminate the document across the country in the coming weeks. Specifically, this strategy and implementation plan highlight equity, quality, and evidence-based integrated interventions focusing on effective pneumonia control, and also provides concrete priorities and recommendations, as well as coordination and accountability frameworks for its implementation by government and partners. It includes such details as financing, service delivery, monitoring, and supervision, as well as target indicators, among others. To ensure its financing within other child health interventions, the second National Strategic Health Development Plan is detailed with all identified high-impact child survival interventions captured in the integrated reproductive, maternal, newborn, child, and adolescent health plus nutrition strategy. It is rooted in the 2016 National Health Policy, which recognizes Nigeria's aspiration to universal health coverage with one functional primary health clinic per each political ward. It also considers the expansion of prepayment social health insurance schemes for universal health coverage, the unfinished business of the Millennium Development Goals, Sustainable Development Goals, and the Global Post-2015 Development Agenda. The plan also aligns with Economic Recovery and Growth Plan 2017 to 2020 and the National Vision 2020 of the Federal Government of Nigeria. Partnership among critical line ministries will be strengthened, like agriculture, energy, women and social development, and environment, crucial to supporting vaccination coverage, nutrition, household air pollution reduction, strengthening referral systems, access to essential medicines, and so on and so forth. It is on this note that I call on the champions for the cause of healthy living for children to support efforts by government in different countries, including Nigeria, to continue to save children's lives and impact on the trajectory of child health outcomes. Furthermore, government has embarked on campaign and allocation of resources for modern contraceptive to raise the contraceptive prevalent rate by 30% of the current level. Distinguished ladies and gentlemen, while joining my voice with yours to make the declaration that every breath counts, I implore you to back it up with actions that will ensure that every child lives. Thank you for your kind attention.
Thank you, Minister, and thank you, Ms. Otezola, or DJ Kapi, as you're known and loved. By the way, we are looking forward to hear more from you tomorrow. Just keep that in mind. Before we move on to session 3, For those who want to make use of it, we will have a prayer room available. If you want more information, please reach out to me in the next break or reach out for the volunteers. Now, session 3, we're going to discuss the role of primary healthcare. This is a session in which I presume you want to ask questions, so let's use our technology again, the web app. Remember, it will appear here. Using that QR code, you can download the web app, register there, and selecting the session and going to the bottom of that session, you will find the button to ask a question. I remind you, 11 questions were our mark, our previous mark. Let's go above that. We'll distill them and then pass them on to our moderator. And speaking of moderators, please welcome to the stage Gitinji Gitahi from AMREF to set the scene for us. He will be later joined by representatives from China, Malawi, Mali, Mongolia, South Sudan, Zimbabwe, Pakistan, and the World Health Organization. Thank you.
Well, I'll ask my panelists to come on board. Good afternoon, Barcelona. Good afternoon, Barcelona. Thank you. Thank you. You know, I saw in some of the documents that were written for this meeting that pneumonia is called the cause without champions. So we must show that we are the champions here today. I don't know how many civil society people are in this meeting. Yeah, civil society, raise up your hands. Oh, thank you. Yeah, please, you may take your seats. Thank you for being here, because, you know, sometimes I'm also civil society. Yeah, so I raise my hand up. You know, sometimes government is so proper that civil society gets intimidated. Simon, yeah? So let's not get intimidated by the properness and make sure that we ask the questions. I would like to introduce my panelists here. With me, I have, where's Jappy? Yes, let me start with no particular order. Maria from WHO. We have Luca from South Sudan. We have Jappy, Minister of Health, Malawi. We have Professor An from China CDC. We have Amar, State Secretary, Mongolia. We have Sidibe, who many of us know very well. And on that side is my colleague Itai Rusike from Zimbabwe. What we are going to do today on this session, I've really enjoyed the previous sessions, is to try and start to look at the role of primary health care for control of pneumonia. And I would like us to reflect on 3 things. One, reflect on the fact that in 2019, the world leaders made, and many of us and all of us, made a commitment to achieve universal health coverage. Health for all without financial difficulty. The second thing I want us to reflect on is that primary health care is a strategic investment for universal health coverage. It is the most important strategic investment for universal health coverage, and we revisited that in Astana. Many of you are there. The third thing I want us to reflect on is the fact that primary health care is indeed not a health system issue. Many of the issues in primary health care, as you'll see shortly, are beyond the health sector. And how does that work on the multi-sector approach? So what I would like to do is, in the morning, many of you who are here might have seen what was presented by Stefan, which is the pneumonia wheel, and also the concept of primary health care. That is what he talked about. I will not reflect a lot on this, but just to say that you have primary health care with the 3 legs: integrated health services, which is really a health system issue. Then you have multi-sectoral policy and action, air quality, nutrition, which many of these are beyond the health sector issue. And then you have empowered people and communities. We're talking about education of women, we're talking about engagement of communities, and we're talking about accountability. So all these things affect the outcomes of pneumonia. All these things affect our investments into reducing pneumonia mortality, but many of them are not in the health sector. So we are going to be discussing that, and what the organizers of this meeting have done is to take that framework of protect and prevent, diagnose and treat, and said, how is this working across many of the countries we have? And we have then taken 30 high-burden countries, looked at indicators around each of these areas I've talked about, consolidated them into what they're calling the pneumonia wheel. The best outcome would be when that wheel is full of color. That would be the best outcome, where the wheel is full of color and there is no white or gray area. So basically, if you look at this, and you can compare this wheel with high-income countries, because they are significantly different, and you'll probably have a chance to look at that. But you will see that if you look at this side, which we talked about is integrated health services, we have data on immunization, thanks to Gavi and to the government and to the people. We have very high, we have significantly high coverage of the, influenza. And then down here, PCV, which is relatively later, we have about 50% coverage. And this is aggregate in the high-burden countries. And when you look at care seeking, which is actually, as I'll show you, the only thing that governments have really been measuring on pneumonia, and not only the government, even WHO, in the UHC index, we are not doing too well. We could do better. That's care seeking. Basically, how many kids were suspected to have pneumonia and actually sought care. And the problem with that is that most of the ones who didn't seek care, we don't know unless you do a demographic health survey, which in many governments that we are dealing with here will do that every so often, 10 years, 5 years, and some, I don't know, maybe the ministers will tell us the last time they did a demographic health survey in their country. So there's a big challenge about that particular indicator there. Then on this side, you look at availability of amoxicillin, DT, and you look at availability of oxygen. Absolutely no data. And yet it's so critical, as you've heard from everyone, how important it is in care delivery for pneumonia. Then we have some information on air quality. I'm sure Maria will talk a bit about that. And I was making fun with Stefan yesterday because her name is Maria Purification as well. So she'll be purifying the air for us today. And we'll be discussing that. And then on this side is stunting, which we have data on stunting and absence of stunting. This side is accountability, social accountability, no measure, which is why I was calling out civil society, because if we don't have data to make people answerable, then how do we do it? Even for government, if we don't have data about what's going on, how do we hold ourselves accountable? So there's a big hole there. But then we have, women's engagement in decision making. We use, UN statistics. And then you have female completion of secondary school. So if you look at that wheel, we are far from filling it, which is then explains why our pneumonia mortality is so high at 800,000 per year. So what we are going to be doing is exploring these three areas with my lovely panel here. We have the largest panel at this forum, I think. We have 7 panelists, and we have a respondent who is going to be joining us. So our respondent is going to be joining us later, is Jai Krishin from Pakistan Institute of Medical Services. So please welcome my panel here with a big round of applause to make them feel well. Thank you. Thank you very, very much. And you've seen the pneumonia wheel, presented it here, presented in the morning, it was shared with you. Useful, practical, does it work, doesn't it work? How, what is being left out, what is working, what is not working, and what reflections do you have on the pneumonia wheel? This question, I'd just like responses from every panelist. So let me start with you, Maria, and then we'll move on like that. Then we'll get to the next set of questions.
Thank you, Chair, and thanks for nominating me the purificator.
Chair of purification.
Thank you very much.
Thank you. Yes.
Yes, I used to be the pollution terminator, but now I'm happy to be the purificator.
Thank you. Thank you very much.
Thank you very much. It's a good progression, because when I started in WHO, because I was dealing with diarrheal diseases, I used to be the fecal point. So it's a good progression.
You're making progress.
Yes.
Yeah.
Don't put that in Twitter, okay?
Simon already did.
Anyway, let me start with that. My first reflection. First of all, primary healthcare is not just about treatment. I know that what I am saying is so obvious, but it's not every day. We still have healthcare facilities without access to safe water, and of course without all of those services that for us is absolutely fundamental. In that sense, I'm extremely pleased that you have included very visible and as a terribly important and critically important risk factor, air pollution. We are having today, and I'm sure you are familiar with the work of WHO that our department is trying to do on air pollution and health. We have 7 million premature deaths every year caused by air pollution, and the children are not escaping to that. We have almost 600 children less than 5 years old that are dying because of indoor or outdoor air pollution. So therefore, it's a risk factor that we need to address. We have a global platform on air quality and health data that we are offering to you. I think this is a great opportunity to join forces. The only way we have to reduce pneumonia mortality is pushing a little bit more on addressing those risk factors. Oh, of course, we need to ensure many things in many fronts, but I think this issue of addressing air pollution is a critical one. We have 93% of our children today breathing air that is not respecting the recommended WHO standards on air quality. Therefore, you might treat a child with pneumonia today, but you are sending it back home where is with mom inside at indoor, where they are probably using an open fire to cook or to heat or to light a house, and they are breathing that pollution that is generated in the place where the child should be supposed to be very much protected. So for me, what I'm very pleased to be here today with you is to join forces, to tell you that the air pollution community, the one working on climate change and air pollution, is ready to join forces. We have many networks, we have the platforms, we have the data, we have other actors, we work with the energy sectors, and we are very keen on joining forces and demonstrating, quantifying that if you increase access to clean fuels at the household level, which is one of our big initiatives now, we are trying to push governments and stakeholders on increasing access to clean fuels at the household level. It's not just to the cooking and clean cooking, it's the way you cook, you heat, and you light your house. Because you might have a very clean cooking, but then nest in the floor, this open fire where you have these pollutants that are coming to your lungs. The baby normally is in the back of the mom, so both are having very serious problems, including obviously pneumonia and all of that. So Chair, I can keep for hours if you allow me to keep purificating, but I will stop here on telling you that this is really the way to address all of those environmental risk factors to contribute to reduce pneumonia. This can be very visible. Of course, if we reduce air pollution, the benefits will not only be on pneumonia, there will be many other diseases that will be benefiting, including the child neurodevelopment. But I think pneumonia can be a very visible way to quantify the importance of this collaboration between the two sectors. We are working on a very multi-sectorial way. You have a lot of focus on the health sector, so by joining forces, I think we can multiply very much and maximize the results. So very, very happy to have this opportunity to be here with you. We have plenty of networks that we can put at your disposal to maximize, as I say, and our intention is just to before the World Health Assembly this year in May, we want to be joined by a big alliance of groups working on air pollution and climate change, which again, I think pneumonia can be one of the most important beneficiaries of all of this work.
Okay,
Thank
great.
you.
Thank you so much. And I know you're going to be jumping off the stage at some point to run off for another engagement and come back. We'll allow you, okay? We are very kind people. But before you go, very quick question. The issue you're talking about is behavior change as well and lifestyle changes. And you talked about you're working with government. But governments don't make households change behavior. It's the households themselves that change behavior. Within the strategy of changing the kind of cooking energy, is there a strategy which is within that will? Community participation, which is up there, women's engagement in household decision making, is this integrated into this decision making, into this plan?
Absolutely. This is one of the critical parts. I mean, when we talk about increasing access to clean fuels at the household level, one of the barriers, I will say, is this behavioral change. But in order to change the behavior, you need to have as well the technologies available. I don't think any woman, or I say woman because by chance They are the ones at home. I mean, I'm not saying that you are not working at home, but did I say that? No, I didn't. But, you know, they are the girls, the ones that are collecting wood or collecting something. This is in exchange of the purification.
I'm the chair here, I thought. Okay, just continue.
The girls working at home, they are spending hours on collecting wood and all of that. So they are the first one that they can benefit enormously. Because if they don't need to collect the wood or something to put on the fire, they will save 3 hours a day that they can go to school. And that will generate an incredible benefit as well in terms of education and gender. I don't know any woman that will refuse if you can say, listen, instead of spending 3 hours collecting wood, then making the fire, then cooking for hours, you can do click, and then having a fire or having gas, LPG, and then, it will take very little. But of course, you need to work on the behavioral change, but making sure the technologies are cheap, available, and easy to get.
Thank you.
And then the community change is going to happen.
Thank you very much. So, thank you for that perspective. And I will come to you, Luca, from South Sudan, looking at this wheel, looking at where you are. Luca was the Minister of Health in South Sudan for a very, very long time. He's been in the health industry for a long time. So looking at the construct of the health system and how the health system works, is this wheel practical, really?
Thank you very much, Mr. Chairman, or moderator, or chairperson.
Or MC.
I'm happy to be in this forum. I'm happy to be in this forum. You know that South Sudan is 7 years old as a country. We used to be part of Sudan. And when I left my country in 1983 to join the rebellion, I left a system of health care where it was possible for me to identify a healthcare system where you can fit and train and equip according to system. When I returned to my country in 2007, I found that it was all Ministry of Projects, which completely destroyed primary health care. Because the most ideal structure to address the issue of pneumonia in my experience, and I practiced primary health care for 20 years, and I've been in policy for 10 years, and I'm always missing the 20 years I spent in primary health care. Primary health care addresses in a systematic way all the issues we are trying to put in a will. Let me just pin myself. Most of you know the definition of primary health care. And the basic element of it was that it is essential, integrated, socially acceptable, accessible, and affordable care for communities and families with their active participation. The elements of primary health care all concern pneumonia. The first is communication, behavior change communication, which my colleague just talked about. The second is nutrition, and we know that 50 or 60% of malnourished children are likely to develop pneumonia. This immunization, and you know that the lack of PCV and other vaccines, even the lack of measles vaccine, and the child gets measles, is likely to develop pneumonia. Family, MCH, mother and child health, and you know that pneumonia kills highest in the first 2 years of life, 80% so the good delivery, good prenatal, good delivery, and good neonatal care is very essential. And you know that water and sanitation are part of the project of, you know that control of endemic diseases and epidemics, like measles and whatever outbreaks. And you know that the treatment of common diseases in primary health care, the most common diseases which we think can be treated at community level, the three most important, as you know, is pneumonia, it's malaria, it's diarrhea. And I think the first years of primary health care, when it was launched in 1978, many countries set up community health workers training program to teach how in the village setting, which was the dispensary, this can be taken care of. And finally, number 8, the provision of essential drugs. which, of course, you cannot provide, you cannot treat common illnesses without drugs. Health, whatever you like, always turns around an exchange of products, whether it's advice or chemicals or injection. A healthcare without some product is not successful. These elements, in my country, South Sudan, I hope it is not in your countries, but that was the impression I got when of the panel this morning. These elements have become projects. I was in an area about 200 miles east of the capital, Juba, asked by the Save the Children Fund to assess the pneumonia situation in that state, you know, and they had 4 partners by that Human International Organization or whatever you call them. And they were working in prime health care, and none of them was providing essential drugs. And another one was providing vaccination. And they were very sure that they are working in primary health care. Well, they are not working in primary health care. So that issue was addressed this morning, I think, by the Minister of Health from Uganda or some other person. The full package of things to do to address the issue of pneumonia, morbidity and mortality are in primary health care. But somehow, maybe because we are looking at the rural level with an urban outlook, we tend to break all these things into small projects and small programs. And you are dealing with nutrition, but you are not assisting, you are not empowering the mother from this minority style. When she goes back, what does she do? What is the problem of empowerment in our community? It's poverty. We know that pneumonia is a disease of poverty. So what are we doing when we have treated the first case of pneumonia and the child goes back to the community? How is she going to overcome the malnutrition that the child was having? How is she going to overcome the frequency of diarrhea that she's saying? How is she going? She's not going to have gas, cooking gas in the village. There's no way. She is going to turn to that tukul where she go and cut the forest. So how does she do it? And I think this will, with all my observation, it is a policy level will. A practitioner level will has to consider the elements of primary health care, not as projects, but as skills. Primary health care are all aid skills, and a well-trained health worker should be able to attend to a sick child, to immunize the child, to provide family planning for the mother, and to advise during pregnancy. Many of you who had the fortune to work in district hospitals, you have done this. It is possible to do it integrated. So to me, the will is good. How to operationalize. The challenge today, and my experience, I'm not criticizing any partner, we do have a lot of money in the system, but the money is broken into projects, and the children are forgotten.
Oh, so you're not criticizing any partner, you've criticized all of them. Okay, thank you very much, Luca.
Yeah.
Thank you very, very much for that perspective. Very grounded perspective, bottom up. And at least now we know that the wheel needs to move ages from just policy to skills.
Yeah.
Okay. Now, I'm going to come to Japi, who is the Minister of Health in Malawi. Malawi has had significant gains on reduction of pneumonia mortality and many other areas. And later I'll come to my friend Sidibe and say, what challenges are there in Mali? Because Mali has kind of the opposite effect the last few years. But we are happy now you've taken over the Ministry of Health. You have to behave here because he's here on stage. So you'll tell us what challenges are there with this multisectorality that are not being addressed in Mali that could be addressed to get to achieve what we need to achieve. But Japi, reflecting on this wheel and the work you're doing in Malawi, practical?
Thank you very much, Mr. Moderator. And just to bring to you that in Malawi, we've been very, very fortunate because the current president has demonstrated a lot of political will to ensure that we realize the universal health coverage by 2030, of course, premised on the primary health care system. Over the years, lots of work has been done to ensure that we reduce most of the indicators that have been affecting our population. Before I go into more details, let me quickly indicate here that in Malawi, our population is currently around 17.5 million. And out of the 17.5 million, 80% of those live in the rural areas. And 65% of the population is predominantly youth and young children. And you can imagine having 80% of the 7.5 million living in the rural area, and these are the most vulnerable. And what government has been doing over the years is to bring services closer to the citizens that are vulnerable. So if you go to Malawi today, you will realize that government has made sure that in all hard-to-reach areas, we have a facility that is providing care to our citizens, both the youth, the children, women, and all manner of people. So in making sure that we have a functional health system, all rural facilities currently are manned by what we call a health surveillance assistant. These are what we call our frontline health workers. They are the people that live with the communities in the most of the rural areas. They are employed by government, paid by government, and government provides with all these with basic equipment. So they are able to do tests at community level for both malaria. They can do an HIV test, and they administer drugs, including antibiotics. So the amoxicillin that was being talked about this morning in our situation is made available to all our deserving young children that have been diagnosed to have pneumonia. And over and above this, government is currently, as I speak now, in the process of constructing an additional 250 health centers across the country. All of them are tailor-made to make sure that we realize the HC by 2030, but also make sure that all our citizens have got access to health care. So in a nutshell, that's what we are doing in Malawi in response to your question as being a part of our success story. That will not be complete if I do not mention a number of our cooperating partners, Gavi being one of them, UNICEF, because for us to provide the much needed vaccination to all our children, Gavi has played a very, very pivotal role, the Vaccine Alliance. So we are able to provide vaccination for measles. Currently, we are also on the phase. We are doing malaria vaccination. We are doing the PVC. This is the papillomavirus. You know, all these have been possible because of the support that we're getting from our cooperating partners. So that is probably why you did get that we seem to be succeeding. It's because we get good support, but we have a lot of political will from the current leadership of the country. I thank you very much.
Okay, thank you. Thank you very much. I have one follow-up question, which I'll come back to you about the issue of multisectorality and how your ministry is working with people outside the health sector to address the 3 dimensions of primary health care. Okay. So I'll come back to you. So let me go back to, let me first jump you and go to the minister there, then I'll come back to you, because I would like you to kind of respond to this question relative to what Malawi is saying and what they're doing. I'm sure there are many successes in Mali you'd like to share about how you're doing things and many challenges as well.
Oh, thank you very much. Let me just start by thanking the organizer of this forum. I personally feel that this forum is timely, is topical, and it's very important that you start by challenging us on this question. But I will certainly say that your question should be why 20 years back we were still struggling. I was 25 years back UNICEF representative in Uganda. We're fighting these pneumonia problems. We were not, and 25 years down on the road, I'm sitting here, Minister of Health of Mali and Social Affairs, and we are saying, oh, it's unacceptable. It's not in Mali. I have 1 out of 5 under 5 dying from pneumonia. So the fundamental question is that one. Why? And I want to say that it will send us back to your problem. Is why? Because like my brother was saying, I will not say that we were just 2-3 things were wrongly done. First, I will not just say project, but I will say even worse than that one. We were just dealing with disease instead of dealing with health. So by dealing with disease, most of the cases, we were minister of hospital. We were focusing on big hospital, very costly, and then the paradigm which could have helped us really to deal with health was not there. So the public health, which you're talking about, primary health care, was in the jargon. But in reality, we didn't construct this primary health care. So most of our people were running from lower to hospital, and it became very costly, and we're missing the opportunity to have them early in their place where they were. So that was very costly as system. And it was not helping us to really demonstrate that we could deal with those children where they are. So the first things I will say is that this paradigm which we have, which is very important, need to take into account health. Like Maria said, the environmental issues, the food issues, the education issues, medicine is important. And I will come back to that. But if you look at the second major problem we are faced with, why today, and I heard this morning, I think one treatment is of amoxicillin is just 40 cents. Yeah. Why is not there? Yeah. That is a global commitment failure. It's unacceptable that in 2020 we are still sitting here and saying, what is done to make sure that even if it's there, it's not sure that in the pipeline, with all the things you are seeing today with resistance, that we have the research and development coming to help us in the future. So we need to broaden the questions. If that were there, we could really think about how in the community level we'll have a delivery system which will help us to go down there. And I think when I reflect on the system with the experience I had, I just realized that also maybe 3 things we need to add to that one, personally. First is the whole issues of equity, lack of social justice, lack of redistribution of opportunities, which is making the system today not accessible to the poorest people. If you take the case of Mali, and it's general in Africa, the out-of-pocket is over 35% of the expenditure coming from my pocket. And so it's impossible for the poorest segment who are down there to have access to that one. So you need to address the user fees issues, and that is what we have been trying now with the Mali Action Plan, which is really about 150 plus. 100 is to make sure that we'll really remove all the user fees, which will really create a barrier for poorest women or for children under 5. But we want to change the paradigm to focus on training 27,000 community health workers who will work on the last mile. And that I will end there. Unless the last mile is working, you're losing your time. Today, the interface between the last provider and community is not working. And that is where we need to invest more. We need to put more money to make sure that this last mile become more effective. And that's where we are trying to go with the system. Of course, all the in this last mile, some people will say that Muso is working on our some part of our region. If you look at the supply chain, no way you will be able to deliver what you're saying here nicely in the policy and because the last mile is not working. So, and that is for what I wanted really to share quickly and to say, of course, you know, Mali, we are in the conflict. I heard the presentation of my brother from Nigeria. When you're in this type of setting, what you were asking me, you lost completely contact with people who are affected by this conflict, and the access issues become a problem. And then the people are moving, the displaced, or so you have a series of difficult issues which are important. Finally, quality. It's not just about in our Mali Action Plan, which is the leading plan on global action plan. It's not just about double down on access, but it is issues also of how we deal with quality then, down there. If you don't have quality, you can put all these things, vaccine, and you know, the effectiveness of your program will not work. So we remain with this type of low level of impact. Stop there.
Thank you very much, Honorable Minister. Yes. You've raised very critical points, other than saying that you need to stop being the Minister of Hospitals to become Minister of Health, which is really critical. I don't know how many Ministers of Health we have here, you know, other than Ministers of Hospitals. In fact, our national health insurance is actually called National Hospital Insurance Fund. So you've raised a very critical point. But you've also raised the issue of managing this wheel and this multisectorality in areas of conflict and movement and people mobility. That is something we need to think about, because the policy level that Luca talked about assumes that things are stable. But if they're not stable, then this wheel falls apart. Where do you start? So I think that's a really critical point. You've also raised the other issue about how to cover for cost, which is where we need to think about, do we think about pneumonia as already covered? We know that primary healthcare has one of the highest out-of-pocket costs, generally, because people assume you go, and then you're told go for the X-ray at the nearest X-ray shop, go and buy your amoxicillin at the nearest pharmacy shop. So again, the issue around the importance of universal health coverage to ensure primary healthcare works is critical. So those are two things.
And it will help you also with cost, because if you look at the cost today, I didn't talk about it, it's only $6 if you go to community levels and But if you go to hospital, you go up, it becomes very expensive and sustainable with your program.
Good. Okay. So at the end, I would like to hear from the ministers on this panel why it is so difficult to divest money from secondary and tertiary to primary. Because we talk about it since 1978, as you say, but we still have the same problem. And we are talking to the ministers themselves. Yeah. So why is it so difficult to actually divest money from secondary to primary healthcare? I'll come back at the end of that. But Professor An, how is the situation in China regarding, because China has very good progress on pneumonia mortality reduction. It's fairly low. And I know that you've invested heavily in community health over time. So would you comment on the situation in China around this concept?
Yes, actually, we are suffering a very big challenge currently, the coronavirus, the pneumonia. But we'll come back to our topics for the childrenhood, the pneumonia. I think the three pillars of the primary health care is very important for the prevention and control pneumonia, because it requires the comprehensive interventions, the multiple sector policy coordination, and the social mobilization. All three pillars, the pillars, I think, are very important for the pneumonia control, especially for the childrenhood, the pneumonia. As an example in China, China we the two parts. First, we improve the coverage of the basic medical care insurance for the 1.3 billion people. Actually, the target already we reached more than 95% of the whole total population. People can access the health care easily, and whatever lives in the urban area or the rural area, and which can greatly improve the equity and the quality of the health medical care. So this policy helps the child suffering pneumonia can get proper treatment and medical care without any financial problem. Meanwhile, the second one, China also we have established an essential public health service package. Within that package, a government paid around like $10 per capita of the subsidy for all the population. And that package including the immunization service and the childhood health management, the health promotion, and other around 14 public health services together. So also, this is have not included the vaccine. The central government also pay.
Excuse me, there's noise coming from somewhere. I think maybe it's a translator interference.
Translator, maybe.
Yeah?
Maybe a translation?
So the sound people, just check where the interference is coming from.
Hola, ¿qué tal?
Is a translator.
Yeah.
Is a translator interference.
So
please check that.
Is it from Chinese?
No.
To
Don't worry. It happens. It happens often, and sometimes can be worse. We had a situation in UN headquarters where the translators were discussing their boss, and we could hear all that they were saying. So this is polite. So we'll get it sorted. Thank you. So please proceed.
Yeah, and also the central government pays all the costs for the vaccine procurement for the national immunization program. All this put together can contribute to the prevention of the pneumonia in childrenhood. And in China, we also set Health China 2030. And that strategy conducts the Health for All policy. This coordinates all the multiple sector policy together. So as a result, as you mentioned, in China, with the child mortality caused by pneumonia remains very lower level. But consider we a huge population, and that the number is still a high number because we are still among the 30 countries. It's because we have a huge population. If China, we reduce like the 10%, maybe a huge number of the global contribution.
Yeah, thank you very much. And of course, we can't forget, because pneumonia affects especially the under 2, the importance of the birth cohort, the annual birth cohort as well, is really critical. And the fertility rate per country will also affect the mortality rate for pneumonia. So that's something to keep in mind. But I'd like to hear from, so the point of health in all policies, we'll pick that up as we get along, because that's a really critical point. So let's hear from Amar about, on Mongolia, in the same question. Amar?
Thank you, Chairman. And I would like to express my thanks to organizers for giving us such a good opportunity to have in this meeting. And Mongolia has the quite big landscape. Population is 3.2 million. Landscape is 1.5 million square kilometers. Very dispersed country. Climate is very cold country. During the winter time is minus 30 to minus 50. During the summertime, it's average temperature is 20 to 30 degrees. So, yeah, of course, it affects to the respiratory tract infection and disease. So, Mongolia has made quite significant progress in decreasing morbidity and mortality under 5-year-old children during the last 25 years. We could achieve the MDGs goal. Mongolia is one of the 9 countries could achieve Millennium Development Goal. For example, in 1999, maternal mortality rate was 199 in 100 live births. By the end of the 2019, it reduced to the 20.1 in 100,000 live births. Also, the children's mortality rate we could achieve to the MDG goal. It was 120 in 1990. Nowadays, 15.1 in 100,000 live births. The role of the primary health service is quite significant for all our successful achievements. Also, the primary health care facilities providing universal health coverage and immunization program to all the population. In Mongolia, we have almost 600 primary health care facilities, most of them located in rural areas. We have 331 villages and 249 family group practitioners providing the primary health care to the population right now. By the health law, the primary health care is free of charge for the population. Also, the maternal and child health care services free of charge for all the pregnant women and children. It's very useful to the population to have a very good access to the primary health care. We are using WHO guidelines and all other guidelines for the treatment and for the prevention of those pneumonia and other respiratory tract infections. In a policy level, we have all the national programs on maternal and child health care. Also, we have the national program for non-communicable disease. We have a national program for communicable disease. Also, we have the national program on immunization. Immunization rate is quite high in Mongolia, almost 90% for the due to implementation of the program. Regarding to pneumonia, first we introduced pneumonia vaccine from the 2016. We started in the 2016. From the beginning of the 2019, we used to do all the pneumococcal vaccine all over the country for all the children under 1 year old. Now, last year in 2019, the rate of the pneumococcal death was 19 in a countryside, 19 among the mortality of the children's under 5-year children's mortality. Nowadays, around 23. We reported 23 deaths among the children. Children's mortality under 5-year-old. So primary healthcare services quite providing quite good national providing all the educational and teaching programs to the population. Also, we have a program to teach and to educate all the doctors who is working in a primary level in a rural area and also in the urban areas. Thank you very much for your attention.
Thank you. Thank you very, very much. Thank you very much for, I was planning to take a holiday to Mongolia. I have to think about the weather now. But thank you also for all the successes that you've had in Mongolia. I was looking at your statistics.
We have a challenge.
Yes.
Yeah.
And you've made very good progress. I would like to hear from Itai now on that side. You've seen when I shared the data there is no indicators, there are no data for community participation. As very active member, Itai is a member of the UHC 2030 Civil Society Engagement Mechanism, active civil society member in Zimbabwe and across Africa and on the international scene. Could you comment on this and about how does this work if we don't have any way to measure how the community is being engaged?
Yes, thank you very much. If I look at this wheel, to me, it is very relevant, mostly because if you look at Africa, most of the health problems do not emanate from the health sector. we need to address the social determinants. We need to address the causes of ill health. So it's like taking someone to the health facility, but back to the same environment that it would have made them sick in the first place. But I think what is exciting, and I hope the African ancestors are kind of happy, is the Astana Declaration. To me, it reaffirmed the Alma Ata principles. It brought back the spirit of primary health care back to the health agenda. Most importantly, it also brought back the spirit of multi-sectoral approach, health in all policies. And the bottom line is it also recognized that health is a people's issue, especially primary health care. We need people that are knowledgeable, we need people that are empowered, that are informed, and that can participate in the health processes. How do they participate in the health processes? It is also important that we have platforms, we have spaces for communities to engage. How do they do that? They need resources. And where do we get those resources from? I think the UHC political declaration in New York gave us a platform. That commitment from the world leaders to then say, we want to move towards universal health coverage. But there are indicators, there are benchmarks. We know in Africa we have got the Abuja Declaration, 15%. We know WHO has got the $86 per capita. And as civil society from CSM, UHC 2030, we have also been pushing for the 5%, GDP. But how do communities participate? And how do we measure? With what support? We know that most African countries have been reviewing their public health acts. And through the public health acts, there's been some recognition, legal recognition of structures for community participation. And one of those key structures is the Health Center Committee. These are the health governance structures that you find in almost every health facility in East and Southern Africa. But these structures, they need to be capacitated. They need to have the skills to be able to collect data, analyze that data, and use that data to engage the authorities in their respective areas. What we have seen in Zimbabwe is that health center committees and community monitors can make a huge difference if they are given a space, if they are given support, if they are acknowledged, if they are recognized by the authorities. And what we have also seen is that health center committees can be a vehicle for information flow. They are able to collect community views, community inputs, and these views can then be taken at the health center level. They are able to monitor the quality of care, but they also need to be capacitated, like I said earlier on. For that to also happen, we heard earlier in the morning when the Minister of Health from Uganda was saying, I need the money. But where is the money? Is this money, are we talking about external money, or we are talking of domestic resource mobilization at national level? I think as Africa, if we are to move, especially towards universal health coverage, we need political leadership, we need political will, we need the political commitment from our national leaders to then say, we are going to be putting our own money into the health sector, and whatever is going to come from external partners is to complement our own efforts at national level. But the most important thing, like you said, how do we measure? We need to capacitate these local structures, especially the most affected communities. We heard about the urban poor, the rural communities who really struggle to meet the health costs, given that most of our health budgets are never adequate to address our health needs.
Okay. Thank you very much, Itai, because you talked about health budgets. We know WHO has a target of $86 per capita for primary health care. Many of the countries are operating between 7 and 21. So the gap is really big. So for the Minister of Health in Uganda, I would say the gap is whatever your average public expenditure is per capita, subtract that from 86, that's the money you should ask from these people so they can cover your gap. I'm doing a quick arithmetic for you. But I want to come back to the accountability question, and I hope, yes, and the measurement question. So what I want to reflect here is this is the Universal Health Coverage Service Coverage Index, which is what is approved by the SDG Statistics and the Office and WHO. And it has 16 tracer indicators. Within the first 4, because we have the ones of maternal and child health, we have infectious diseases, we have non-communicable, and then we have service capacity, bed capacity, and that kind of thing. If you look at the first section, which is reproductive, maternal, and child health, pneumonia is captured as one of the tracers. It's actually the 4th tracer indicator, child care seeking suspected pneumonia. That is the only measure that we have. And when you look at the wheel, it's the only measure there that we had, and we didn't capture anything else. So let's, we have just very few minutes now. I would like to talk about accountability and what shall we measure? All these things we are talking about, what are we going to measure to know whether we are making steps towards pneumonia mortality control? Are we just going to measure the number of children who die? Or are there measures that we can put in terms of input and in terms of impact? So maybe a quick comment from each of you on that as we close. So I will start with, yes, Honorable Sidibe.
No, I will just start by saying that it's so critical to have strategic information which will help you to really guide your decision making. So it's important to measure what we treasure. If we treasure today really pneumonia and we want to fight, we need to be able to measure. But I am very scared when I came and I check and I try to see. I found that we are faced with so fragmented approach. Every single player is coming with his back, is coming with his strategic interests, is coming with his vision, is coming even with a tool to help you to measure that. It's impossible. So the first problem to be able to move and to have a good accountability system is first to change completely the paradigm and make a coordination, harmonization, alignment a reality. So I know what I want. The country vision is clear. First, the people need to be able to align themselves to our priorities, our system, and also to harmonize with our strategies. If that is not there, you will never have a mechanism. You know, I introduced these 3 ones those days, but it was about that, to make sure that at least we have one reporting, single reporting mechanism. But saying that, to come back to your point, pneumonia is not just about immunization. Yeah. We all said that right now. So it's not just about measuring if our immunization program is doing well. Yeah. It's the all other intervention, how you measure that one. And so that's why we have been able to push this district health information system, going until county level, to make sure that at real time we are capturing information on all intervention, so it can come out quickly and it can be analyzed and it can be put in the way that decision can be taken. Mm-hmm. So I think going back to this district health information system, to strengthen that, to train community health workers, to make sure that people who are at the lower level can have access to those type of information system is important. But before that, if we don't have our own plan, our own vision, our own strategic map, and make sure that, look at, for example, we have the 4 big G, Global Fund, Gavi, Global Polio, I can go, and so. I don't remember once those big 4G came to us and said, please, let us work together on the next 5 years. That's what we want to do and to make a change happen. So that will never happen if we don't do it.
Exactly.
I will stop.
And I hope you have nothing against G's, because I'm GG.
Yes, I know.
Nothing. Okay, just checking.
So I think it's important to really.
But that's a really critical point, because we are saying that data information needs to be led from the bottom, not from the top. And actually, if you look at, you are the architect of 90-90-90, at UNA. So in the country, we adopt those measures, but anywhere where there's no partner, the measures are left until there's a partner who comes. So I think maybe let me just come to China and then come to Malawi and say, are there measures that we should use? Other than a donor coming to say, now we are focusing on pneumonia, therefore we want this measure. Are there measures we should be looking at for holding ourselves accountable? And I know I'll come back to you, Luca, because I was told that South Sudan did the health system readiness. I know that you are involved in that process. Just to know whether there are measures, indicators from there, health system readiness for pneumonia that we can pick in this conversation on accountability. So, Professor Ann?
Okay. Actually, the measure is very important. It's seeing what's get measured, what's get done. So, but the indicator or the tracer, I think it depends on the country. We need to know in our country what we are missing, the data. For example, the coverage, the immunization coverage is a very good tracer or the indicator. But in China, we remaining with a high coverage already, but we still have very important vaccine not in the program. So it means for us, it's a tracer, it's a new vaccine introduction into the program. Like PCV, we are not in the program. The HIV, we are not in the program. So it's very funny. It's very, China looks like a very rich country, but consider the big population. Any money is divided by the 1.4 billion is nothing. Yeah. So, so this is I think the tracer and also indicator. And also I thought if we need the policy, inform the policy for the data, we need to know what the disease burden of the pneumonia, not only the number of the pneumonia, but epidemiology changing of the pneumonia. What's the real reason? Is a virus, is a bacteria, or other risk factors? So that is which direction we are fighting with the pneumonia. So that is, I think, is really dependent on the country. Also, for us, we are serving the domestic vaccine supply. The very expensive PCV in China is like $100 per dose.
100?
Yes. So, but that is imported from the Pfizer because it's not in program. And the domestic supply is slowly developed the vaccine by the manufacturers, but it's very slowly to can be reached the needs of the overall capacity supply. So that I think all the tracer put together, we need to individually for the country perspective.
Okay, bottom up again, tracer, bottom up, and let's hear from Jappy.
Thank you very much, moderator. In Malawi, we also use the same bottom up approach, where currently I did mention in my presentation that we have what we call HSAs. And recently we've also deployed IT experts that are working hand in hand with the HSAs to consolidate data, which is then used for policy formulation. Because we believe that without data, we would be making wrong policies. So that is currently the case. In as far as issues of making sure that policies are made pretty much based on evidence. So that's what we're doing. Thank you very much.
Okay, great. Thank you very much. Luca, do you want to comment? And then I'll
yes,
come
I
back
just
to
want
Amal.
to say in South Sudan, we have the district health management system too. But the situation in South Sudan, because we are in a state of no war, no peace, and about six
no war, no peace.
Yes,
that's the policy. Okay.
70% of the country inaccessible, and up to 80% of any service delivery being done in the country is done by partners.
Right.
So the thing which is really burning in my heart about this is that we need to have two types of measuring. Measuring the health management system from the bottom.
Yeah.
Secondly, is measuring among the partners the efficiency of an oversight. At the moment, I think the developed countries, because they have so much money, they throw away what they can afford. And they don't seem to be interested. Did that money really produce an outcome? And so every now and then, we come here and things don't seem to move. So I think that we need a mechanism where we must be interested in an audit. We, the beneficiaries and those who will give us, has the money produced. And we will have to decide on the indicators. But secondly, the issue of intersectoral collaboration. I would like to talk to inter-partners or partners collaboration. Because in my early years, when I was in high school, we saw for development assistance, people come and work embedded in the system, embedded in the ministry or embedded in the department, so that there is a transfer of technology. At the moment, in my country, all the organizations, they have their project offices, they do their own thing, and they can give you a verbal information of what they are doing. And if you insist on writing, they write up something. And the people in the government, they are frustrated because they don't even have a pencil, and they spend their time being very angry. So you are not having anything coming up. So I think that people should plan jointly. People should budget jointly, and people should be able to say, what is it the government is doing? Has the government given 2 and the donors have given 8, or has the government given 3 and the government and the donors have given 7? And then we follow how much that money is used. Whether it is in clinical setting or in management, it is only by embedding the experts in the system that there can be transfer technology. If not, when the project ends, and many of these projects usually end when the money ends, they go away and then we say, oh, you know, this was UNICEF project, and it's all dead because they've gone. So a project was there, but there was no transfer of skill. This to me is important. Number 2 is the issue of community empowerment. I think that we are undermining ourselves. It is almost an insult to say all the community will be empowered is to be informed, to be given education. No, I think that we need to, primary health care said, essential health care at the cost community can afford, cost and country. It is time that we know that in traditional African society, health care is not free. Everyone of us knows here who is an African, health care in the village is not free. Whenever I was sick, usually my grandmother took a chicken to a healer, and then it is paid. So the issue of the fact that people must participate in paying for the cost of their share of their health, it also empowers them to have the power to demand the service. Because the moment they go to a health center just like beggars, and the doctors are moving there and talking their English, they don't know. So I think these 2 issues to me very important. It is time we think of how can the communities themselves participate in accessibility. I want to give an example, although the Minister of Health from Mali is here. When the extensive program of immunization started, after the first 2 years of the whole country being cleared of the backlog, the Minister of Health adopted a system where the family has to pay 100 francs. He told you pay 100 francs to bring your child because then the center, the health center or the district cannot complain of fuel. The car is there, but there is no fuel. And with 100 francs or 150 francs, it was possible for the vaccination team to move about. And I think that to have a car parked because the donors have not given money for fuel, it is an insult to our independence.
Yeah. Thank you very much, Lisa.
I want to add something about nutrition. I want to say a word about nutrition. Because we know nutrition is important in pneumonia. Malnutrition is important in pneumonia. And when a child is treated with pneumonia and he goes, or those who are not going to come back because they are well fed, after the 6 months of breastfeeding, we are not always very clear as to what is it, what type of food does the child eat complementary with.
Yeah.
And I have learned that in Uganda, there is, and the Minister of Health from Uganda can tell, in Uganda there is a system, I think, called wealth creation, where they give out animals as to something called zero grazing. It's, you know, small animals, and a woman will look after this, and she has an income from the milk. I think in South Sudan, I've been advocating with 1 or 2 donors who seem to be interested that the ideal food for a child under 2 years of old, even not under 5, is milk. And so probably if you want to reduce or to prevent pneumonia, you must assist this family to acquire a mechanism where they can have, because milk is the only reliable food for a child. Everybody knows milk is for children, and they are not going to rob. So livelihood project should be really part of our intervention, because that is how you fight nutrition. And the only worthwhile empowerment is an economic empowerment. You can lecture to somebody, and like one Indian lady one time said, well, whether I have 1 child or 3 children, I don't have food to give them. So I think that the issue of economic empowerment, to me, should be part of our dialogue if we are trying to reverse pneumonia.
Thank you, Luca, because you're reflecting, even when you go back to the wheel, you're reflecting on the area about community participation, decision making, and we know the role of the women in these decisions you're talking about here. And therefore, even within the wheel, if you look at education, we are measuring number, female transition to secondary and that kind of thing, and also female decision making. So these are critical issues. And I wish we had more time, because I would have come back and said, why are these things not happening? And how are the ministries of health ensuring that they actually have a strategy to engage ministries outside health that are so critical to ending pneumonia. But our time has come up. You've raised 2 issues. Aid effectiveness, the issue you're talking about integration of strategy and planning, aid effectiveness. Please review the aid effectiveness principles. There are 7 principles of aid effectiveness under the International Health Partnership UHC 2030 that reflect on exactly what you're talking about joint planning, joint strategy, not projects, as has been said, and even the ministers have referred to it. The other thing you talked about is community participation, which is really, really critical, which is reflected here. So what I would like to do now, because our time is coming to an end, is invite our respondent. After that, we are going to pick 2 questions or 3 that have been sent by the audience that we would like to, I would like to ask the panel to respond on. Our respondent is Jai Krishin. Welcome back. Our respondent is Jai Krishin. He is the head of Department of Pediatrics, Pakistan Institute of Medical Sciences in Pakistan, obviously.
Thank you, Chairman. It's indeed a great honor and privilege for me to be on this forum. Basically, before I go for highlighting the importance of primary health care, I would like to accept certain responsibility, because we are one of the 5 countries at the moment, and we are one of the countries which are producing more mortality in terms of pneumonia. We are contributing about 19% of the mortality which is related to pneumonia, which is, I think, is a very, very poor performance on part of our country. So I do accept that. And similarly, in terms of nutritional indicators, the condition is again in dismal, because it is about 44% of the children, they are stunted. And out of about 33%, they are underweight. And the vesting is about 7 to 9%. And I think these all factor enhances the risk towards the dying from pneumonia. One of my speakers, she highlighted a child having a malnutrition, they have got a 9% increased risk of dying from the pneumonia. So I being the clinical pediatric unit at Children's Hospital, we are involved in the training of the undergraduate, postgraduate, and the lady health worker, which are basically the community health worker for last 15 to 20 years. These lady health workers are basically the grassroots health care providers in our society, and they are working to bridge the gap between the primary health care services and the communities, especially in terms of BSQ, RSU, DSQ, and tertiary care units. Through their training, we try to ensure that these lady health workers are able to enhance the community awareness and empowerment on the protective and preventive initiative. Because until and unless we are not highlighting this protective and preventive initiative, it's very difficult to control the pneumonial death. Regarding the environment trigger, one of the speakers, she highlighted the importance of environmental pollution, which is one of the risk factors for increasing the risk of pneumonia, basically using the fossil fuels for the burning purpose inside the home, smoking inside the home. Our government is working in terms of outdoor pollution because they have planted some millions of trees. Since the government of Imran Khan has arrived, they have planted millions of the trees to control a little control over the outdoor pollution. And similarly, I would like to highlight the importance of these healthcare workers in terms of highlighting the importance of exclusive breastfeeding. Because until and unless we are not improving or we are not basically supporting the exclusive breastfeeding, the child is not going to grow. He is likely to be malnourished. And secondly, we have to enhance so that they should be complementary feeding by the age they are about 6 months. So by these tools, we can reduce the mortality because they improve the nutrition status of the children. So until and unless we are not going to improve the nutritional status of these children, again the risk of dying is very, very high. And similarly, hand washing, sanitation, which is again an integral or a key role in combating the death from the pneumonia. So these healthcare workers during our hospital visit, we basically train these through the IMNCI workshop, which we are carrying out twice a month in our hospital. And through IMNCI working, we need to make them understand what are the important things. And they are also being trained how to diagnose pneumonia in the primary healthcare facility, in the community level, concentrating on timing the respiratory rate through the ARI timer. They should have a pulse oximeter. They should have an easy access to the primary healthcare facility so that once they diagnose the child with the pneumonia, or especially those who are having a danger sign, they immediately need to be transferred to that health facility so that they can be treated accordingly, and if they need any oxygen, they need to be provided. And similarly, we want to upgrade our healthcare system, especially the primary healthcare system, especially the BSQ, DHQ level. The present government of Pakistan is basically establishing a state-of-art healthcare system in the vicinity of Islamabad, urban area, rural area, and then it will be act as a model to be adopted all across the country. So we are trying hard, and so one thing which one of my speakers he told is very important, that we have to provide the primary healthcare facility at the cost which the country can afford. If the country cannot afford, how can we invest a lot of money? In our setup, we are spending only 0.7% of the GDP on the health facility, which is a very, very minimal amount. So with this minimal amount, how can we improve the primary healthcare facility? So I think there is a lot of will and commitment on the top of the government so that they should provide, increases the health budget, and then they should develop more and more RSC and VHQ level, increase the number of lady health workers. Right now, when this program was initiated about the lady health worker program, they recruited about 90,000 primary healthcare workers, and they were providing services in the rural area, which usually control about 60 to 70% of the population. 30% of the population are still left. So now this government is increasing the number of healthy healthcare workers to provide the services in the area which we are not yet covered. The second area is in terms of urban area. We are not concentrating on urban area. But if we look at the slums of the urban area, the condition is pathetic. We are seeing a lot of cases of pneumonia in the slums area where there is no lady health worker. These lady health workers are basically based into the community in the rural area. So I think they need to be over this area also, just to pick up the pneumonia at the early stages, refer them, and then give them the curative treatment to reduce the mortality.
Thank you. Thank you very much. A big round of applause for our respondents. So I have a set of questions here and a population of panelists. So we have to find out to handle this because I would like us, we have instructions to end at exactly 4, so we have only 10 minutes. So I'm going to ask specific questions and I would request you to take 30, 40 seconds to answer each. So no big stories. So I've tried to kind of allocate the questions the way I feel. And welcome back, Maria. Yeah. The air is still pure enough as the way you left it. I have a question for you and Itai. So each of you 30 seconds. And the question is, the level of advocacy on air pollution and climate change is more with the youth and civil society than governments. What can we do for government to get more engaged in sensitizing communities to act on pollution and climate change? So 30 seconds.
Okay. 1 year ago, we did the first ever global conference on air pollution and health at the World Health Organization, and we have been as well approving global climate change and health resolutions at the World Health Assembly. So, and we have been participating to the COP, which are the climate change summits, where we are bringing the argument of air pollution, means the causes, the underlying, the sectors that are responsible for generating greenhouse gases emissions are overlapping with the causes for air pollution. Therefore, if you tackle climate change, you will reduce air pollution, and as a result of that, you will reduce the massive mortality and morbidity associated with that and reduce the 7 million. So the governments are bringing and participating more and more. They recognize this health argument as a very strong motivation to do more on climate change mitigation because we are providing them the health benefits associated to the mitigation of climate change. And this is changing completely. Until now, we were talking about planets, we were talking about polar bears and glaciers. Now we are talking about my lungs, my brain, my cardiovascular system, and then this is something, asthma, and this is something that the politicians and the general population understand and is motivating very, very strong. So we can use more and more those to motivate more action. Mayors are critical and fundamental in the government, are the ones that are responding the best on all of those activism and need for them to. But it's true that the health sector is a little bit behind. Exactly. So we are engaging the energy sectors, governments, mayors. The health sector needs to follow, to move from this curative hospital approach to this prevention, primary prevention, which is our raison d'etre somehow, but we need to recover.
Please invite the ministers of health to your next summit on air pollution and climate change, yeah? And they promise to come. Itai, 30 seconds, community activation on air pollution.
Yes, let me say that the WHO is in the process of developing a social participation handbook. And it will be a very useful tool on how we engage with the national governments, on how we engage with parliaments, and how we engage with other stakeholders. So a draft has been circulated for comments and inputs, and I really want to encourage the delegates here to have a look at this draft document and give their comments and give their input, because it will be a very, very useful tool to engage the governments and the other stakeholders.
Thank you. Thank you very much, Itai. And I have a question which I'll ask the two ministers to answer. The question is, every disease-specific program, the verticals, has often similar barriers to overcome to implement scale, clinical practices, commodities, tools. How do we make everyone work together beyond the verticals? How do we bring system integration? So maybe just in under a minute.
No, I think we have been talking about that the healthcare ecosystem is very complex. Everyone is coming, like I said, with their strategic interest, and we need to find a way to really coordinate. The first thing I will say is that it's important that country will really develop his own vision, strategy, and bring people around coordination table. If not, it will not work. I am convinced on that one. It will work because we decide that we know where we want to go, and we want people to help us to work together to do that. But what we missed, I think, from this discussion, let me just say that, which is very important, is innovation and technology. Yeah. We are in different world today with artificial intelligence, with blockchains and internets, all the things. So the world in which we are working changed completely. So how we will use this new technology and of course to better help us to bring coordination down there at delivery levels. That is the problem. So for me, I will stop there.
So drone technology to help integration,
I think
at that point. Okay, I think that's a really
and maximize each dollar we are investing today, because if not, we will not be able to make it.
Very few governments have electronic medical records in the countries where
that's
we're talking about. Very few governments have an electronic medical record. So, Jape, you have 30 seconds to this question.
Thank you very much, Mr. Moderator. Health being very, very dynamic, it is also very important that we are as inclusive as possible, because the moment you leave other important stakeholders outside of the system, you're also going to encounter challenges. In our case, we work with pretty all important stakeholders, so agriculture, natural sources, education. All these are, to us, very, very important stakeholders. That much space, because we believe that, for example, if you leave out education, someone said earlier on that health starts from a family. If you have got an related family, obviously you're bound to have problems. So you have to make sure that each family is educated. If you have got an educated family, you are surely going to manage your own health issues at household level. If you don't do that, you're going to face problems. So as a country, we are trying as much as possible to include pretty much all stakeholders in our programming.
Fantastic. Thank you very much. A last one from Amar on, and this is kind of a yes or no question. Should pneumonia become a marker for how quickly the needle is moving on primary health care? Should pneumonia become a marker so that we know if you're improving on pneumonia, then we know our primary health care is improving? Yes or no?
Yes.
Yes?
Yes.
Anything that you'd highlight that we need to make sure? Yes?
Yes.
You said yes or no?
Thank you very
Good.
much.
Thank you very much. And I think the last question was on subnational level data, and I think we have discussed that quite significantly. So what I would like you to do is join me in thanking this brilliant panel that has debated this issue. Thank you very, very much for also being a fantastic audience. I think we've covered ground. There are many issues that have arisen that we could have gone more to discuss. But remember, we've talked about financing, the issue of financing, that we can talk about all these things, but unless there is sustainable financing of the health system at primary health care, we will not achieve. We can keep talking about them, but we must discuss sustainable financing so that people seek help when they need it. That's really critical, and at primary health care level. The next issue is the issue of moving from policy to country. Action must happen in the country. Action does not need to happen in Geneva, in Barcelona, in New York during UNGA. If it doesn't happen in the country, in the community, it's not happened. We've heard a lot about that. The other thing we've had is the need to make sure there is effectiveness of all the resources. Bringing all the resources to the table and discussing them and agreeing on a common approach. When we have verticals that don't speak to each other, no one has said verticals are bad. Actually, in this age of UHT, everyone thinks that we are saying verticals are bad. Verticals have to be there. There will be needs for verticals. But those verticals must come together on the table and plan together because they leverage on each other. There is need for community participation, and most importantly, it should not just be left to civil society. It needs to be institutionalized community participation. These are the things we've had. Thank you very much for your questions. Thank you for participating, and thank you to the panel. Thank you.
Thank you.
Thank you. Very good. Very nice.
Thank you. What an amazing panel. Let's take a break, around 20-25 minutes. Let's reconvene at 4:25 p.m., 16:25 hours. There's coffee right outside, and we'll go ahead with the final session of the day on international partnerships. Thank you. afternoon. Welcome back. Last year, 12 international health agencies released a new plan that promised much greater collaboration in the way they work together to support countries to achieve the Sustainable Development Health Goals. What does that really mean for child health in general and pneumonia specifically? Well, this is our next topic. We are particularly honored to have the Honorable Minister of State to the President and former Health Minister of Senegal here to find out. Minister Awamadi Kolsek, we welcome you and your panelists.
Hi, everybody. I am very happy to see that in the afternoon, after a break, we have still some people who are here to listen to us. Thank you for that, because it's not easy to be here from 8 in the morning to now. We are also lucky to have with us in this session on global partners, very important people who are here with us, representing Gavi, UNITAID, the Global Fund, GFF. And they will give us more information and maybe have a contribution on the debate we have since the morning. It was important to have this meeting because a lot of us, we are looking at children, we are looking at child survival, but it is important to have figures and showing that maybe we have done a lot in a lot of diseases, but we have to recognize that children pneumonia has not been very well tackled in our agenda. What to do? We have global partners who have done very well, who have supported countries, but the killer number one is still here. What we will do and what we can do to work on what exists already and try to work better and maybe to help tackle this disease. But the discussion since the morning has been very rich, and I would like to highlight 3 things. The first one is we are speaking of health and not of medicine. This is also very important. A lot of people are focusing, and we have the last session on primary health care. Since Almata, the Bamako initiative, we have all said that it was important to look and work at community level and have primary health care well tackled. But until now, we are still working and speaking and saying that it is not enough. Country in the driving seat. It's something we are also always saying, but is it true? Do we do that? Is it not important now to think and to say and to do that? The global community is here. Maybe they will tell us how they are also looking at this issue, because you are all supporting countries. And I will start by Tabani Mafosa. Excellent work done by Gavi. Everybody since the morning has been referring to that. And we are all hoping that we will have a successful replenishment, and think that all of us need to be champion, because we know that vaccination has really helped a lot. But you are not doing only that. But we need to know also, if we look at the figures since the morning, that pneumonia fighting vaccines coverage is not very high in all the countries, and particularly in countries where we have the more death concentrated, like India, Nigeria, but also some specific countries like Chad, Somalia, etc. Donc this is something you need also to look at. And what I would like to ask you is that before that, some also have said that the vaccine, pneumococcal vaccine, is too expensive. Can you tell us what Gavi is doing to be sure that in 2030, more than 90% of children, particularly in the high-burden pneumonia country, are vaccinated? The last miles also, the issue of last mile. Do you have some response on that?
Thank you, Madam Chair. I think that it is important for me to begin by recognizing the remarkable progress that has been made in vaccine coverage. Since 2009, we have reached 185 million children. And it is indeed true that vaccines still are considered expensive in some instances, but it is also important to note, especially in the space of pneumococcal vaccine, that it is at a 98% discount from the developed world. So if you compare the price of the US and the price that we are having, it is at 2%. That's a very significant discount that we are looking at. Since 2009, we have covered about 60 countries out of 68 Gavi-funded countries. That's also very remarkable progress. But Gavi will be also the first one to acknowledge that progress has stalled, especially in some of the countries that you point out. When you speak about Chad and you speak about Central African Republic, we think about those from a fragility and a conflict lens. When you speak about Nigeria and Pakistan, we think about going subnational and what that means to be actually at the grassroots. And so Gavi 5.0 is focusing at deepening our focus at a subnational level, but also in the fragile context countries. And in that spirit, we hope that we will reach the unvaccinated children that at this stage are about 10.2 million. And that number has actually not moved in a number of years, and it needs a concerted effort.
I think that this is very important as work you want to do and you are focusing in, but do you have a special strategy or something you want to do for the last miles? A lot of countries has 90%, yeah, if they are doing well, yeah, at least 10%.
Yeah, yeah, I think with pneumococcal PCV specifically, you noted, and speakers in the morning did not, it is still at 48%, and there is a lot of room to improve to take it much higher to the 80s. I think one of our strategies is to really strengthen the data and the micro plans that are done at a local level to make sure that we're able to identify and to work on strategies to reach those children. And if I may pivot at this particular point, throughout the day we have been talking about primary health care, but Gavi is thinking beyond primary health care. We are thinking about how do we work with some of the players in the WASH area. How do we work with some of the players like the World Food Programme, UNHCR, the ones that are actually hitting the last mile, so that we break away from the mold of what we have always done and look for new ways of working. And some of the new ways of working really relate to working with new partners as well, who have a deeper and better reach than we currently have. I think the Minister of Mali did note that there are places that because of conflict, the government is actually not able to access. But some of the NGOs and the civil society is actually able to reach those places. How do we make sure that the space is open and they are able to be brought, and we actually leverage the platform and the space that they have and the reach that they have as well?
Thank you. Thank you. Michael, the Global Fund, you too, I think that you have done and been involved in supporting countries, and a lot of progress has been observed concerning the 3 diseases, HIV, TB, and malaria. A lot of countries has been really supported and have seen a lot of changes in what, particularly in indicators. But malaria, for example, is the one who is killing, who has killed, because now it is going down, but kills still a lot of children. But if you are doing your job very well, for example, for malaria, and that you have all your children now saved without any malaria, but these children can die from pneumococcus diseases, and particularly pneumonia. What do you do as Global Fund to really try to contribute to integrated community case management, including pneumonia?
Miss, thank you very much for your question, and it's an important one. I mean, the Global Fund's contribution to integrated community case management is an example of our dedication to strengthening health systems, including community systems and health responses, to integrating malaria responses on community and health system platforms, and our obsession with saving lives. So what does the Global Fund do? The Global Fund is already financing ICCM interventions in many sub-Saharan countries, sub-Saharan African countries, and also investing in community platforms in Asia and Latin America. The Global Fund, together with USAID, PMI, are the largest international financiers of integrated community case management. And an example of that is the work that we're doing in DRC, together with the Ministry of Health, provincial governments, and with UNICEF, that has activated hundreds of community sites for ICCM. We've just completed a successful replenishment, and we also wish Gavi a successful replenishment, because having a well-funded partner like Gavi is essential in terms of our work in health. And countries are currently preparing their application requests to the Global Fund, and we do expect through these applications an increase in the investments on community systems and in ICCM. And I think this is particularly important for countries like DRC and Nigeria and the G5 Sahel countries. Those countries are responsible for the majority of the malaria deaths, and also are on the top of the list for the malaria countries. The challenge we have, of course, is who funds the non-malaria commodities. The Global Fund can fund the ICCM platform and the malaria commodities, but, and this is an important caveat, we cannot fund amoxicillin, zinc, or ORS at the scale that's needed. We are working with partners and advocating with countries to procure these commodities, but we are not making the progress that we need to make. And this is very surprising when you consider, and as we heard earlier, that the cost of these commodities is relatively small and they're easily accessible. So what are some of the things that we can do through the Global Fund model in terms of addressing this situation? I think the first one is looking in terms of domestic financing and co-financing. For countries to access their full Global Fund allocation, they need to meet co-financing commitments. And I think an important message for this audience is that national co-financing can include the non-malaria commodities to put ICCM at scale. I think the other element is it's not all down to governments. It's also the work that we do with the private sector and other partners. And an example is that of the work that we're doing in Nigeria with the private sector and at state level to find alternative sources of financing for the pneumonia commodities so that we can expand ICCM within the country. I think a second element is how we expand and focus our partnerships around ICCM. We're working closely with GFF, Gavi, the World Bank, and UNICEF on the Global Financing Facility. And there's an opportunity for countries to prioritize impactful and cost-effective interventions like ICCM as part of their investment cases, also for IDA loans. And we're also providing catalytic funding for the ICCM task force, which was led by UNICEF, and that previously supported 28 countries in Africa to include ICCM as part of their applications. And I think the third element is the work that we do in terms of with ministries of health and civil society to strengthen the policies, the strategies, the coordination of ICCM at country level. And as I think we've heard earlier, there's more work that we need to do there. So I think our ask is to strengthen and broaden our partnerships around ICCM. The Global Fund can do the heavy lifting in terms of the ICCM platforms and the malaria commodities. The gap that we have on the pneumonia commodities is small, and I believe if we can work together, we can plug that gap and save lives from pneumonia. Thank you.
Thank you for all the examples you are giving us. For example, I look at the co-financing, where countries can also buy other drugs than the one the Global Fund is working on. When you look at also supporting the health system, you can have also an open possibility of doing other things. I think that maybe countries themselves need to know more what happened, and maybe best practices need to be more disseminated. Some countries can think that they cannot do that, what you say. It is done elsewhere. Why not in my country, for example? And this is something I would push to really disseminate more and share more all the best practice you have to push countries to be also open and know that it's what they want that you will do and not what you want that they have to do. So this is also something important. Are you ready for that, or have you done it already? Maybe it's something.
I think we're already. I mean, we've done a number of reviews on integrated community case management. And it's often we know what the best practice is, and this is often an issue in health. Is how do we apply best practice in different contexts? And that's, for me, that's often down to the leadership in countries and the champions that we have in civil society and government for primary health care, for community responses, and for really focusing on how we're saving lives and being just intolerant of poor relative performance. So in one very simple example, in a study that we did together with USAID and with UNICEF, is very few countries have an ICCM coordinator, and that's something that's really necessary, because to do ICCM programs properly, you need someone who coordinates, as we've heard in terms of community responses in pneumonia, across many different sectors and functions. And having one coordinator can help in that internal coordination that can improve things. I think the second element is looking in terms of the investments that we need to make in terms of improving health data, and how governments with civil society and other actors are looking at that data and changing necessary course. Rather than trying to stay the course to see if things are improving, it's to use data to drive impact and improvements. And one element is at the global level, it's important how we publicize this information. And I think for many people, even in the health community, seeing the proportion of deaths due to pneumonia, socializing that, I think, will be part of how we drive action. And maybe an analogy for that for me was the successful work that was done over the last 2 years with the TB community, where we saw that the improvements in TB case notification were very much plateaued, and that we needed a real political movement to say that's just not enough. And then using the data to provide a very clear target. So we're going to get 1.5 extra million TB cases notified annually over 2015. And so that political attention on an issue, a greater understanding of how serious that is in terms of lives lost, and then setting a real clear targets, I think really incentivize at country level people to do more and step up. And I wonder, from that TB example, is it something that the pneumonia community can learn from?
Thank you. We now go to the Acting Executive Director of UNITAID, Philippe UNITAID also has been established at the beginning to work and support countries on HIV, AIDS, TB, and malaria. I don't know how UNITAID have done to be able, more than others, to shift a little bit and be more open to other things and other diseases. Maybe you can also tell us how you have done it. You will announce a new initiative later. I don't know if we can know that now, but yes. I know that later it will be announced. Investing in technology. And this will help to reduce child death in 9 countries. This is very important. Tell us how UNITAID was able to move to a more integrated approach. Thank you.
Madame la Ministre, cher Awa, I think first it's a pleasure to be with all of you today, and the discussion so far is something that we care a lot, and point of view of the countries. And by the way, I think that's the reason why we moved to some kind of more disease-oriented approach, which we will continue, by the way, because we believe that innovation, access, and scale up with the partnership we have with Global Fund, with PMI, with PEPFAR, and UNICEF is key in the country. But as part of the strategy, we believe also that we cannot stick only to tackle one of the 3 diseases, just for a reason of efficiency and equity. First, maybe you don't know that UNITAID has in its active portfolio around $500 million focusing on children's health in terms of diagnostic, in terms of treatment for HIV, TB, and malaria, and we are very proud of this, because it's not because we love the children, it's because there is a need for the children to access to better services and technology and medication. And this is nothing, it's a broken system and market, and we need to take care of this. Innovation is just not about technology. I just want to mention again, it's also the lesson learned from the scientists and the implementers from Senegal, from chemoprophylaxis, for example, that we push all together 5 years ago. And now it's in the region, it has shown drastic change in terms of mortality of children, which is one piece. I mean, the less you are sick, the better you are. And we are very pleased to see the Global Fund and others and the countries to put money and make it happen. And next step will be ITPI, prevention for infants. And we will do this with Gavi because we believe that we also need to have this articulation with the programs and to build a response. Coming back to your point in terms of how we manage to do something more focused on access to the test, to identify, to make sure that we get children that are really severe access of pneumonia through the measurement of oxygen is because, again, first, we believe that we cannot just take care of malaria. When the children come, it may come 1 out of 5 because of malaria, but the rest. So to build a response, to be serious about how we can support the community approach, but also what we call the first responder, we can call it whatever we like, primary health care. We need to make sure that these people can be, one, supported. So it's just the first line, but also what is the second line, how this work together. So it's a question of system, but from the point of view of what is the need of the patient. And I think that the transformation is also there. The question of system is very important. I think the question of what are the real needs of the people, the children, but how we can help also the community and the worker is very key. Technology can help. It's not the only solution, but technology can help. So for question of equity, but for question of more efficiencies, we have managed, and we hope that is the beginning, and we have the support of the board to do more. So I hope that what we announced today will be followed by other intervention. But just to make an illustration, we are very proud also to have make a move in terms of test and treat cervical cancer among women, not only the women who are living with HIV, which has 4 times more risk to develop a cancer with the co-infection of HPV, but for all the women in need. And that's the same kind of thinking that to do for the 3 disease is something very important, but it's not enough. And we need to use the lesson learned and the community response and the country to build something more ambitious for the more money, more help for the money, whatever it's international or domestic, which is our motto.
Thank you. When you will announce your initiative?
Well, just after this panel, my colleague Katarina, and so it will be
it will be just said. Today.
Just
okay.
Today, 43 million, 9 countries, pulse oximeter, the beginning of something that hope that will be big. I can announce it's a real something new that we will launch a new initiative in terms of oxygen in 1 month. So it's again building things. It will be small for beginning with oxygen, but yes, we are building not a systematic response because we are not working alone, but we want to contribute to some kind of broader consideration on what needs to be done.
Okay, I think that the point here is important when we look at what Michel Sidibé, also the Minister of Health of Mali, said just at the previous session, that innovation is also something people need to put on the agenda.
Innovation everywhere, including also the west part of Africa. For many reasons, we know it's not always easy part of the world to work, but we believe that we also need transformation there. And again, it's also to realize the kind of task shifting we can help with the technology. Cervical cancer is a beautiful example. The idea is not to push the technology, is to think about how even the people themselves, with example of the self-test for HIV, for example, but it can be done for different topics, how people, the community, the first responder, with the right tool can do a lot better, and also it increases the credibility of the system and the effectiveness of the response. So again, technology, access to medicine, make it affordable is very important. It's not enough, but it can trigger, I think, a very good response, a global response that helps the people.
Thank you. Now we go to the global financing facility with Leslie. Leslie, you are working in 36 countries already. I remember when I was at the beginning on the board where we were just having, I think, 5 countries to test it. Now you are at 36 countries.
That's right.
This is very important. And the work is to strengthen the health system for women and children. Now, you have a very important tool, investment case, and this is at the heart of your model. It seems to me that it is important to show that these countries are all, if they look at their data, put pneumonia also as a leading cause of death. How you use it to support the countries? Because now that they have done their investment case and they have shown that this is my problem, do you support them in their real priorities, or how it is working? What is your way to work at the global financing facility?
Great. Well, thank you for the question, Honorable Minister. And really, it's a pleasure to be here with all of you. The quick answer is that yes, indeed, the RMN-CAHN, the Reproductive, Maternal, Newborn, Child, and Adolescent Health and Nutrition Investment Cases at country level, do address pneumonia. But I thought perhaps it might be useful to back up and just describe a little bit of the model for the Global Financing Facility, since it remains not a 3-minute elevator pitch when you explain it. The GFF does support low and lower middle income countries to accelerate progress for women and children and adolescents. And it's strengthening both the financing and the health systems, ultimately for universal health coverage as a goal. And we do this by supporting government-led multi-stakeholder platforms, country platforms. These are almost always or usually platforms that already exist in a country. And the idea is that these are government-led, country-led. They bring the various stakeholders together around these issues. And those stakeholders need to include CSOs, private sector of agencies, financiers, representatives of academia, and so the UN technical at the country level. The idea is that this country platform generates the key priorities within the health plan that these nations have. But we're looking for the key priority issues that can be moved, that the needle can be moved, and that are funded through domestic resources, through the World Bank, IDA, plus the Global Financing Facility grants, and then, of course, with all the partners at the country level. The foundation of the Global Financing Facility is indeed country ownership and leadership. And actually, for me, today has been incredibly gratifying, because it seems to me that throughout the day, we have talked about the key issues that at the Global Financing Facility we really stress and incorporate. Things like equity, things like multisectorality, and of course, government ownership. The government is in the lead. The platforms play the role of developing these investment cases and then overseeing the implementation, and along with the development of the investment cases, of course, a results framework, because we need to monitor how the implementation of these cases goes forward. So I asked colleagues at the GFF a couple of weeks ago to take a look at the initial 16 completed investment cases. So these are the 16 countries that represent those countries furthest along in the GFF process. And when we looked, 13 of the 16 have either they are prioritizing addressing childhood pneumonia in the plans, in the investment case, or they are tracking at least one or more indicators. So this was actually very gratifying to see. I thought it would be useful to give you some examples of what I'm talking about. So, for example, in Cameroon, pneumonia prevention, integrated management, and treatment for newborns and children under 5 are prioritized as a part of, in their case, a recently revised investment case. And that's probably an important point to make. These investment cases are not static, and we anticipate that they will be reviewed and updated and adjusted as needed at country level. In Guinea, the investment case is also being revised right now, and it's building on a very recently approved national RMN-CAH plan strategy. And their pneumonia prevention and treatment, it's going to rise up as a key issue. In DRC, the government is working with the Global Financing Facility and the World Bank to improve knowledge around the diagnosis and treatment of children who present with possible acute respiratory infections, pneumonia, through performance-based financing platforms. And this is another key tool that we use. These platforms incentivize healthcare providers and facilities to achieve specific performance criteria, including metrics of service quality. Pediatric antibiotics are included in the list of essential drugs in the DRC project and plan. And they're procured through the platforms, through these RBF platforms, and treatment is complying with the national protocols. And finally, as an example, in Afghanistan, pneumonia treatment is included in a basic package of health services supported by a project co-financed by the bank and the GFF. So these are just a few examples of how it plays out in the investment cases and in the projects that are supported by the GFF resources. But overall, the goal, of course, is to strengthen health systems in GFF-supported countries to ensure that women, children, and adolescents are getting the best that they can, ending preventable deaths and accessing the care they need. I just wanted to reflect the background paper for the forum notes that childhood pneumonia, how we're doing with childhood pneumonia, is essentially a litmus test of how health systems are functioning and how universal health coverage is moving forward. And to me, that was a really nice way to think about it, as a litmus test. And I think that applies very well to the Global Financing Facility, our approach as well. So as a country-driven partnership model, I think all of us in this room, one of our responsibilities is to ensure that as countries are making these decisions and are prioritizing their priorities, that they have the evidence and information that they need to make those to prioritize the health services. And again, it lines up with exactly what you have been talking about, Madam, that we need to make sure that the information and data are available and that we collectively are making the decisions about how to prioritize which issues we are focused on. So I'll stop there, but I look forward to more discussion.
If I listen to you, and if we look at the world we had before,
yeah.
A country doing its own invested case can decide that they would like to be supported for mother and child. They want to be supported on primary health care.
Exactly.
And this will be funded by the GFF?
Absolutely. So the investment case is a pie. Our resources are a pie, just like that wheel. And of course, the Global Financing Facility money to an individual country is a small, small piece of that pie. The domestic resources are there, the World Bank project, and then all the financiers, Global Fund, Gavi, and all of the other partners at the table who are contributing. So this is a good place to emphasize that the critical need to align and harmonize our financing in support of those priorities would mean that if a country had prioritized childhood pneumonia reduction and prevention, then we as financiers and partners, including the government, need to come around and support through our various resources that work. Absolutely.
Very good. Last year, this is a question for all of you. You had we know that 12 international health agencies, I don't know if you're also part of that, released a global action plan and wanted to have more collaboration, alignment to the international health efforts. This is also something we are promoting for a long time, alignment, coordination. Pneumonia has always followed through the crack of international development assistance. It is maybe why children are continuing to die. We have a good record because it is decreasing, but it is still there. What are tangible ways your organizations, each of you, can work more effectively together to close those gaps, especially for better diagnostic, treatment, prevention, everything you want, but you need to work together. We have now 1 minute. I will give 30 seconds to each of you, and we will have 1 minute more, but I think they will agree because we started later. But we will not push more of that, but 30 seconds. I start by you. We continue like this because you have not spoken for a long time. So I want you to start.
Sure. Thank you very much. I think Gavi is extremely committed to the Global Action Plan, but we also want to recognize and to point out that it must be collaboration with a purpose. And it must be collaboration that is also timed. Sometimes there is, when we talk about the Global Action Plan and when we talk about collaboration in general, we think about a grand entrance of a bride that has got to be fully prepared and dressed up. But it doesn't have to be that way always. If Global Fund and Gavi are able to get moving and others can catch up, it is important that we don't always stop if a purpose of getting connected and moving is started. So get started, keep the momentum. We don't have to have all 12 moving at the same time. We can sequence those who come out first. Let's move on the priorities where we converge.
But you have always to speak to each other for people to know when you are starting something, they can come.
Indeed.
Leslie?
Yeah, I think we are starting to do better at communicating among ourselves at the global level. And we see, I think all of us, we're very dedicated to this need to better align. But to me, it's got to happen at the country level. And so I think the responsibility is to enable that dialogue to happen at the country level and the alignment to happen there. And that may mean devolving responsibility, resources from the global to country level in a way that we haven't yet done. So I think there's need for innovation and creativity about, and not just the words on the paper, about alignment.
Thank you. Philippe?
So if there is a will, there is a way. I think that first, we need to recognize that this discussion between institutions are important, but it's not what we want to do. What we want to do is to focus on how we can change things. And we have many examples, so as a 30 seconds, I cannot go into the details, but we are doing more and more. I think the specific contribution we can push as UNITED for the benefit of all the community is also generating evidence. You were talking to that and say how to share the lesson is to produce evidence. So when we introduce an intervention, we spend around 50% of in operational research, in producing evidence to feed recommendation, but also to share the country, not the tool, but how to use the tool, what kind of impact we can look at. To make it short, I think that, and my colleague will go on that later, but in terms of respiratory infection, I think, as you mentioned, I think it's a good indicator of the quality of the primary health care. So if we can also think the gap into very specific intervention that collectively we can organize with the country and measure, I think that's the best thing that we can do for this global action plan. And I think it's something that we share together. So I hope it's not just a discussion between organizations, but it's really something that we can achieve all together.
Thank you. Last word from the Global Fund.
I like the collaboration with purpose and how that happens both at the country level and how we link that to a global movement. And I agree too that prioritization at country level in terms of the priorities is extremely important, not just across all the primary health care, and being very evidence driven in terms of where we need to have results and adding accountability to do that. And I think also it's when you take a path together, it's also looking where some of the particular quick wins are. I mean, for us, for instance, if we can finance, if countries and others can finance amoxicillin, we can really step up what we're doing at community level. And so those quick wins that bring us to small steps, and then the larger steps in terms of what we're doing at country level in terms of evidence based on the prioritization and the accountability, and tying that to, I think, from what should come from this forum is a global movement to say enough's enough, and what we saw in terms of that progress and those curves flattening out, that's just unacceptable, that we dedicate ourselves to really bending those curves back to saving lives.
We need to act now. I think it is a word everybody was saying since the morning, and look at coordination. If we look at global level partners, coordination, alignment, accountability, but also really country ownership, because all this will work if countries themselves are able to say, this is what we want, these are our priorities, and we need also to monitor what we are doing. I would like just to thank you all. Thank you, the panelists, but also ask you if you can have a round of applause for them. Thank you.
Thank you, Minister. Thank you, panelists. Has anybody misplaced reading glasses by Moleskine? Transparent? Does anybody want use spare? Okay, I'll keep them here just in case. Well, we're approaching the end of the first day. I know you're tired, but this is important and interesting. You're now going to hear how several organizations with very different mandates are joining forces to protect the most vulnerable children from infectious diseases, and of course, including pneumonia. This is a two-pronged session. First, you'll hear from Save the Children and GSK. They'll have this particular setup. This is called an unmoderated conversation. The topic is their 7-year partnership. And then following, Unidate will take the stage to tell us more about the new partnership with PATH and Alima, which spans new countries. So please I call to the stage Claire Hitchcock from JSK and Janti Sorrentino from Save the Children. Thank you, welcome.
Thank you all. This is my friend Claire and I are going to have what we call a fireside chat. So I would ask you all to pretend there's a fireplace burning in the background, but we're also mindful that we are between you and an exciting announcement soon, as well as the reception. Yes. So we're going to have hopefully a smooth flowing conversation. And then see where that takes us. Maybe just to kick us off, Claire, can you talk a little bit about what we call the 360-degree nature of our partnership?
Yeah, well, good evening, everybody, and I'm really thrilled to be here because this summit is the culmination of a huge amount of work, particularly to really bring pneumonia to the forefront. And I've been working at GSK for nearly 18 years now, leading on our global health programs, and recently took over as head of the partnership. And what we do at GSK in this, what we believe is a very unique partnership, is to take this 360-degree approach, which is very holistic in helping to save children's lives. And it ranges from investing in health workers and health system strengthening, supporting humanitarian response, using GSK science and innovation to bring new ideas to the partnership. And this is underpinned by our employee engagement program as well. We have over 100,000 employees, and they contribute to the partnership not only through fundraising, but also their skills and their expertise too. So it's really something that as a company we can all get behind. And whilst our focus as a company is on addressing infectious diseases, we do know that pneumonia is something that can be prevented. And so that's why I'm really excited about this summit, because I think this is now giving us an opportunity to work and advocate together on something that is very specific.
Great.
So, Janti, I've said a lot about what GSK does, and I think what we love about working with Save the Children is because you also have a very wide reach and experts in your organisation. And do you think that our partnership is different?
I would certainly say so. It's very different from some of the other partnerships that we have. What I always loved about it is that we started off with a common and joint ambition, right? And we all treasure what we measure, it was said before, and we've committed jointly to really ambitious goals. Some of that is about programmatic work at a country level with funding, but we've also said we want to save 1 million children's lives. And we've made other sort of goals around policy and advocacy change. And that has served us, that dashboard has served us for the past 7 years, I think, in a very different way. We talked about the volunteering. We have staff from GSK who spend 6 to 9 months with us, really adding value to the organization in areas not just in health, but also in HR or marketing or finance. And then when they go back to GSK, I'm assuming they'll be better leaders because of the invaluable experience that they've had. I would also say, though, and product development clearly is fantastic, and we've seen some real tangible examples around chlorhexidine where we've really amplified our programs. It's also a partnership where I think both of us realize, without making it this too much of a hallelujah story, it's also sometimes really hard work. We don't always agree. Save the Children sometimes wants to say things about pricing of vaccines, for instance, certain things that you don't always like us saying, right? So, and then we really have to understand each other and have really good communication. But because the relationships we've built are so widespread and so long-standing, there is a sense of trust. I think we've always managed to overcome some of these hurdles.
I agree, and I think tensions are good in partnerships because they really do help to drive things forward. And I think in that case, we were supported by our passionate colleagues in Save the Children to make pneumonia a focus. And in particular, we've made a real breakthrough in Nigeria where we're using, where pneumonia is actually our entry point for an integrated program, which will take place in, what is taking place in Lagos and in Jigawa. And what we're really excited about in doing this together is that our partnership has acted as a catalyst, bringing others in, including the government, including academics, including civil society. And so, we've built on all the learnings that we've had in other programs and said this is where we want to start. And again, what makes it different is that we've invested resources in what we called the inception phase, which was really kind of looking, well, what are the needs? And working against those very clearly identified needs that are kind of academically proven.
Mm. And I think that's a good example in Nigeria. I think what makes the partnership great for us is that we've in most cases we start off with almost with a blank sheet of paper, and then we dive in, not just the two of us, and we bring in others. So the partnership allows us to convene other partners, academic institutions, local government, of course, other peer organizations, sometimes other private sector partners, other institutional funders, like we did in Kenya, and small catalytic interventions can then sometimes lead to much bigger things. And it is that freedom and creativity in the beginning with a bigger prize in mind, I think that makes the partnership really special for us.
It does. And I think for you as a senior leader in Save the Children, how do you use that to advocate and kind of bring other partnerships with the private sector?
It helps us massively. It gives us credibility. It allows us to reach out to other private sector partners who think, well, that's interesting. We want to have something, something like that. It also helps us reach out to other of our more traditional institutional funders who like that we work in this, public-private sort of partnership. It certainly also helps locally in country where both of us then have a presence and we can actually bring others to the table. So I think in many more almost intangible ways, it also helps bring others at the table. So, Claire, for you, what is the one thing that you think most people would not know about this partnership?
Well, one of the things that I'm really proud of in the partnership, and I think this really comes back to the skills that my colleagues have in the organisation, is that we've had a number of procurement specialists come and work for Save the Children. And what they've done is done a whole assessment on the procurement processes for Save the Children. And as a result, have helped to save your organisation £7 million. And that is not insignificant, because that does mean that those resources can be used elsewhere. And as you say, the other thing is that they come back to the company, not only a huge sense of satisfaction, but also encouraging us to be much more careful about our resources as well. Not to be profligate in a big, private sector company.
Very good. Very good. I think I would say what I'm very proud. There's many things I think that that we can be proud of in this organization, in this partnership. I would certainly call out the emergency health unit. It's an idea that was conceived a number of years ago. GSK was one of the first, if not the first, I think, partner to really support us, help us also create that concept of how do we make sure that when an emergency happens, either sudden onset or sometimes protracted crisis, a cholera outbreak in Yemen, Ebola outbreak in DRC, etc., that we are ready to go instantly with the right materials, the right people, a trained team, the right supplies, all done, ready to be rolled out within 48 hours. And GSK's support in that, not only, yes, funding and underwriting of the risk, but also your technical advice to make sure that we got the right things and the right profiles of people and the right training ready to go, I think has made an enormous difference. And that is now, I think we now have 7 teams that we can stand up within 48 hours across the world, and we've worked in the most difficult of places, really doing immediate life-saving work on the ground.
Yeah. I mean, we're working together for impact, and that I think that makes a huge difference. That we've got a very clear purpose and clear goals. We've got a framework within the partnership which allows us to evolve things and change and have the grown-up discussions when we need to. And I think at the end of it, and I think this is why these kind of fora are so important, is that we get the chance to hear firsthand what the issues are and how we as a company will be able to contribute.
Great. And it's also a good reminder, I think, for all of us, and we were talking earlier, right, that it's not just about us doing a great partnership and doing more of it, but also how do we make sure we get even more people on board to fill in some of the gaps where neither one of us can actually do it, but we see the opportunity arise.
Yeah, because what struck me is that between us, we're very well connected to everybody here, from the countries to the multilateral organisations, and I'm really looking forward to be able to doing more together, and with other partners.
That's right. Great.
Thank you.
Thank you very much.
Thank you very much. And now there's time for the spotlight announcement. Please come to the stage.
Good afternoon, everyone. My name is Katerina Galuzzo. I'm the technical manager at Unitaid, working on malaria and fever. As part of Unitaid's current strategy, we started to think about how we can build on our malaria portfolio and have greater impact on reducing childhood mortality. That's when we realized what we needed to do was to start talking about how we can better manage febrile illness and start thinking more about integrated approaches. We had to think about what could Unitaid do to drive innovations for managing fever in low resource settings, and how and where could we have the most impact with our investments. Through extensive partner engagement, consultations with countries and communities, and working out the funding landscape, we learned that there were some new tools available, but they weren't being used. Pulse oximeters are recommended for use in IMCI, but they're rarely available. A reason for their limited access and for their availability was that while they were available, they weren't adapted for use in children in low resource settings. So they weren't rugged enough and they weren't suitable for the use case we needed them for. These tools have now recently come available. These tools can detect oxygen levels and provide important information to health workers, signaling when a child is severely ill and urgently needs care. We've been working closely over the last 6 months with our partners at PATH and ALIMA to develop projects that will pilot the use of pulse oximeters at primary healthcare. The aim of these projects is to demonstrate that these tools will be scaled up, and by making them more available, will have impact on reducing child mortality and saving children's lives. So with that, today we'd like to announce that we've recently signed these 2 grants with PATH and ALIMA, and we are getting ready to start implementing these grants this year. We also want to acknowledge that these grants are hopefully mark the first of these types of investments for Unitaid in the future to come. These grants are an investment of over $40 million. We'll be working across 9 countries in Africa and Asia, and we hope that they will provide the framework and generate the evidence needed for wider and global scale-up. We are delighted to be partnering with both PATH and ALIMA on these projects, and we also want to acknowledge the many partners that have been integral to getting these projects off the ground, including UNICEF, WHO, USAID, countries, communities, and the Gates Foundation. So with that now, I'll hand over to Mike Ruffo from PATH to talk about the TIMSHI project.
Hi, everybody. I'm Mike Ruffo from PATH. I'm the director of the Tools for Integrated Management of Childhood Illness project, or TIMSI, or TIMCHI, some say. And so if you're not familiar with PATH, PATH's goal is to accelerate health equity so all people and communities can thrive. We do that by taking ideas and transforming them into sustainable solutions to improve health outcomes. And we do that through partnerships. So that's why I'm very excited to be here with all of you and on stage with Unitaid and ALIMA to talk about this important initiative that PATH is a part of to improve access to tools to better diagnose children with severe disease. So our project fits squarely within that diagnosis piece of the pneumonia wheel. And as you all know, when a child has pneumonia, it's critical that they have access to a healthcare worker that can effectively diagnose and treat or refer them. That diagnosis, though, as you heard earlier, can be challenging. But there are tools like pulse oximetry that can help those healthcare workers make those diagnoses. But there's barriers to access to those tools in a lot of low and middle income countries. And those barriers include affordability, appropriateness, supply chains, maintenance, and even understanding how to best operationalize them. That's why PATH, with funding from Unitaid, and in partnership with the Swiss Tropical and Public Health Institute and the Ministries of Health in India, Kenya, Myanmar, Senegal, and Tanzania, and a number of other partners working on this TIMSI project. And so the goal of the project is to increase access to appropriate and affordable tools to better diagnose severe disease in children. We're going to do that through action, evidence, and innovation. So action, we're going to equip healthcare workers in primary healthcare facilities in 360 primary healthcare facilities across our 5 project countries. Evidence, we're going to generate missing and important evidence on feasibility, cost effectiveness, and health impact. And then innovation, we're going to work with partners to accelerate development of next generation devices that measure multiple signs of illness to further strengthen healthcare workers' ability to diagnose severe disease and strengthen healthcare systems. So the impact we're trying to achieve through that is over 10 years, increase the coverage of these tools in our focus countries to 60% in the primary healthcare facilities. And by expanding access and collecting data, we want to generate demand, increase donor engagement, provide incentives for manufacturers to innovate in this space, and incentives for countries to adopt these tools. So that's, in summary, a very brief summary of our project. I'm very excited to make progress in this area in partnership with Unitaid and with Swiss TPH and the Ministries of Health and all of our other partners, and in close collaboration with all of you and with ALIMA. So with that, I hand it over to you.
Good afternoon, everyone. I'm Marine Vignon, the Air Project Manager at ALIMA, the Alliance for International Medical Action, based in Dakar, Senegal. Placing the patient at the heart of our strategic vision, ALIMA always works in partnership with technical organizations and international research institutes. We use this model because we are convinced that we are stronger together. This is why we are happy to work alongside PATH, Unitaid, and our partner for this promising and innovating project, which was built in consortium with Soltis, Terre des Hommes, and INSERM. Today, less than 3% of research takes place in Africa. But in fact, this is where more research is needed the most. Each year, in West Africa, respiratory distress, including pneumonia, is among the leading causes of childhood death. We hope to show that by improving the detection of severely ill children with hypoxemia using a screening tool, we will contribute to reduce child mortality. This is why we have created the AIR project. The AIR project is a large-scale pilot project which is currently being implemented in 4 countries in West Africa by Alima and our partners, in Mali, Guinea, Burkina Faso, and Niger. Our teams will deploy the pulse oximeter in more than 200 primary health centers, in partnership with Ministry of Health and with the aim of scaling up at national and regional level. The goal? Save lives and improve the care of children by giving health workers a simple tool which can help quickly identify children suffering from severe disease. We believe that this pulse oximeter is a small, simple, reliable, practical tool indispensable at a primary healthcare level. Along with our partners, we hope that it's an impact for today, tomorrow, and the future. Thank you.
So we just want to say thank you to listening to the announcement. We hope you're as excited as we are about this news. And if you have any questions for Mike, Maureen, or myself over the next 2 days, please feel free to reach out to us. Thank you.
Well, thank you. And thank you to all of afternoon and morning speakers. This has been a pretty intense first day. I have great news, at least for those on social media. We are trending on Twitter, so tomorrow we need to do it again. We're doing it with Stop Pneumonia. Perhaps we can try with the next one. Anyhow, 2 bits of information and you can leave for the day. This evening, 6:30 p.m., so in 45 minutes, there is a reception that Gabby and La Caixa Foundation are hosting. It's called Power of Prevention. The reception will highlight their vaccine partnership in the Bosque Inundado, the flooded forest. In case you haven't had time probably to walk around the building, it's an amazing piece of the Amazonian rainforest just down there when you exit. I wouldn't miss it for anything. Also, for those returning home later today, home being temporarily the Hotel Barcelona Princess, there will be a shuttle bus that will take you there, and tomorrow morning back here so that we can start promptly at 8:30. If you want to catch that bus, please ask at the reception desk or our volunteers. We look forward to seeing you tomorrow for day 2 of our Global Forum on Childhood Pneumonia. Thank you very much. Bona nit, buenas noches, good evening.